Kita tuh sekarang di sana di videonya
has been documented by several studies that these things are important and there is a good correlation. Now, how to approach a patient, how to approach history taking? We should always encourage the patient to give history, except in cases where the patient is a child, where you should ask the mother or ask the close relative if the patient is too sick. It is relevant to the case examination, patient examination. Patient gets a different type of confidence. He opens out, he is able to narrate himself better. And in case the language is a barrier, then should take the help of the interpreter. History should not be taken in a very hurried way or in a crowded order. There is a big room, 15 people are sitting and you are taking history. You will never be able to do a good job. At times, it becomes important to ask. So history is quite a lot an expression of the individual and your ability, how much you are able to extract out of him. I already emphasized about the importance of the interpretation. Symptoms will depend on whether you are dealing with a valvular disease, congenital disease, a rhythm disorder, or you are dealing with a coronary artery disease. Comorbidities, coexisting illnesses can modify the history. should always obtain history in a systemic way, and I will be laying down how you should approach. Should take the present history, past history, history of the family. If you are suspecting a coronary artery disease, history of the risk factors, the treatment, the procedures. History should be precise. It should be informative, and you should take the history in a relevant way to make a good diagnosis. Accurate history depends on the way you approach and certainly on the patient's background. Now, there can be specific pointers. The moment you see the patient, you can get an idea. If you are dealing with a patient below the age of 5 years, most likely you are dealing with a congenital heart disease, either cyanotic or acyanotic. If you see any extra cardiac features, as Dr. Palajani was telling, you look at, you see features of Marfan's or Noonan's. Infective endocarditis, arrhythmias, or CCF. Others can be, you have to take history to know what we are dealing with, whether patient has a rheumatic fever, rheumatic heart disease, any hypertension, any drug history. Now, when we look at primary cardiac symptom, and sir already gave you idea about some of the symptoms, there are 6 primary cardiac symptoms: dyspnea, chest discomfort, palpitations, edema, syncope, and cyanosis. Let's deal with them one by one. At times you will realize, and when you grow more and more in the field, that obtaining the history of dyspnea many times is extremely difficult. The expression of a given patient may be completely different from the second patient. What is dyspnea? It is abnormal, uncomfortable sensation of one's own breathing. And different patients will express it differently. Somebody will say that I get a catch in my breath. Other person will take, there is a shortness on breath. Third person will say I have a labored breathing. And again here, what is the expression in the local language? That's how the patient will complain. The dyspnea is supposed to be due to activation of mechanical and chemoreceptors in lung, heart, and pulmonary arteries. And there can be multiple causes of dyspnea. A dyspnea can be due to heart disease, it can be due to lung disease, it can be due to severe anemia, it can be due to metabolic disorders, particularly acidosis, uremia, or it can be due to anxiety. So dyspnea doesn't mean that you are dealing with a cardiac disease, and that's how you have to take the history in a much specific and precise way. When you see dyspnea as a complaint, you have to know about the duration, what is the class, relieving factors, associated factors, character, whether it is exertional induced. And sir did mention some of the types. It can be orthopnea, PND. There are other varieties like trachopnea, when you get breathless on lying on one side, seen in various lung disorders. You can have dyspnea, which is there on a standing, platypnea, orthodexia syndrome, and bendopnea. Now, PND and orthopnea, sir did talk. Let me tell you, PND and orthopnea often coexist. The common cause of orthopnea also is a left heart failure, but it is important to know that orthopnea is dyspnea on lying down, which gets better when the patient sits up or you raise the upper part of the body. Orthopnea can occur in various disorders, commonest being left heart failure, but orthopnea can also occur with massive pleural effusions, can occur with pericardial effusion, can occur with massive ascites. So they should not be confused that they are synonyms. Obstructive sleep apnea can give rise to orthopnea. And many times in patients of heart failure, there can be combination of central and obstructive dyspnea. Bendopnea, sir did mention about the bendopnea. And this is a sign of advanced heart failure, not only of heart failure. And there is an excellent paper in JSCC heart failure where it has described the hemodynamics of these patients. These are the patients where there is a pre-existing high pulmonary wedge pressure and low cardiac output. And when they bend, there is mediation via the reflexes and the pulmonary wedge pressure further increases. This you are already aware, the New York Heart Association classification or American Heart Association classification. And this is for 4 symptoms: fatigue, palpitations, dyspnea, and angina. American Heart Association has modified the NYHA classification. In Canadian Heart Association classification, as sir mentioned, is for angina. There are also other classifications, Goldman's functional class, 6 minutes walk test, which is more objective. So in the exam, you will be many times asked and you should be aware of that. Now, this is again a common question asked: how do you differentiate the dyspnea is coming from the lungs or from the heart? And let me tell you, at times it can be extremely difficult. But important to know that cardiac dyspnea is a specific scale. It will come at a specific scale, a specific speed. Like patient will tell you that when I'm climbing the bridge in Mumbai, it's very common for people to go catch the train. They will climb the bridge, they will become out of breath. And the moment they stop, it goes away. Whereas the pulmonary dyspnea, it does not have this type of pattern. It is gradual, it can be seasonal. And of course, there can be acute increase in both acute decompensated heart failure in cardiac and acute decompensation with bronchial asthma. Chest pain is another symptom. And again, I think meticulous attention to quality, location, radiation, triggers is extremely important. Probability of disease entity in a given patient. Now, there can be different type of chest pains. The chest pain can be ischemic, what we call as angina. There can be chest pain, which can be aortic pain. And it is extremely, Dr. Palajani touched on it. Aortic pain is very classic of dissection and other aortic disorders. It is maximal at the onset, tearing mostly at the back, whereas the pain of myocardial infarction or pain of acute coronary syndromes is usually not maximal at the onset. It becomes maximal in next 10-15 minutes. There can be pericardial pain, which increases with inspiration. Pleural pain increases with inspiration. And of course, other causes of pain like GI conditions, cholecystitis. All meticulous details about where the pain is. And most of the times, if you will ask the patient, do you get pain in the chest? Patient will say, no, I don't get pain in the chest. Different patients may complain of pain at sorry, the slide went off quickly. So it can be retrosternal, it can be radiated to the arm. There can be various permutation and combinations. Acute coronary syndromes, Dr. Palajani already touched, so I will miss it. Palpitations is another cardiac symptom, and it is abnormal, uncomfortable awareness of one's heartbeat. Again, the expressions can be different. Somebody will say there is a fluttering in my heart. Somebody will say that is skipping. Somebody will say pounding. Assess the history. What is the duration? What is the regularity? What is the rate, onset? Are there any triggers? Those which are regular, rapid, pounding sensations in the neck usually suggest AV nodal reentry. Sudden, fast, rapid, unrelated, lasting for a few minutes can be SVT. And palpitations which are exertional or palpitations which are there on lying down many times may be related to volume overloading. Palpitations on lying down sometimes is a manifestation of anxiety. The anxiety also can give rise to palpitations. Syncope is another cardiac symptom. which is an extremely important symptom to know. And syncope is defined as transient loss of consciousness due to transient global reduction in cerebral blood flow, rapid onset, short duration, and there is a spontaneous recovery. You should know all the points to differentiate it from epilepsy. It is again quite commonly asked, and because of the time, I won't be able to touch that. So syncope and epilepsy differentiation is important. An abrupt cessation of cerebral blood flow for more than 10 seconds and blood pressure. So there are two elements in syncope. The cardiac output decreases, systemic vascular resistance decreases, and there can be sometimes an element of arrhythmia, brady or tachy. So we should try and assess in the history whether there has been a hemodynamic component or not. Fatigue is another symptom which may denote a cardiac disease. It's very non-specific symptom. And again, differently patient will say, I get tired, and again, expressing in their local language. It's a common symptom, non-specific symptom. But if fatigue is present in patients known to having a cardiac disease, like ischemic heart disease or LVOT or RVOT obstruction, this is a sign which is of advanced nature. And this indicates that when the patient is exerting, he is unable to increase the cardiac output further, and that's why he is getting fatigued. It can also occur in patients with severe left main disease, severe left ventricular dysfunction, severe pulmonary hypertension. So fatigue is an important symptom. At times it can be non-specific. It's important to know. Now there can be cardiac disease manifesting through other systems. Hemoptysis, cough. We commonly see patients of heart disease coming with hemoptysis, and hemoptysis can be due to pulmonary congestion, recurrent URI, pulmonary infarct, bronchopulmonary collateral rupture, abdominal symptoms because of heart failure, and impaired brain function because of imbalance of the electrolytes. So these are the manifestations of heart failure, but the symptoms are manifesting through other systems. Symptoms related to complications. A patient may have AF, he will come to you with palpitation. A patient of valve disease may not be complaining of any valve symptoms, but may come with fever because he has developed infective endocarditis. And a patient of heart disease may first present to you with congestive cardiac failure. Now, when you have assessed the history, there are 4 components which you should keep in mind. What is the etiology? What is the anatomy or the pathological structural lesion? What is the physiological disturbance, and what is the functional class? Like we say in the exam, tell rheumatic heart disease, mitral stenosis, mitral regurgitation, pulmonary hypertension, and VIH class 2 with or without atrial fibrillation. So you should come out with all the components. And etiological diagnosis, either you can be dealing with the rheumatic heart disease, congenital heart disease, lumped together now as a structural, atherosclerotic coronary artery disease, systemic hypertension, myocardial disease, pulmonary embolism, vascular disease. So you should talk about the etiology, physiology, whether the patient has CHF or not, whether there are any arrhythmias and atrial fibrillation being common, and we are able to usually make it out clinically. Conduction abnormalities, bradyarrhythmias can be diagnosed clinically. And the format of clinical examination should be a systematic one. Look at the general appearance, whether there is cyanosis or no cyanosis, blood pressure, pulse, respiration, examination for CCF, then inspection, palpation, percussion, auscultation, and looking at other systems. And we will be talking to you about each and every. Now, suppose you look at this patient, right from the general examination, you can see there is a syndactyly and a polydactyly. And this type of thing is common in patients who have a single atrium, Ellis-Van Creveld syndrome. And if you see that patient has a cyanosis, you are dealing with the cyanotic heart disease. So a systemic approach to history taking and then going through a programmed approach about the examination can help you. So thank you very much. And I hope I have added to what sir told, and that should be our approach.
I think both lectures were excellent and all of you were nicely those. And if you have any points, because next lecture is of slightly different nature. If you have any doubts in this, what is presented, please it can be more interactive also. And then we have some time. Anybody has any doubts or questions in this, what is presented? Obviously, it can't be totally covering everything, but most important aspects, most of the touch. If you have anything, you can, there's some mics which are being circulated, right? They'll be happy to answer. Just to add something new which has come up, whenever there is a guidelines type of articles come, all of you should go through in detail. The chest pain, ACCHA guidelines have come on chest pain in October 2021. So all of you, I request all of you to go through that, and they've added some new interesting things. The how chest pain in females are slightly different, and females I feel always are special. So it is a dimension is added in it. And some of the new things which come up of dyspnea and acute MI ACS guidelines, all that is okay. But they're particularly covered only on chest pain. That are, I think you can go through. Many things are already told, but some of the new particular things are like which are relevant. Many of the times we keep telling atypical chest pain. They've clarified on it. There's nothing like chest pain, cardiac, non-cardiac, and typical angina could be there, not typical chest pain. Some of the things are clarified in that. You can go through that article. Like that, anything which is practically relevant to our day-to-day practice and history taking comes, I think all of you should give more importance. And then anybody has?
I think all of you should go through Braunwald's textbook of medicine, the latest one, cardiology. How to, as he said, how to diagnose a classical pain of angina or myocardial infarction. He has actually given several points on negative predictability value and the positive predictability value. In that, he has given 2 points, like pain on both the shoulders, pain at the back, pain in the center of the chest, pain on walking. So various points are given, and then the ratios are given. So I think all of you should read that. Maybe some examiner who really goes through him, like what he has gone through, may ask you a question. What are the points on which you will predict that there is an anginal pain and a non-anginal pain? So this new kind of a guideline on diagnosing an ischemic pain or anginal pain has been published. So I think if you go through the latest edition of Braunwald's book, textbook of cardiology, the whole chart is given. I got it on my, but because of the paucity of time, I didn't show it to you.
I think today we are blessed with one of the pioneers like Palajani sir, Satyavan Sharma has given you very good insight about the history taking. And most of, as an examiner, I knew that in the long case, your face decides. And how you tell the history, how do you narrate your history to the examiner? History taking is art, but presenting history to the examiner is also very important. So you have to edit certain points. At the end of the long summary of the history, the examiner will ask you to summarize the points. So that time also you should be prepared, because 40 minutes you will be given for case examination. So that time you should write down your points, the relevant points. Same thing is the negative history. If a person is 65 years and you are telling there is no history of the childhood, that is something not relevant. So you have to, unless you know the diagnosis, you drive the examiner to that way. So you should know what is important, negative history relevant to that case. Then it makes very interesting, and then you can drive the examiner towards your examinations and everything.
Any of you to ask 1 or 2 questions so that we also think that we are listening to the lecture seriously. Otherwise, we might feel that we are skeptical. No questions? Very clear?
Excuse me.
Yeah, please.
What's the difference between syncope and TIA?
Difference between syncope and TIA.
The transient ischemic attacks, usually in syncope, there will be a history that for temporarily the person has lost the loss of tone and has fallen down and has become unconscious, and then has rapidly gained the consciousness. Whereas in transient ischemic attack, there may be dizziness, there may be weakness, there may be blackness in front of the eye, but the history of fall will not be there. History of loss of posture will not be. Thank you.
Sir, excuse me, sir. Sir, how do we take history to differentiate whether it's a dyspnea on exertion or fatigue on exertion? While taking history, how do we extract that?
As I mentioned, sometimes to differentiate between dyspnea and fatigue also may become difficult. But dyspnea is mostly a expression which will tell that the patient is becoming aware of his own breathlessness, is becoming aware of uncomfortable breathing. Whereas fatigue is whenever a person is trying to exert, he's unable to walk, unable to this thing, and sometimes both fatigue and dyspnea may coexist. A patient becomes fatigued because he is dyspneic, or a patient may become dyspneic because it's fatigued. So sometimes the distinction may be different, but dyspnea mainly refers to the uncomfortable sensation of breathing, which can be expressed as whether you are expressing it a catch in the breath or difficulty in breathing or stoppage of breathing. Whereas fatigue is mostly inability to walk, feeling weakness in the legs that I am not able to do any work. So that will be the differentiation between fatigue and dyspnea. And at times both can coexist.
I differentiate in just one and two words. When you say dyspnea, I say it is lungs. And when you say fatigue, it is to the whole body. I think in simple terms, it is like this. The symptoms are related to the lungs, you're not able to breathe. Fatigue is entire body.
That thing, when I was at least a student, what used to intrigue is when I was doing especially MD general medicine, our cardiology professor used to write unstable angina admit. Now you used to see ECG used to be normal, patients used to be okay. Then some funny reasons also used to be there in those times in the hospital. That would make you laugh. I'm just telling you this. And sometimes some political leaders used to get admitted with unstable angina, and something used to happen. So I was just worried. I was not understanding what is this unstable angina because USA. So now chronic stable angina is different. Unstable angina is different. No. So do anybody have any idea why is it called as unstable angina? What is this so unstable about it? Why did Brownwald say it? Anybody can answer this? No? You also they might ask, no, what is unstable angina? Why are you saying unstable angina? Yeah? You can answer in that mic.
Sir, change in the intensity of the pain.
So what it basically means is the definite particular pattern which was there, the patient was getting discomfort on a sequence of same work he was getting before. Suppose 100 steps he walks, or 1 flight steps he used to get angina, it used to decrease. Now suddenly, because of some process which is happening inside the coronary arteries, either the pain should increase. Increase could be with a less intensity exertion only is getting pain, or pain is happening more prolonged time, or is more severe. So it could be like in duration is lasting longer. So that means crescendo type of angina that is increasing. Other thing is even at rest also it starts getting discomfort. So the why that is labeled like that is if you don't take care, then patient could get into myocardial infarction. Post-MI also sometimes post-MI angina is there. That means myocardium is not dead. So you should be addressing that. That's the importance of becoming stable angina pattern into unstable. That's why it is labeled. And there are primary, secondary, all that I think you read in Brownwald. So that is the reason why it is said as unstable angina. Unstable angina can be with normal ECG, can be with abnormal ECG. Nowadays we have now troponin elevation. Now we say it is NSTEMI. But in those days, I used to get to think sometimes ECG is normal, unstable, sometimes. But still, the art of history taking becomes very important because everything could be normal, but patient could still have significant disease unless you talk to the patient properly, take proper history, you will miss out totally. Many times postprandial discomfort also is missed, and people think it is gas, and go home and suddenly they land in trouble. So all that is history taking is important. And how many of you read this chronic coronary syndrome? Chronic unstable angina we used to, stable angina we used to call. Now it is called as chronic coronary syndromes. Request all of you to go to that article, which shows that it is of 6 types and various things are described. So that's also could be asked in an exam. What is the latest modifications? Some of the latest things which I thought I just add up on, you can go through those, right? And now, any other, otherwise now Shiva will take you to different dimension of artificial intelligence and other things happening in cardiology now. Any doubts in these basics? As sir and madam said, expression of diagnosis is very important. So Satyendra Sharma sir showed clearly that slide. Etiological diagnosis, anatomical diagnosis, functional derangement. At least those steps, if you follow, automatically, even if the diagnosis is not right, still you'll get through. So that's simple. Otherwise, just many of you might say just mitral stenosis. That's not the full answer. So follow that pattern of expression. Some of you are good, maybe knowing all this, it could be repetition. For the sake of everybody, I think we thought we should diagnostic expression and history taking will get you through the exam actually if you do it well. Okay. Thank you. Both. Thank you.
Thanks, Srinivas. And the basic purpose of this meeting is this only, that we don't want a monologue, come here, give a lecture and go down. So it doesn't really make anything interesting. So it is the first round, it's fine. But the next round, I really want everyone to come have a dialogue rather than a monologue and express yourself. It's not your true exam, so you can utter whatever you want. Nobody is going to pull you. But yeah, get your doubts cleared if you have. And I'm sure all of you must be having a lot of doubts. Anyway, so moving on to the third topic, we Okay, so shifting gears, you must be quite surprised at how come with history taking clinical art of case presentation, we are switching over to artificial intelligence and clinical cardiology, maybe the other side of the spectrum. But as Dr. Satyavan Sharma said rightly so, that you can never separate the history taking and clinical examination from whatever may be the advances which might have happened in cardiology or anywhere else. So that is the reason purposely we brought this topic also at this juncture, thinking that, yeah, you are the generation who are going to face a lot of it, and you have to be prepared for that. Before I start, anyone here who has done any slight interest in artificial intelligence? Very nice. Okay, at least one hand is there. So, okay, for next 15 minutes, I'm going to take you through, I can't really teach you anything on artificial intelligence, but I'll just give you a sneak peek of what is happening with artificial intelligence and why is it important. Okay. So the challenges are, I'm telling you, take it in writing, that in next 5 years time, the way we are practicing, it is going to change completely. And our generation may pass off, but you people will have to face it. Okay. There is so much of medical advancements which is taking place. Patients are aware. It is well-informed patient. We get irritated saying, oh, he has Googled it and he's asking us a question. He will ask questions. So better get prepared for that. That you have to answer all the questions which are coming out of the Google. Okay. If you get irritated, you are the loser. He is not the loser. And let me tell you one thing is that AI is the last thing which is coming into medicine. AI has literally dominated every sphere of life. Wherever you go, whichever place you go, it is being dominated by AI. The flights with which you came I can tell you half of the flights are operated by the AI things rather than a manual person sitting there. So everywhere it is an AI. And unfortunately, it is a medicine which is in the last. And fortunately, cardiology is little ahead in accepting AI. You may call it artificial intelligence, you may call it assistant intelligence or whatever it is. My only point is, don't look it as your enemy. We medical fraternity have done this blunder in year 2000 when there was a millennial shift. The whole country, whole world shifted towards the computer side. And we medical people have hardly gone into that. That is the reason many of my generation still find it very difficult to operate computers and other things, because we didn't volunteer it. We didn't want to accept it. We said, oh, this is our domain and we are going to have it. So first thing is stop your resistance towards that, accept it. If you accept it, you will be the boss, you will be the leader, and you can train it, you can do it, and you will be the master in that. But if you don't, yes, trust me, 50% of you will have a really difficult to establish yourself because AI is going to take over a lot of things. So what is the all things? Sneak peek, I'm just giving you a small thing that artificial intelligence deals with machine learning, deep learning, computer vision, and different types. I'll show you a little bit of it, what all this means. What it does: automatic diagnosis, continuous remote monitoring, improved decision-making, treatment selection, precision medicine, and reduce costs. So one word about the precision medicine. The way we are practicing cardiology at this moment of time will not be practiced like this. What is happening as the whole thing has been done? We are using one size fits all. That's it. That somebody had a cardiac, had an MI, he had an infuel MI, you treat it. You had an antiol MI, you treat. These are the things, these are the 5 things, and you treat. It's not going to be like that. It will change. Okay. How it is going to change? It's called personalized, or you can call it as the personal medicine or the approach, where the genetic polygenic risk scores will be taken into the consideration, and it will be suitable considering the genetic, considering the environment, considering the risk factors, that patient can be treated or will be treated. So it is again change. What is may happen, I'll show you in my next few slides, that probably in India we're still not doing it, but in many of the countries, how patients are being treated, how the whole diagnosis is done. So what is this artificial intelligence is? Another small thing which I really wanted to tell is that I don't know about all of you, but a lot of medical fraternity thinks, oh, come on, shut up. Computer cannot do anything about it. When I'm not going to, whatever I feed, that is the only thing it is going to tell me. Partly right, partly no, wrong. Okay. Don't think that, if you are feeding wrongly in computer, so you are a smart guy and the computer is not a smart guy and it's not going to give you the answers. You're mistaken there. So artificial intelligence is a field of computer science that studies the design of intelligent agents, which takes the best feasible action in a given situation. So basically what it means is, it all goes back to 1950, whereas basically Alan Turing is the father of AI. And he's a mathematician from England, and who actually devised the first code in Second World War, which actually tried to read the code for the German missiles. That's how the England took over the Germany. So that is the first thing the word was coined, can machines think? And I'm telling you, yes, machines can think. Okay. So don't be under the a confusion that, machines can't think, only humans can think. And I don't think so. So basically, going forward, the Turing test, there is something called as a Turing. I don't know how many of you are aware of it. What is Turing test? This is again can be asked. Turing test is, suppose if I'm interacting with a human being and a computer, they are not, both of them are not visible, but if I'm not able to differentiate that who is the human and who is the machine, that means the Turing is equal to 1 for that machine. That means the machine is as good as a human being. Okay. And now majority of the equipment, a majority of the devices which are available in day-to-day practice in clinical cardiology are having a Turing test of 1. Okay. So basically it's acting humanly, thinking humanly, acting rationally, and thinking rationally. Okay. Artificial intelligence, in other words, works like this, that primarily it has got both the components. It can act like a human being, it can rationalize like a human being, and it can give you the output. Okay. So these are the few small things which I just thought to take you through, that machine learning and deep learning. These are the two words which are often used in AI. Okay. Machine learning is a part of an AI, is a part of a computer science, which basically allows a system to learn from the data, and then rather than explicit programming. So it's not like that the computer, you program it, you do a coding for 3 days, and then after that you come out with the result. It doesn't work like that. It learns from the data. The machine learning is, it learns from the data, and then it gives you the results. So the only thing what it depends is the data. So data becomes the king. If you have, and so much of billions of data, I just will take a detour here and tell you that I don't know how many of you are aware of thing. There is a program called Karya. Anyone is aware here? Okay, Karya is a one program which is done by a Bangalore-based an NGO, and it's feeding the uneducated women almost like a 30,000 rupees per training thing, which happens for 3 days. So you may be thinking, what I'm talking about this about. So basically what is happening is the government of India, all the governments and everywhere else also, they are allowing AI specifically in 3 fields: education, health, and of course the communications. So and finance, not communication, finance. So in these 3 things, what is happening is literally it will take over the whatever we are doing at this moment of time. I'll come to that, what I'm telling you. Going back to the Karya is, here this is an uneducated lady who narrates on a phone or a system in her own language, in her own vernacular language. There are hundreds of thousands of languages which are spoken in our country. Unfortunately, the US and other people are not having that language database to make the programs which can reach the every nook and corner of not only India, but all Asia and all across the world. So this data collection for the language, the billions of dollars have been spent by all the major 3 companies, Google, Microsoft, and the Apple, and who are actually investing. So this Karya is one such program which is really. So what I'm saying is, we are all educated people are bypassed by technology, and it is going down to the end user technology people who are actually at this moment benefiting it, and eventually they will start using it also. And so we have to get aware ourselves that what this AI business is. So machine learning is this is how it learns from the, basically what it does is it makes the patterns and then that is able to make the decision and predict outcomes. There are 3 types of supervised learning, unsupervised learning, and reinforcement learning. There's no point going into those details also. So deep learning is the one which is important. It is inspired by the complexity of the human brain. So like learning data and generating patterns. So this is where we get cheated. We don't understand that. So if you use a deep learning, which has got various neural networks, the way we have a neural network in our brains, we have neurons. Similarly, these neural networks have billions of nodes, which literally works like a neuron. And what they do is there are multiple layers of them. And these layers, whatever is the input data, from there they understand the pattern and they come out the outcome. Still, I may not be able to probably explain you what I meant by this. Now I'll take you to this point. Yeah. I think here the things will little bit be more clear. Traditionally, what happens is we are all like in medical research, whatever the research is happening, statistics is the base. Is a standard method to be used. So what we do is we normally propose a hypothesis. After proposing a hypothesis, we do some equations. The statistical analysis is being done, p-value, CI, confidence interval, and everything we do it. And then we try to get the outcome. So which basically what it does is give how much is what are the risk factors for the disease, what is the outcome of a new treatment. So we are tuned to think that you have a causative factor and you have a product. And that is how the medical research has been going on all these years. So cause and effect relationship has been established. So we propose a hypothesis, and that hypothesis is validated by that particular statistical analysis. So that's how we say this particular treatment is good, this is not bad, this trial is correct, this trial is not good, it is negative predictive, whatever you can call it. Okay. But AI doesn't do that way. It all requires is a data. It doesn't require a hypothesis. It can learn the non-parametric relationship between the different risk factors. It can see what are the patterns. How do we think? How do we memorize? Generally, human being memorize by the patterns. We don't have an algorithms in our brain. We have a patterns. We have a patterns, and the same pattern is again recollected, and that's how we memorize, that's how we take decisions, and that's how we become an intelligent person. So it is the patterns. The neural system, the networks also does the same thing. They have a pattern. So they read the patterns. It doesn't require hypothesis, but it can give you the outcomes. And those outcomes many times are inferior to the human outcomes, many times equal to them, and many times superior to the human outcomes. So I hope I'm a little bit able to clear that what exactly the AI, how the artificial intelligence works. So this is what AI data is driven and does not require the formulation of hypothesis. It makes predictions with high accuracy without needing to interpret the data. Its goal is to identify hidden patterns in the data and predict new data. AI is able to use very complex non-parametric models from the vast amount of data in comparison to simple parametric models requiring a suitable size data set used in the statistics. So that is where the problem comes. We think it has to be statistically correct. So when you apply statistics is a very simplified way of approaching any problem. It just sees a linear correlation between the data points and the outcome, and then it gives you the results, whereas the AI works in a different fashion. So on that behind, so I'm not here to, boast my things or whatever I did, but yeah, we did the first ever artificial intelligence based cardiovascular disease risk score, and which has been validated all across the globe. But I'll just take you to this slide only, that basically coming back to the point is that normally in cardiovascular disease risk scores, the Framingham and the Q risk, these are the Framingham is the risk score is the most accepted, the CVD risk score. But we have seen that Framingham failed in most of the things, and it failed in our country miserably, because when the randomized trials were done with this Framingham risk source or whatever the cardiovascular, whether it's a Q risk or ASCVD, all of them, the problem is the accuracies were hardly 59% or 51%. So the outcomes were not different. Whereas with AI-CVD, what we evolved over a period of in the last 4 or 5 years, the accuracy is nearly to the 81% or 85%. And when I go all abroad, all across the globe, and when I talk to our own fraternity people and tell them that AI-CVD could do this, so they generally feel that how is it possible? You are telling the same risk factors, you are telling the same thing, but how come your scores are better than it's some crap is there? So I'm trying to put you that only, that if you can read the non-parametric correlations between the different risk factors, your outcomes will be different. Now, with this background, similarly, we are working something on heart failure. Heart failure is basically, all of you must be knowing that there is a HFpEF and HFpEF also. HFpEF almost occupies the 50% of the total heart failures. But HFpEF is one unfortunate thing which most of the time cannot be diagnosed clinically. There are hardly any symptoms are there. Symptoms are there, but there are hardly any signs are there wherefrom you can really make what it's, because it's a preserved ejection fraction. And it affects the 50% of the total population, and the prognosis remains the same as the reduced ejection fraction is. So what we have tried to do is we have tried to analyze the data of these ECGs who are clinically normal, clinically non-significant, but we could break the ECG in them and then predict 10 years that who are the people who are going to develop HFpEF or who are going to develop a HFrEF. So that is one remarkable thing which we could achieve. We are going to publish it in Lancet and other things. Forget about all those things. My point is why I'm talking to you all this point is, trust me, tomorrow or after 2 years or 3 years, whenever you sit in your clinic, whenever you're sitting in your hospital, the patient is going to come to you with a diagnosis. You don't have to do a diagnosis part of it. Okay. It will be 99.9% his diagnosis will be done, because the advancement has taken so much, the wearable devices are so much. IoT is an Internet of Things. Internet of Things is that two devices can speak to each other, can communicate with each other without even switching on. So if I have one device and some device in US or in a remote area of some Nalgonda, wherever it is, two devices can communicate with each other through an IoT platform, and that will evolve. So that is the reason what is happening is that most of the people will come to you with a diagnosis. So you need to be abreast with that. You have to be prepared yourself with that, okay, you don't have to get irritated with this guy is, posing off, he's a doctor, I am the doctor. You will have to shun those qualities of us and then start dealing. So I'll show you one thing is that we think about coronary angiogram, that is our bread and butter. And this is the, sorry. Yeah. Oops. Can we run this, please? Sorry. Okay. So you can imagine this is the clarity of angiogram on 4D photon counting cardiac CT. So I don't think so when you have such a clarity on 4D photon counting CT, people are going to come for a regular coronary angiogram with an invasive coronary angiograms and other things. There is a study which is done in China, which is basically doing a facial reading. And it is predicting 5 years down the lane that who is going to get a CAD and who is not going to get a non-CAD. Okay, it is already, the trial has come, they have already published the results out of it. Similarly, the ECGs, we think it's a digital ECG. Digital ECG is a crap because most of the time the diagnosis is bullshit. But now you have AI-powered ECGs, which has been tested with a board-certified cardiologist. Board-certified cardiologists, 6 of them, their accuracy was 90%, AI accuracy was 99.7%. All those who are doing an echocardiogram, please remember that your echocardiogram, what you are trying to interpret, there is already a software available, which it is taking 8 seconds for one echo to interpret. And so in about half an hour's time, almost like 1,000 echoes can be reported precisely than what a cardiologist can do. Okay, what an MRA is doing. So AI has literally invaded every sphere of our field. My request is not to frighten you or anything, but please accept it as one more tool. Because there are the engineers, beauty of the engineers is, because I worked with a lot of Microsoft people, I worked with a lot of Google people and other things, very top guys. Fortunately for us is, they don't have that much of domain knowledge on cardiology in our subject. Similarly, we don't have too much of a knowledge on the computer side. I had to learn a lot of it. So all those youngsters, please don't be away from that. Try to imbibe, try to have a little bit of an idea, you little bit read, and your domain knowledge on this will help you to grow, and it will help you to grow yourself also. Thank you so much. Now, moving on, again, coming back to our traditional thing is the JVP, which is again a very critical thing in examination. I'll request Dr. Hiten Shah to come, please.
Yeah, please. Shivkumar, I think we are fortunate. AI will diagnose maybe, but therapeutic treatment at least is with us only. Don't worry. I don't think AI can directly treat and put stents angioplasty. At least in our lifetime, all the cardiology community is safe.
Srinivas, I'm not in debate with you.
That also will be done. That
But
also will be right.
I'm telling you.
No, I'm saying
Okay, there is a
angioplasty.
software. What they have done is because we thought that robotics are only when until unless we connect and do it. Okay. So what they have done is they have taken the 20 best operators, which included Antonio Colombo also. Okay. They have taken the 20 best operators, their methodology, and that has been captured into AI tool. And so later on, it will be included into the software, and then that will be the completing the procedure.
Hope it not happens in our lifetime. But one thing I can confidently tell is, though AI may not replace totally, but doctors who are accomplished with all these new gadgets, new AI will be better off compared to those doctors who are not aware of this. That much is certain. So I think all of you should, why he wanted to give a basic idea is, you should always have some sort of basic idea about what is new coming up in technology. And because doctors who are comfortable with this will be better off in treating, diagnosing, and dealing with day-to-day patients compared to those doctors who do not have it. At least it can help us in a lot of things. So ChatGPT, how many of you used? I don't know. If you type everything in ChatGPT, today we are having this program, what I have to talk, it tells you tuck, 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 10 points. So knowledge is freely available. The only thing is we need not ratify, mug up like when we were students. Everything is there. How to know, interpret it, how to delete is what you have to understand. But all the new things which are coming up, please be aware. How many of you use ChatGPT sitting here? Yeah. So Google has become a little old now. ChatGPT will exactly formalize and tell you how to write it. I'm supposed to present. So tomorrow I'm talking on this. What I have to suppose you type it. Instead, the speed how it comes also is too good. In less than a minute's time, it gives you full chart what you need to present and all that. That is fantastic. So like that, I think you need to be aware of what is happening and all of you become comfortable. And some of the gadgets also I thought Shivkumar would touch, but it's on the age. All this auscultation business also has now become, this technology has helped us. Right? You have stethoscopes which can directly give you ECG and the murmur comes there. Like what you call as phonocardiogram is already coming onto your iPhone, already coming on the displays on the screen. So that is definitely a help for diagnosing. And it's in the COVID times, it has been used, tested very aggressively to transmit the data somewhere also. So like knowledge, country barriers are also gone with the help of technology. The murmur, which I wish I can show it, we have started using it to put the patient, especially when you're doing a balloon mitral valvotomy or a TAVR, you put the stethoscope, record it before and after, that thing disappears. You clearly know what is the murmur like, how is it coming. We have been using it. So those some of the gadgets are very really useful things are also coming, like how ECG is captured. Now auscultation also I feel is very interesting, sir. Previously the stethoscopes were expensive. Now it become cheaper also. Siemens stethoscope also has this now.
Basically, I'm using the same stethoscope. Okay. Okay. I have it with me. And yes, I'm telling you that it's so easy. Okay. You can see it. You can see record the murmur. You can hear it later on. You can see what is the difference between the thing. And in fact, I used it the same thing for a TAVR patient. I did it before and after. So I didn't touch those things which are too basic things because they have already come into the market, I'm sure. And all those who are using ChatGPT, it is a generative AI. Okay. There again, the problems today we have is ethical issues. Those are the major challenges for us, the data. So those things, anyway, we can go on for a long. So sir will say, and then after that, I'll go to.
I can assure all of you that whatever Shiv has told you is really going to be there in the year 2050. Whatever myself and Satyavan Sharma have taught you just now, it will be relevant for your examinations. So please remember that and memorize and mug up that. Please be sure. I can understand. But Shiv, I tell you, now even the artificial intelligence fathers, like you must have read Hilton. His name is Howard Hilton, one of the father of artificial intelligence. In protest, he resigned just about a couple of months because he looked at the future and he felt that the future is going to be such that this artificial intelligence is going to control all of us. And that's where 26 countries, including UK, and I think India is also a signatory to this, that there will be restrictions on this artificial intelligence. So please don't take this for granted because artificial intelligence is going to be restricted. I hope not for medicine.
No, but you're absolutely right. That's what I was saying, ethical issues, because the AI now is facing one of the major challenges is in ethical issues, because it can create a havoc. It can create havoc not only in medicine, it can create in everywhere else. So the data can be, because there are a lot of things in that which can be misinterpreted, which can be misused, which can be abused. So that's the reason many of the governments are taking forward, and this, until unless this is sorted out, AI can be a very dangerous tool. The way the nuclear weapons are there, similarly, AI can be a bad tool. I agree.
Thank you. First of all, I must say thanks to Pailajani sir, Satyavan Sharma sir, Dr. Shiva, Dr. Srinivas sir, and Intaz for be persistence for such kind of academic activity. And after listening to the AI talk, now I'm again going back to our traditional method. And I would like to add one point. Today's era, the most successful person will be who is ready to adapt the new environment rather than fix to his own criteria. And the second important message is there should be a concept of integrated internal medicine. You know that cerebral malaria, previously the drug was only the quinine, but it has a lot of toxicity. We had lost many lives because of the cardiac toxicity. But the Chinese, their herbal medicine is artisanal, and they come up and now we can treat cerebral malaria at home also. The same thing is our charak, susruta, komarya vignam. They are having their own values. Each leaf has its medicinal value. So same thing. If you want to grow, obviously science and technology is like a work in progress. But we should not forget our roots because there should be, and now in the what being in a university hospital, we are seeing a lot of the today's era, the implants and devices are playing the role in the playing the major game in health industry. I, being an examiner, my criteria of passing the candidate is not to see the theory because everybody is well versed with on the fingertips. If person is conscious about not to harm life by doing unindicated thing, then I will clear that person because of all this technology and all. Obviously, you have to take what is relevant for your practice, but you are ready to adapt the new things. The same time, you should not forget your roots because clinical examinations, history, you will drive the persons in a specific path rather than bombarding everything on the same platform. Thank you. So the question, my topic is very important, the jugular venous pulsation. It is also, I think all of the candidates, they want, whenever they try to tell the history, they try to avoid JVP or they try to misuse that word. And it is not being, they are getting scared. कि अगर JVP बोला और कुछ फंसे तो गए. Yeah, they try to correlate and try to pass it off. So let's make it simpler. I will try to make it simpler. What is JVP? There are two forms, the jugular venous pulse and the pressure. The pulse is, it is a defined as a oscillating top of the vertical column and it reflects the right atrial pressure. So what is the JVP means? It is the windows for the right heart. It indicates the hemodynamics of the right heart circulations. And the pressure is the top of the height of the oscillating column. So see, this is the height of the oscillating column, which is a direct communications with the right atrium and the different oscillating waves, the right atrial contractions, filling, emptying, that creates a waveform and that we are counting as a JVP pulse. Now, before we start the journey, we should not forget our legends who had identified those pulse and the pressure wave. One is Sir Mackenzie. He developed the monograph and that he record the arterial and the venous pulse. And obviously, Paul Wood, all of you are not reading the Paul Wood article, then you are not fit for any of your exams because he is like a I can say his books are considered as a Bible of cardiology. and he described the book Disease of Heart and the Circulation. Eisenmenger articles, you are not going to clear the exams if you had not read the article, each line of it. And you can see the person with the mustache and the wine in his hand, the Sir Lewis, he had developed the technique of how to measure the JVP, the bedside assessment of the JVP. So we should salute those who had given us the clinical informations about the JVP. Now, what is the JVP? Usually, it carries around 70 to 80% of the circulating blood. Before yeah. Most of us should know first where the once your mind knows, then only your eyes will see. So this is how the JVP course is. It runs between the two heads of the sternocleidomastoid and from earlobe to the middle end of the clavicle, and it is into the lateral to the carotid. And usually it lies deep to the sternocleidomastoid junctions. Okay, external jugular is usually superficial. Can you make out all this landmark? So you should correlate with the human body. Okay. Now, why the internal jugular is preferred than the external? Because internal jugular has a direct connections with the right atrium, and it correlates with its hemodynamics better, whereas external jugular can be easily compressible. It has indirect connections, and when patients with heart failure and all, it can be easily compressible or disappear. Now, why right over the left internal jugular we should consider preferred? Because right is in the straight line with the right atrium. Okay, it connects directly SVC to the RA, and it less likely to be compressed by any of the three. Whereas the left has a large innominate vein, so any intracardiac mass or structure may give rise to false impression of that. And this is how the venous scores. You don't have to remember, but only remember that internal jugular runs from the earlobe to the middle end of the clavicle. Now, certain you must have seen that first of all we don't make an attempt to see the neck. Today's we just directly put the echo probe. So neck is again very important to know the vascular volume of the patient. And certain patients, I do admit, it has a low sensitivity and specificity. Even the experienced cardiologist has a 65% sensitivity and 85% specificity. But it does plays a very important role. So in a child less than 12 years, you should not make an attempt, because sometimes you may, it is difficult to obtain. But in the adult patients, if you have to see the volume, if hypovolemic, make it lie down flat. If it is very much dyspneic and the veins are anchored, you can make it angle more vertical. Okay. And how to examine? Always make a patient in a relaxed positions with the reclined positions of 45 degree, slightly head tilted and towards the left. But don't make the patient stress. Patient should be avoid of doing any Valsalva maneuver, exaggerated breathing, or any kind of a breath holding activity. The light should be come from the back and at the triangle of your sternocleidomastoid. So you can see the wave and observe the oscillating movement. And then you have to measure by putting a two horizontal scale. One is at the top of your venous column and another is at the angle of sternal angle. And you have to measure the vertical height. So this is how, and most of them, they say, okay, we auscultate the heart sound and we say which one is precede, and it is very difficult. So better to palpate the carotid and see outward movement or inward movement. And that makes life very easy. Which are the waves who's moving outward and which are having a collapsible waves. And then, and with carotid or without carotid. So you are making the slightly tinted positions, palpate the carotid, focus the light, and you can diagnose the waveforms easily. And what is the difference between the carotid and internal jugular vein? Here it is more of phasic, two phasing wave you are seeing. They are non-compress, they are compressible. They are varying with the respirations, and they with abdominal jugular reflex, they shows increasing the column height. So again, this repetition of same. So I want say that it is non-palpable, and it is easily reducible. Now, how to examine that we had discussed? You have to put a vertical scale between the two horizontal scale, and you have to measure the height, and you have to add the 5 centimeter, because the mid RA is 5 centimeter below the sternal angle. So you have to add 5 centimeter, and normal JVP should be if it is less than 4 centimeter, meaning if you add 5, it should be less than 9. And if you convert into the water, it is 1.3 centimeter of water is equal to 1 millimeter of mercury. Now, first we have to see whether the pressures are raised or not. So you are measuring the column. You have to see whether you are dealing with the raised pressure. So anything above 9 centimeter with adding 5, or only 4 centimeter without adding 5 centimeter, it is raised JVP. And which are the and you have to see whether it is non-pulsatile or pulsatile. If it is non-pulsatile with the engorged vein and raised JVP, it usually having a SVC obstruction. And what are the pulsatile but raised JVP causes? The cardiac causes are right-sided failure, any conditions with a severe PH, constrictive pericarditis, and all. Okay. So the elevated JVP, the cardiac causes are, so we are dealing with the low RV compliance, or inflow is incompetence, or a circulatory overload in the form of any fluid overload state, and others are like a SVC obstructions or COPD. And this is again, if the JVP you can't elicit it, is pulsations are sometimes goes beyond the earlobe, and the whole veins are engorged. Then you have to raise the hand, and when you have to see the angle between your sternal angle and what angle the veins are collapsing. If it is less than 4 centimeter, that means it is a normal RA pressure. If it is more, then you are dealing with a increased RA pressure. Now coming to the waveform, there are two positive waves and two descents. The visible waves are A and B, and descents are X and Y. So we will discuss each of them. But again, I would say the timing is very important with carotid. If it is precedes the carotid, it is A wave, and it is after the carotid, it is V wave. Or you can coincide with the heart sounds also. Now, what is A wave? It is the first positive deflection, and it indicates the effective RA contraction. And usually, it is dominant wave compared to V wave. But it usually precedes the upstroke of the carotid, but it follows the P wave. And the X descent is, it is a systolic through the C wave. So it is a fall in RA pressures during the early systole. So the RA is getting pulled, the tricuspid valve is pulled off, and that's why there is descent is visible. And the C wave is, again, it is the interruptions of that downward pull by the positive reflection, because there is upward bulging of the closed tricuspid valve, and that during the isovolumic contraction phase. The V wave is the end of systole and the early diastole. There is another one positive deflection, and it usually roughly synchronous with the carotid. And X descent. What is X descent? It is again a form of atrial relaxation during the atrial diastole. And the Y descent is all passive filling. The tricuspid valve is open up, and the whole passive filling of the right atrium to right ventricle is, so RA is emptying, and that give rise to a Y descent, rapid Y descent. H wave you can remember, but it is a wave for the slow motions, and it has been described in 1907, but it has no much clinical benefit. So, as a clinician, we have to see, first of all, what are the outward waves and what are the inward waves, and in the position of the patient, the leg raising, if it's not visible, you can put gentle compressions on the abdomen that we will discuss. Or patient is hypovolumic, make him euvolumic, and then assess the wave. The difference between the A and B wave, as I say, one is active contracting phase and another is passive. And one is preceding the ice wave, another is after. And usually it is A wave is taller compared to B wave. So A wave is usually normal wave, it is a prominent wave. So what are now abnormalities? The prominent A wave is seen here, the atria is contracting against the resistance. So that will give rise to a giant A wave. So in any RV inflow obstructions or any pulmonary outflow obstructions, PH or PH situations, or RV cardiomyopathy, you get a wave giant. And if the asynchronous contractions in a closed tricuspid valve, that give rise to a cannon A wave. And cannon A wave, it could be a regular or it could be a irregular. Depends on. So JVP not only helping us into the diagnosis of the volume status, but also diagnosing certain arrhythmias also. And in exam, if candidate has been given a case of mitral stenosis and he has been asked to demonstrate the JVP, and if patient is in atrial fibrillation and he said A wave is present, then he has a return ticket. It is a because A wave can't be possible. Atria is fibrillating. There is no atrial kick. So A wave is absent in atrial fibrillation. Prominent V wave. Usually they merge with the C wave, and most common CV complex prominent pulsatile wave are in a patient with tricuspid regurgitation. It could be either organic or functional, whatever. The prominent V wave, again I said, severe TR, MR, or any volume overload state. Now, absent X descent. It is again, as I said, okay, there is a CV complex. So, X descent will be absent in a patient with a tricuspid regurgitation. Now, the patients with slow, I would like to focus on the slow Y descent. The Y RA is emptying, but the RV filling is impaired. And it usually gradual in a patient with tricuspid stenosis, pericardial. So TS patient always make an attempt to see multivalvular case. You are hearing the murmur of this thing. The patient is in congested state. Always make an attempt to see observe the JVP, whether you are dealing with a slow Y descent or rapid. And rapid Y descent, again, a severe TR in a constrictive pericarditis or severe heart failure. And lastly, the word about the hepatojugular wave reflux. Here, you have again, it has been said, patient should be, if JVP is not visible, make the patient relax, abdomen should not be tight, and your periumbilical area, you have to apply a gentle pressure of 10 seconds, and you have to see the duration, the rise of the venous column. If it is more than 5 centimeter, then it is, if it is persistent or it is a sudden fall, then if it is more than 15 second, 25-second persistent, then it is abnormal. So I'll just say, so here why this happens, if RV, incipient RV compliance or RV failure, RV is not able to accept the extra load on it. So that give rise to a increased jugular velar pressures, and it will take some time to fall it. So this is how I would say these are kind of 4 response you will get in a hepatojugular reflux. One is a flat, that is a negative. Second thing is sudden rise and the fall. But the positive would be it sustained more than 4 centimeter rise and it sustained for more than 25 seconds. Now the respirations. Normally, because of the during inspiration, the JVP falls. But in Cushman signs, during inspirations, Cushman signs happens in a constrictive pericarditis where RV can't accommodate more blood. And that time during inspiration, it increases. And this is how you should differentiate cardiac tamponade versus constrictive pericarditis. You can see in cardiac tamponade, what are the triad of cardiac tamponade? The muffled heart sound, hypotension, and the raised JVP. And raised JVP, here the X descent is prominent, but the Y descent will be slow. Whereas in CP, it is a W pattern, the X and Y descent, but rapid Y descent. And they are more prominent. Okay, so constrictive pericarditis that we have discussed. So double descent, always think the wide, focus on the wide descent. If it is slow or rapid, and then you can diagnose. And in exam, you have been asked to draw a JVP. So always, whenever you are reading, just make an attempt to understand and draw it in your way. Because these are the common etiology and you should know the waveforms and always make an attempt to draw ECG below. Because examiner should know which part of systole and diastole you are drawing each waves. And this is a classical of TR, the CV complex being prominent and depends on the severity, it happens. Now, what about the congenital heart disease? Because that is also part of your syllabus and where you have to see the integrity of IAS and IBS. If septum is largely defect, then JVP is normal because both ventricular pressures are isolated. So there won't be a transmission of any wave. But if septum is intact in a patient with severe PS, there will be a reflection of large giant A wave on the JVP. The pulmonary hypertension, again, it will be a reflection of a wave, CV complex and all. In a patient with ASD, again, normally, normal isolated garden variety ASD without pH, A and B are equal, but in severe pH, all the findings of raised JVP and the CV complex and all. But JVP in VSD and PDA, it is difficult to diagnose because it doesn't carry much information. Sometimes they said, okay, as JVP has a connections with pulmonary capillary wedge pressures, can it reflect the left ventricular state? It may reflect in a patient's, it should not be taken as a direct marker, but yes, in indirect marker, it can reflect in a patient's with HEPF and all. That we had discussed. Abstinence anomaly, I think it is a same of a prominent A wave, that Himalayan P wave you can get on the ECG at that as a direct relations, indirect relations with the prognosis of the patient and how much the atrialized RA is. Now, the cyanosis with the prominent A wave, that is a very important slide because that the cyanotic heart disease, you should know this. So if septum, again, I would say that indicates the septum is intact. So you are dealing with either ASD with severe PS situations or Eisenmenger PDA where the JVP can be raised. But not in Eisenmenger VSD. VSD, large defect, the pressure equalized. So VSD, usually the JVP is normal, but ASD and PDA Eisenmenger, you may get a pH finding on the JVP. I will not go into the detail. And cyanosis with the elevated JVP, yes, in a patients with increased pulmonary blood flow, parallel circulations like a TGA, tricuspid atresia, or PPH with RV failure, you may get a RASA or adult tetralogy fellow. All of you should know our Indian author who had contributed good work on the adult tetralogy of fellow and their article you should read. And the second thing is JVP with the cyanosis with the normal JVP. That is, usually silent heart is usually a tetralogy of fellow or pulmonary AV fistula. Now, I want one of you to answer this. रिव्यू हो रहा है will make his effort. I played, taken sir few clips of JVP, so they can, what we spoke, they can identify and understand that I want to check. Okay, any questions about the JVP? It is difficult, but you practice and it takes less than a minute to examine the JVP. To make an effort, at least in your day-to-day practice, to see the neck variance and correlate with your file. Okay. नहीं. Bila masih I will, if it is run, I will have a clip in between.
I think students should feel free to express your doubts on JVP. Many of you would have doubts. I don't. I agree. If all of you say you're thorough. Madam is very passionate. She collected a lot of information. Feel free to discuss. No examiner to fail as a point. Yeah, please ask. Yeah, go ahead. Give a mic to them.
Hello, excuse me, ma'am. Ma'am, what is the difference between giant A wave and Canon wave?
Giant, Canon A wave and giant A wave means in giant A wave it is because of the pathology first of all difference, but the Canon A wave it's a flicker movement. Giant A and it has more decided, and it, because here the atria, there is a desynchrony between the atria and ventricle, and it can be regular or irregular, whereas giant wave is always being a regular. Okay, that clipping I had kept, but it is difficult to show to you. Yeah.
He'll sense it will work.
The Canon airways usually you see in a patient who's got a complete heart block. I think that's what she meant, that there will be dysynchrony. So a patient who got a complete heart block because the ventricles are beating at their own way, the atrial contraction occurs many times at the closed AV valve, and therefore there is a giant A wave. So that's what it looks like, a Canon A wave. That's what it looks like.
Actually, Canon wave and giant A wave should be separated. A wave is a pre-systolic event. Canon waves are systolic events. So that is one of the major differences. And mechanism Dr. Hetan already told. So that is what is usually expected in the exam. A wave, pre-systolic. Now, how easy it is to make out is a different thing. But on the recordings, that is what you will get.
Unfortunately, what happens nowadays when you see a patient on the bedside, nobody even unties the top button of the patient's shirt or the hospital gown to look at the neck. And the first thing that patient looks at nowadays is at the radial artery or the femoral artery pulse, whether that is available for doing a coronary angiography or not. I've seen this. And so I think the whole idea of examining a patient has changed. But I think before we do all that, we must know the basic examination, the body of the patient, the symptoms of the patient, whatever artificial intelligence, of course, it will come. There will always be a kind of a interaction, it has to be an interaction between the patient and the doctor. Until unless the patient knows that you are a doctor who is going to treat you or treat him, he will never gain a confidence. He's not going to get a confidence in the machine. He's going to get a confidence in the human. So eye-to-eye contact is the most important thing. So I don't think even artificial intelligence comes, Shiv,
the human contact is and eye-to-eye contact is not going to change. So rest assured all physicians that we are going to have our own bread and butter is not going to go in the hands of the computer scientists.
Madam, one more thing, many students we keep asking me doubt is this business of lying flat and 45 degrees and making them sit. To make them understand, it's only the way method to make the upper level prominent. You can just highlight those points regarding the position to see the JVP and how does it help?
As we had discussed, 45 degrees is always a better thing. But if patient is hypovolumic, and then make it slightly supine to elicit the JVP. And patient is having a CCF and all, so you have to make it big. You can't be lie down or even in recline. So that time you have to change the angle. So depends on the volume status, you have to change the angle. Okay.
But I want more questions, because what is happening is examiners are getting so excited and they're all telling their own experience. I would like that, only one question has come. Please ask more questions about it if you have anything. Everybody is clear about JVP? Oh, go ahead. Yeah, somebody is raising the hand. Go ahead. Then we will take an exam now.
Most of them, when we examine A waves, they tell it is where it is the kicker of impact. And A waves are higher up in the neck, like a most visible thing. Is it okay? Whatever. Understand the
What was your question?
the A wave, normally you see that it is the kicker of impact, lower part of it. And if you want to comment on B wave, then it is higher up and it is most visible thing. Not like a kicker.
No, usually A wave is more prominent than the V. Unless the patient is having a tricuspid regurgitations or anything, that time we will take over. But usually CV complex is more prominent and AFib, you can see that. So always correlate with the better timing with your carotid. And then you can take a judgment whether it is, because normally the A wave contour is bigger than the V wave.
Want to see the B wave.
Huh. No, it is two positive waves are so one is before and one is outer. And these are our outward pulsations. And the descents are inward pulsations. And you have to correlate with the carotid. That's all.
Hello. Ma'am, hello. Excuse me, ma'am.
Yeah.
Hello. Do the GVP changes with the change in angle, ma'am?
1 second. Watch the video.
Hello.
So I think there is some transmission problem. It is as they said rightly that it is as difficult as JVP. Okay. So it's
Volunteer, identify the first one and second one. What is what? Can you see in the first lady, whatever the patient, the pulsations are more of a lateral. They are a large CV complex of a severe TR, whereas they are a GVP pulsations. Whereas here, you can see the pulsations are single and it is a throbbing pulsation at the middle end of the base of the neck. They are because of the carotid aneurysm or the carotid pulsation. So you should able to differentiate whether you are dealing with a GVP or a carotid pulsation. Next. Yeah. This is very identical. Okay, I'm giving you the hint. The graph. Yeah. Can you? One person, please. Yeah. Pardon? Fine.
If you
Yes, good. And with the prominent CV complex. Yeah. Yeah. This is
TS.
what is the diagnosis?
TS. Yeah. Prominent A wave, TS.
Prominent A wave and the Y descent is
Absent.
slow.
Tricuspid stenosis, ma'am.
Yeah. But you can see the prominent X descent. It could be because of cardiac temporal. Okay. Next. Everything one flicker. And there is a very, all of you can just see on the figure, very good video recording by Dr. Paul himself for all the GV people. I have taken a few clips from the second. See. What is the diagnosis? It's just a flickering wave. One is regular, another is irregular. It's a canonade. Next. Next. Last. I agree. Here the not that much property. Here the descents are more prominent. It's a case of CP. Next. Okay. So always see the outward movement, inward movement, and the relations with the carotid, and make examinations, any examinations in a segmental approach. First, see the level, make the patients in a proper position, and check the pressures and then the waveform. Thank you.
Okay, with this, we'll take a break for 15 minutes.
I have a question.
Who's this?
Since A wave will precede carotid and V wave will precede carotid, since we are seeing in continuum, we cannot differentiate it. But we are seeing continuum, we are not palpating and we are seeing the carotid. One wave is preceding the carotid and one wave is preceding the carotid. We don't know which is which. Differentiate A wave or V wave.
And can you demonstrate on how?
Without palpation, how we do?
Heart and the murmur. You have to at least auscultate for 2 to 3 cycles. Then you can diagnose whether it is systolic event, diastolic event, and you can time the murmur. Okay.
Ma'am, can you please demonstrate on how the Gartner method is performed?
Who is that?
I don't know.
What was the question?
Repeat your question. Demonstrate on how the Gartner method is performed, how the measurements are done, which waveform is visualized, and how the hand is placed on the sternum.
I can get. So what was the question?
Okay.
Gartner method that you have to just raise the hand and you have to see what angle the veins are collapsing compared with the sternal angle, and that height you have to measure. If it is less than 3 centimeters, that means it's a normal.
Are we supposed to look at the veins in the arm, forearm, or the hand?
Wherever the veins are prominent. Okay. Yeah.
Okay, with this, we'll take a break, and within 15 minutes, we'll meet again. But as I said at the beginning, I need those names, and please give it to Linson or Mr. Vara, that whoever is volunteering for tomorrow, the long cases as well as the 2 short cases. I don't want it is to be lingering on another few minutes, half an hour. Please give it your names to them.
Yeah, welcome back. I think request all this of you to settle in your places. And we have interesting lecture coming up. This is the certain must for you to get through exam. And that is a multiple disease case. Others may come, may not come, but this definitely is there. So we requested sir to discuss on it. We're very fortunate to have him, and you'll benefit more by knowing the approach to multivalent disease. Dr. Satyavan Sharma sir will be discussing after this a brief flavor of what is happening more latest in the valor diseases and structural heart interventions. I'll cover, then we'll break for lunch. I request sir to come over.
For our after our morning session, when we discussed about the clinical history taking examination of jugular venous pressure and also about the AI, let's talk about the multivalvular disease. Multivalvular disease, from the point of view of many of you, is quite important. In the examination, many times a case of multivalvular disease is kept, and mostly kept as a long case. So it is important to understand what is expected out of the examinees in a patient with multivalvular disease. Multivalvular disease have two components. There can be many times what we use is patient is having a mixed valve lesion and patient is having a multivalvular disease. A patient may have involvement of more than one valve, it becomes a multivalvular disease. There can be involvement of mitral valve, involvement of aortic valve, which is quite common in rheumatic disease and also in certain other disorders. Tricuspid involvement is not uncommon. There can be a involvement of a single valve, and the single valve can have two lesions. There can be a stenosis and regurgitation. And many times in the exam, it is asked, what is the patient having? Is there a involvement of the mitral valve? Is there a involvement of aortic valve? Which lesion is dominant? And let's say that's what I will try and address. So combination of stenosis or regurgitant lesions on two or more valves or mixed lesions of stenosis of regurgitation on same valve is common. And usually that is what is kept in the exam. It is not uncommon to see involvement of two valves in more than 40% cases of rheumatic heart disease. Functional incompetence of the tricuspid valve is quite common as compared to the organic tricuspid valve disease. And what is also important to know is when you will see patients with multivalvular disease, when you see a patient with only one valve involvement versus two valve involvement, you will start finding that the incidence of tricuspid regurgitation increases if there is a multivalvular disease. Organic tricuspid regurgitation is not infrequent, and particularly after we started having a lot of data from echocardiography, we know that organic tricuspid regurgitation also is common. And in patients with significant mitral valve disease, the incidence of organic tricuspid valve disease is quite common. It may not be possible to clinically accurately judge all the lesions, but a fairly good idea can be made out about the presence of the lesions and about their severity. And that's what all the clinical medicine is about. We know investigations beginning from ECG, X-ray, and more importantly, echocardiography has taught us quite a lot, particularly in the field of multivalvular disease. It is important to understand that the consequences or the findings of specific combinations depend on the consequences depend on a specific combinations, whether the combination is of MSMR, ASAR, or ASMS, MSPHTR. So the consequences will depend on the specific complications and timing of the each lesion. It is possible in valvular heart disease. Both lesions may not start simultaneously. There may be a gap between the two lesions beginning. There might have been a patient where there is a history of rheumatic fever at the age of 8 to 10 years, and then again at the age of 17, 18 years. And this patient may develop one wall involvement at X time and the second wall involvement at subsequently. So the timing of each lesion also will determine the clinical picture. The loading conditions, which ventricle has got loaded, the ventricular function, the left ventricular function, the right ventricular function, and both components, systolic and diastolic. So all these factors determine the clinical presentation of the patient. It is important to know the etiology of multivalvular disease. Majority of the times in our country and from the purpose of examination, the etiology which you will see of multivalvular disease is usually rheumatic. I will put it at least in 80 to 90% of the cases, the etiology will be rheumatic. And in those patients, it will be quite common to see that there is involvement of the mitral valve, there is involvement of aortic valve to varying degree, and also the patient has developed some involvement of the tricuspid valve. It can be a functional involvement or it can be an organic involvement. Degenerative heart disease is not uncommon, and degenerative heart disease we are seeing, and particularly in Western world and even in our country, we are seeing a lot of degenerative disease. There is a lot of degenerative aortic valve stenosis which is being seen these years. And also with degenerative aortic valve disease, that there can be involvement of the mitral valve in form of a mitral annular calcification. So you can see in elderly patients, a combination of aortic stenosis with mitral incompetence. Of course, mitral incompetence in elderly can be due to other reasons. I'll come to that. So that can be another type of case which you can get in the exam. A patient in the age of 60 years or 70 years having findings of AS and findings of MR. Also, degenerative disease can be in form of myxomatous degeneration of the valve. There can be myxomatous mitral valve disease, myxomatous tricuspid valve disease. The other etiology of multivalvular involvement can be sometimes in aortoarteritis, there can be involvement of aortic valve and the mitral valve. In connective tissue disorders like Marfan's, there can be involvement of mitral valve, aortic valve, rheumatoid arthritis, SLE. These conditions also can involve, but they are less common. Infective endocarditis can involve mitral valve, aortic valve, and of course, rarely it has been known to cause even involvement of all four valves. Carcinoid disease, quite uncommon, but if you see a patient where there is an involvement of tricuspid valve and pulmonary valve, a combination of TR and PS and PR, think of carcinoid. Radiation is emerging as a, I won't use the word common, but radiation is emerging as a cause of multivalve disease, and radiation-induced mitral incompetence, radiation-induced aortic incompetence. And in those populations where there are a lot of patients of malignancy treated with radiation, we are seeing these cases. So from the point of view of the exams, the commonest etiology of multivalvular disease will be the rheumatic, not to forget the degenerative cases, and some cases of aortoarteritis or connective tissue disorder can come into. Rarely, congenital AV canal defects can have a mitral and tricuspid regurgitation. And at times, you may get a case of dilated cardiomyopathy where there is a functional mitral regurgitation and aortic regurgitation, mitral and tricuspid regurgitation because of annular dilatation, and this can mimic like a valvular heart disease. So the background of etiology is important to understand. There are a couple of important things to understand when you see a patient. They are also described in some certain textbook as rules of thumb. And one important thing is a severe lesion becomes more obvious than a mild or moderate lesion. Say, for example, there is a patient where the aortic regurgitation is severe. You will get all the signs of aortic regurgitation. And if this patient is having a mild or moderate mitral regurgitation, you may not be able to appreciate it because all the findings will be dominated by the aortic regurgitation. The proximal lesion, or what is called as an upstream lesion, tends to determine the clinical presentation. Example, a patient having mitral stenosis and aortic regurgitation, findings of MS may dominate. Distal lesions are relatively masked. Hemodynamic and clinical consequences of 2 or more lesions is not what it should be. And very interestingly, we will start thinking that if a patient is having 2 lesions, 2 and 2 should become 4. It is not always so true because there are a lot other factors which determine. A patient, for example, having a severe MR and a severe MR, we will expect that this patient should have a large amount of left ventricular volume overload. He should be very symptomatic. That cannot be true. So important to know certain rules of thumb, particularly that severe lesions are the ones which become more obvious, and proximal lesions are the ones which tend to determine the clinical picture. Many times in the exam, you might have missed a given murmur, or you might have thought the X lesion is dominant and Y lesion is dominant. And the examiners may keep asking you the questions. Do you think this patient is having this lesion also a little bit? So think over, maybe the dominant finding of other lesion has made you not realize that there was another lesion which was mild. The consequences of multivalvular disease sometimes are that there will be low flow and low gradients. A patient who is having, say, a combination of a mitral and aortic valve disease, and if both are stenotic lesions, these both lesions will produce a low cardiac output. And because of that, there can be low flow and low gradient. So you may hear the murmurs which may be less dominant, less prominent. Mixed valve lesion increases flow and gradient. Now, if there is a, say, for example, a mitral stenosis and a mitral regurgitation, the mitral regurgitation in a patient of mitral stenosis will increase the flow and the gradient. And there may be a systolic murmur and there may be a diastolic murmur which may increase with the flow. And in hemodynamics of these patients, the application of continuity equation may become difficult. Pressure half time may become invalidated. So there are multiple things which occur in multivalve disease. I'm sure in the echo talk, you will be getting more light on this. And any lesions which are upstream lesions can cause a functional mitral regurgitation or functional tricuspid regurgitation. It is not uncommon to see a patient with severe aortic regurgitation because of left ventricular volume overload. This patient may develop a mitral annular dilatation and there may be findings of mitral incompetence. A patient where there is a pulmonary hypertension, you may get a tricuspid valve incompetence. Now, there are various lesions which we encounter in clinical practice in multivalvular disease. There can be involvement of one valve and there can be varying degree of narrowing and leakage. There can be a patient with MS and MR, or there can be patient with the MR and MS. Now these terminologies and these descriptions are utilized in clinical practice, you get a case where the both findings of MS and MR are present, you will be asked which lesion is dominant, whether it is MS dominant or whether it is MR dominant. There can be a patient where there is a aortic regurgitation and aortic stenosis. And again, the question arises whether aortic stenosis is dominant or aortic regurgitation is dominant. In relation to a patient who has got an MS and MR, not only it is important in the exam from the point of view of knowing what a candidate is knowing about hemodynamics and auscultation, it also has a therapeutic bearing. A patient who has got a dominant MS and a mitral regurgitation, which is not significant, this patient can still be subjected to a balloon mitral valvotomy rather than sending him for a mitral valve replacement. So this is one of the implications of knowing the specific contribution of a given lesion. Then you can have a MS with aortic regurgitation. You can have a mixed mitral with aortic regurgitation. You can have MS, MR, AR, AS. So you can have various combinations, both valves, and you can add all stenosis regurgitation you can have. You can have the regurgitation lesion of both valves, aortic and mitral. You can have a stenotic lesion of both valves, mitral and aortic. You can have a mitral stenosis with mixed aortic valve disease. You can have a mitral stenosis with organic involvement of the tricuspid valve. Actually, at the time when I was doing my DM nearly 4 decades back, we used to see a lot of cases of triple valve involvement, all organic disease of mitral valve, aortic valve, tricuspid valve. These lesions have become less, but still seen. And functional tricuspid regurgitation of varying degree is common in almost all types of valve diseases. Now let's first come to mitral stenosis and aortic regurgitation. This is a frequently encountered lesion you will see quite commonly. And aortic regurgitation, as we know, increases the preload, and vice versa. The reduction of preload is done by mitral stenosis. And because of this, if the patient is having a tight MS, pulmonary hypertension, which is a common thing to, it will reduce the preload of the left ventricle, will reduce the cardiac output, and which in turn will reduce the peripheral signs of aortic regurgitation. So in patients of tight mitral stenosis with severe pulmonary hypertension, it is important to remember that peripheral signs of aortic regurgitation can be underestimated. So when you get such a case, it is possible that you are underestimating the aortic regurgitation, and that is what is expected from you in the examination. The examiner will keep asking, do you think how much is the AR? Is the AR significant? Can the AR be moderate? And then you start this thing. But if you know the logic behind it, in patients of mitral stenosis, particularly that mitral stenosis, which is severe with reduction in cardiac output and severe pulmonary hypertension, where preload has got reduced, you can underestimate aortic regurgitation. The other part, there can be patients of aortic regurgitation. And as we know in aortic regurgitation, you can have, if aortic regurgitation is severe, you can have a mid-diastolic murmur at the apex called as an Austin Flint murmur. Now, how to diagnose mitral stenosis in these cases? This is another question which is asked in the exam. Is the patient having mitral stenosis or this is a Austin Flint murmur? Now, how do you suspect mitral stenosis in a patient where there are findings of otherwise dominant aortic regurgitation? And if there is an atrial fibrillation, if there is a diastolic thrill, if there is an opening snap, and if there are features of pulmonary hypertension, these findings will favor associated mitral stenosis in a patient of aortic regurgitation. So it is important to know how this combination, which is common, can present, where it can be underestimated, where you can underestimate or overestimate the another lesion. Now, this is an echocardiographic example of a patient where there is a mitral stenosis and aortic incompetence. And this also brings out that there can be limitations of applying pressure half time, limitations of applying uh, continuity equation. And the important thing when you do echocardiogram in combination lesions should be you should look at the valve areas. Mitral stenosis and mitral incompetence is another combination which is common. Etiology, by and large, 95% of times, or I will say 99% of times, of a combination of mitral stenosis and mitral incompetence will be rheumatic. Rarely in these years, actually, with people living longer, I was seeing a lot of cases of mitral annular calcification. There can be patients with mitral annular calcification where there can be mitral stenosis and mitral regurgitation. But mitral annular calcification usually presents with dominant MR rather than having findings of dominant MS. But this is one of the causes it can be. And there is rarely you can have a congenital mitral stenosis, parachute mitral valve, and other variants. Now, you will be asked commonly the exam if there is a mitral stenosis findings and mitral regurgitation murmur, what you are dealing with, whether it's a OS or it's an opening or it's a third ultrasound. So you should be ready with these answers. Opening snap is usually louder. It is widely heard, widely audible, whereas third ultrasound is a low pitch sound and it is heard with the bell. Opening snap, A2OS interval opening snap is usually soon after the aortic second sound, whereas third sound is usually delayed. So these small things are asked when you see the combination lesions. How do you know this patient is having a significant MR if there is a mitral stenosis present? And these, the findings which can help in that, if you feel that there is a left ventricular type of apex in mitral stenosis, then you suspect that there is an associated MR. There is a pansystolic murmur, wide splitting of the second heart sound. And how do you suspect if the person is having mitral regurgitation? How do you, and at times, only mitral regurgitation can have a mid-diastolic murmur, flow murmur in severe mitral regurgitation. Now, if this patient is having atrial fibrillation or severe PH, think of that there is an associated mitral stenosis. So these are questions which may be of less importance in the era of echocardiography. Once you do the echo and you know these things, but this is what have been traditionally asked. It is good for a student to know these. AR with MR is another combination. A patient can be, mitral regurgitation can be, mitral regurgitation can be present due to primary etiology, or mitral regurgitation can also occur in patients of aortic regurgitation due to dilatation of the left ventricle. So this is again a very, you will be asked, suppose there is a patient where there is a severe aortic regurgitation and this person is having some findings of mitral regurg. You may be asked if this mitral regurgitation, functional mitral regurgitation, or this mitral regurgitation is of the same etiology. Is it of rheumatic etiology? In severe aortic regurgitation, if aortic regurgitation is long-standing, there can occur LV dilatation, there can occur LV dysfunction, LV failure, and then can give rise to mitral regurgitation. And both the lesions, aortic regurg and mitral regurg, can further enhance the left ventricular dilatation and left ventricular failure. There can be load on pulmonary circulation, and also PH and TR can develop in these patients. So in patients of aortic regurgitation, association of MR is not uncommon, and MR can also secondarily occur in these patients because of the functional deterioration of the left ventricle. Presence of atrial fibrillation in patients of aortic regurgitation is usually a pointer to mitral regurgitation being of rheumatic etiology. Aortic stenosis and aortic regurgitation is another quite a common lesion to be seen. Again, the questions are usually the same. How, if there is a patient of aortic wall disease, how significant is aortic regurgitation? How significant is aortic stenosis? And these years in the era of TAVI, it may be important to know if there is a dominant AR or dominant aortic stenosis. If you see in a patient of severe AS, the pulse is high volume, it indicates that the patient should be having a significant amount of aortic component. Cardiomegaly in a patient of aortic stenosis will indicate that there is a significant amount of aortic regurgitation. Usually aortic stenosis will give rise to only left ventricular hypertrophy. There will not be a dilatation. So if you see in aortic stenosis that there is a cardiomegaly, diagnose that there is associated aortic regurgitation. The presence of long murmur, delayed peaking murmur, soft aortic second sound, paradoxical split, conduction to carotids favor the presence of what is called as an organic aortic stenosis in presence of aortic regurgitation. So these are the usual questions in the exam asked in these patients. Patient has got aortic regurgitation. Also, there is a systolic murmur. It will be asked whether this aortic stenosis is functional or this aortic stenosis is organic. So these, there's a small points help to differentiate. Combination of mitral stenosis and aortic stenosis, we don't see these years, this combination that commonly. Of course, the picture of rheumatic fever has changed considerably over the years, and we don't see the type of cases which we used to see 3 or 4 decades back. But still, we do see some cases where there can be combination of rheumatic mitral stenosis and rheumatic aortic stenosis. This diagnosis can be tricky. To diagnose both lesions clinically can be tricky. There can be low volume pulse and lower systolic blood pressure can occur in either lesion if it is tight and severe. AS can be missed or underestimated in those patients where there is a severe pulmonary hypertension. So if you get such a case, and if the examiner is hinting you whether this patient is having associated AS also, or in a patient of AS, examiner is hinting you whether there can be associated MS, you should understand the nuances, that these are the lesions where combination can be missed on clinical assessment. And these can be the reasons. So you can underestimate or miss aortic stenosis in a patient of mitral stenosis if there is a severe PH which has caused low cardiac output. On the other hand, mitral stenosis can be missed in severe AS. Severe AS softens first heart sound. It elevates the left ventricular and diastolic pressure, and because of the elevation of the left ventricular and diastolic pressure, LV-LA gradient reduces. LV-LA gradient reduces and the length of the mid-diastolic murmur reduces. So you can miss or underestimate mitral stenosis. Presence of atrial fibrillation, severe pulmonary hypertension are usually clues to diagnosis of MS in patients of AS. So you should keep these small points in mind, which can be of great importance in diagnosing these. And these are also important. Many times, even after echo and X-ray and ECG, unless your clinical thought process is clear, you can miss these lesions. As I was mentioning, these days with longevity in the society and people living longer, there is a combination of aortic stenosis with mitral regurgitation seen not uncommonly. And this is mostly of degenerative etiology, commonly seen in elderly Western world. Even in our country, we are seeing cases. Long-standing aortic stenosis causes increased afterload, left ventricular hypertrophy, dilatation, dysfunction, and secondary MR with leaflet tethering and annular dilatation. So severe aortic stenosis can give rise to MR only because of severe AS. There can be other reasons of MR in elderly. Along with AS, there can be mitral annular calcification with mitral regurgitation, or there can be ischemic heart disease associated with papillary muscle dysfunction, or there can be a patient where there was a degenerative mitral valve prolapse who has come up to this stage. So the combination of AS and MR, not uncommon, poses a challenge in diagnosis. And also when you will look at the therapeutics, even these are the patients where TAVR can be challenging, patients of aortic stenosis with mitral annular calcification, or these are the ones where there may be requirement of a double valve therapeutics. This is an example of a patient. If you see, there is a severe degenerative calcific aortic stenosis on the middle panel, and this patient also has got some prolapse of the posterior mitral leaflet, with the result that there is a mitral incompetence and there is a severe aortic stenosis. So this can be a combination of aortic stenosis with mitral regurgitation, which is not uncommon in elderly. Now coming to the tricuspid disease, tricuspid valve disease. Now, as I mentioned at the beginning, that there can be two ways in which the tricuspid valve can be involved. Involvement of the tricuspid valve is quite common in mitral valve disease, with the mechanism of causing pulmonary venous hypertension, pulmonary arterial hypertension, and they get tricuspid regurgitation, what we call as a secondary tricuspid regurgitation. More is the involvement of the two. If you have a single valve disease, double valve disease, chances of functional tricuspid regurgitation increase. We should not forget that organic tricuspid valve disease also is not uncommon. We still do see patients with organic tricuspid valve disease. And tricuspid valve disease in a patient with a involvement of the mitral valve or aortic valve, there can be certain symptoms of tricuspid valve disease, which can be pointers to think of tricuspid valve disease. And whether it is a tricuspid valve disease secondary to the left heart disease or primary, the symptoms which can be a pointer to tricuspid valve disease can be, these patients can have symptoms because of certain reasons. There can be reduced cardiac output. And because of the reduced cardiac output, patients may complain of fatigue, effort intolerance. These patients develop right atrial hypertension. And because of that, there can be hepatic congestion, pain in the right hypochondrium, congestion of GI congestion, and the symptoms of nausea, vomiting, loss of weight. They can develop fluid retention. There can be pedal edema. There can be ascites. And ascites and pedal edema in patients who are having an organic tricuspid valve disease can be multifactorial. And at times that can be the clue that a patient, despite giving diuretics, is having some ascites, GI symptoms. And these symptoms, the ascites and pedal edema, can be due to various mechanisms: increased venous hypertension, in decreased renal perfusion, hypoalbuminemia. They can develop malabsorption syndrome, protein losing enteropathy, cirrhosis of the liver. So if you see such symptoms, there should not be any hesitation in the exam bringing out a tricuspid valve lesion, tricuspid regurgitation, or tricuspid stenosis. That will depend on the physical examination. But you must think of that this patient is having a tricuspid disease. Functional or primary, you can discuss. Now, physical findings of tricuspid regurgitation and the stenosis. Again, the tricuspid regurgitation manifests with features secondary to chronic venous congestion, pedal edema, abdominal wall edema, ascites, the jugular venous pressure, and as Ethan was telling, these are the patients where there can be large B wave, there can be A wave if there is pulmonary hypertension, there will be a rapid wide descent in patients with tricuspid regurgitation, slow wide descent in tricuspid stenosis. But of course, slow wide descent is a little difficult clinical finding to appreciate. But what is easy in the venous pressure examination is to find a large V wave and a rapid wide descent. Those are usually easily appreciable. Signs secondary to venous pulsations. Sometimes the venous pulsations may be so strong, venous pressure may be so high that you can have a earlobe sign, pulsations of the venous, pulsations of the earlobe, proptosis. There can be icterus, peripheral cyanosis, cardiac cachexia can develop, pulsatile liver can develop. And the murmur of tricuspid regurgitation is a murmur which is usually heard on the left lower sternal border. The murmur increases with inspiration. Tricuspid stenosis murmur increases on inspiration. It's a superficial mid-diastolic murmur, and the increase in inspiration is also called as a Carvalho's sign. So functional tricuspid incompetence, organic tricuspid incompetence are not at all uncommon. And when you are looking at a context of a multivalvular disease, you will find patients having some degree of tricuspid valve involvement and signs of tricuspid valve involvement. Whereas seeing the combination of MS, AS, TS, that is quite uncommon these years because we don't see that virulent rheumatic fever and rheumatic heart disease. But organic tricuspid regurgitation is not uncommon. And what is the clinical importance of the lesion severity assessment? Of course, apart from you're passing the exam or you're going for the exam, there is a practical importance. The assessment of the lesion helps in clinical decision making. And there used to be a time when even echocardiography was not available when I was doing my residency in CMC Vellore. We used to auscultate patients. Patient has tight MS, some aortic regurgitation, and we used to clear the patients or close mitral valvotomy just based on clinical assessment. So if you are looking at a patient combination of MS and AR, if AR is mild or moderate, this patient, if valve morphology is suitable, you can still send this patient for a balloon mitral valvotomy. If you have a combination of a patient with a MS and MR and aortic valve disease is mild or moderate, you can send this patient only for mitral valve replacement, can follow up the aortic valve lesion. If there is a severe disease of both the valves, aortic and mitral, that definitely requires a double valve replacement. And one should not forget organic involvement of the tricuspid valve is important. Its incidence increases with number of valve lesions. And if there is a significant organic tricuspid regurgitation, patient is going for surgery, the tricuspid valve should be tackled at that time. I think I'll close here and I'll be happy to answer any questions if there are still some time left. Yeah.
Morning, sir. How to clinically differentiate between organic and functional TR, sir?
Good question. Hey, between organic and functional tricuspid regurgitation, the most important thing is when we are talking of a functional tricuspid regurgitation, there is a associated left heart disease. Means there is a patient where there is a mitral stenosis or mitral incompetence, and this patient has pulmonary hypertension. Now, when patients are having pulmonary hypertension, we tend to diagnose that this patient is having a functional tricuspid regurgitation. I'm talking mainly just clinical. When you get a patient where there are findings of mitral stenosis or mitral regurgitation or combination, not much of pulmonary hypertension, and you still start having a findings of tricuspid regurgitation, you clinically suspect that this patient may be having a organic tricuspid valve disease. And of course, the finer distinction of functional and organic will come when we do the echocardiogram. We look at presence, absence of pH, and also look at the morphology of the tricuspid valve, where the disease process is there in tricuspid valve, thickening and other thing. But strictly speaking, clinically, organic tricuspid regurgitation should be suspected if there is a tricuspid regurgitation murmur in absence of pulmonary hypertension.
This exam also, they keep asking assessment of severity of each of these valve lesions. If any of you have any doubts on that aspect also, you can clarify it from sir. Combinations of lesion, the way this one. And as explained by Professor Devan Sharma, another thing is a non-pan murmur. The murmur in functional tricuspid regurgitation may not be pan-systolic murmur. It may be finishing earlier. So non-pan murmur without evidence of pulmonary hypertension. Now you can have tricuspid regurgitation with a organic disease or functional disease both. But once you are having a sustained parasternal impulse, that will go in the favor of a secondary pulmonary arterial hypertension induced tricuspid regurgitation. But if there is no second axon valve, if there is a non-pan murmur, generally primary murmurs are not that loud, but yes, you can have murmur. And thirdly, you are having a hyperkinetic type. And you are differentiating between the secondary or the primary, then you should think of this.
I'll take it.
Sir, do we need to grade dominant lesion in exam?
Can you tell again?
Sir, if in a mixed lesion, if there is one lesion is dominant, that is severe, and other lesions are also present, should we grade them mild to moderate, or like how to do that?
Well, usually, traditionally, they have been, the possibly a good term is whether it is significant or it is not significant. But yes, loosely it can be graded as mild or moderate. So the importance becomes is, whether you are having a MS and MR, whether this MR is dominant or whether this MS is dominant. Now, again, dominant, significant, these are the terminologies which are usually used. So for the other lesion to say whether this lesion is grade 1, grade 2, I don't think it's that much important.
And I would say, like in exams, you will be asked to tell the complete diagnosis. This is justified. And then you said, why severe MS? Then people start saying only the murmur. Always take the history, positive physical findings into the account, rather than directly jump into they are your weapon to justify. So please don't neglect that. Now my questions to all of you, if both lesions, like patient with AS and MS, both are pliable, non-calcified AS, rheumatic, and a pliable mitral valve, and you are subjected for valvotomy, young patient, you don't want to, because valve replacement is again, you are introducing disease by anticoagulation. So although rheumatic VAV, the results are suboptimal, which lesion you will operate first?
AS we will operate.
First, you will say, I will do transeptal first because the heparin issue, if anything goes wrong, it will be, and then, and if you hand over to surgeon, then The surgeon, we don't require anything in order because it's from ways, whatever is comfort zone, because it's already patient is on sick.
The good thing about multivalent disease is at least you can make out one correctly also, still you get out of the exam. But the prominent lesions, generally you don't miss, whichever is significant. Even the associated insignificant lesions, you are not able to diagnose also, still it is okay. But you should not miss out very prominent things. Otherwise, the examiner will come to know that you have been fed with the diagnosis. So that's important to correlate what findings you have.
Now, yes, combined lesions do present a problem. Now, the important thing there is don't try to make stenosis as regurgitant lesions at mitral valve both see. Which one? They can coexist. But make either of them as dominant. And we are talking only about the mitral valvular involvement. There is no aortic valve involvement. So if there is MS and MR, if you have volume overload, MR is severe, then MS will be mild or moderate. At aortic valve, both can be severe. Now the problem here is that, suppose there is aortic regurgitation, and then you have to talk whether AS is severe or not, or significant or not. Unfortunately, the indicators to say that AS is significant are all those which make it severe as well. For example, if in the presence of severe AR, you are having a forceful, sustained apical impact, two possibilities, either he is in heart failure or significant AS. Now, this significant AS means severe, because only that can cause, or aortic carotid delay is also your finding. Aortic carotid delay itself is a finding of a severe AR. Or long murmur, because short murmur can be functional. If you find long murmur, again it is an indicator of a severe AR, severe AS. So, as long as you are not finding the severity indicator of the other lesion, say it is, first statement is, it is very difficult to decide in the presence of this. You are passing the exam, you are giving the examiner a chance to let you through, to tell him that both lesions, particularly for aortic valve, sir, both lesions can be severe. However, I'm not finding anything suggestive of significant AS. So I would say that it is probably not hemodynamically significant. But remember that hemodynamic significant AS, if you are able to diagnose, it indicates a severity, right?
Okay, thank you, Dr. Satyavan Sharma sir. And now it's heating up, and obviously every faculty is somehow taking out time from their busy schedules and coming here for a couple of hours, and then they are going back. So that's the reason our whole schedule may not be the same the way it's printed. The lectures will go up, and that is another reason that tomorrow there is a cyanotic heart disease early in the morning instead of being today. So now, of course, my colleague, Dr. Srinivas, will proceed with the structural heart interventions.
Before I go on to just to close this valvular heart disease, the multivalvular disease assessment discussions, generally, as Madam said, I would like to mention that each of you have your own methods. So you have various. That's the beauty of having teachers like Dwivedi sir and Sharma sir. Each of us have. So proper history analysis and probably coming on to each point before you go on to the main murmur becomes important. And once you say the MS severe means you might get prolonged MDM, but as Madam was telling, analysis take some points from history, then take some points in the general examination, and then sounds, then murmurs. That way you will get it to order, and the examiner will also understand you know the subject well. For example, suppose in the mitral aortic stenosis patient is there. The classical triad of symptoms, generally, if it is there, generally, you know, Braunwald's thing, exertional angina, syncope, and breathlessness.
then that means generally patient could have, once a AS becomes significant, it is significant AS, generally symptomatic AS. Then once you come onto the examination, some things are very hard data points. I would request all the seniors to excuse me, just I thought I would also mention. So some things like in the examination, this what mentioned in JVP and all that could be soft, but some things are very hard data. Like if you have a strong parasternal lift, then that means the patient definitely needs to have PAH. And suppose you say apex is down and out and forcefully heaving, that is a hard data. It can't change. Patient should have significant valvular disease to get cardiomegaly. Like that, there are some things which you obviously cannot miss, and you have to properly interpret and you check with your diagnosis. So, for example, if you are taking a patient of aortic stenosis, symptoms-wise, then you think of it as more significant. Then probably if you come to vital data examination, probably blood pressures could be systolic decapitation could be there. JVP may not be important unless patient goes to failure. But precardium again could be important where you could have dilatations. Other carotid pulse also is important. Slow rising pulse, that is a strong sign that patient could have severe aortic stenosis. Then you have apex beating, slow heaving apex. S4 sometimes could be non-specific in elderly, but sometimes presence could help. And other thing is in second heart sound, though it is looks very difficult to make out, but delayed A2, sometimes paradoxic, again indicates severe aortic stenosis. Then delayed peaking of the murmur also is said to be correlating with severe aortic stenosis. And probably patient going to failure only with AS again could indicate heart disease being severe. And then those are the things by which you analyze. And each of you could have history. After end of history also, examiner could have you ask you what is your history analysis suggests. You should be able to think before you go to the examiner and present your analysis of history. By and large, if patient is presenting with pedal edema or ascites at the first sign, you could think of right heart disease, which is generally not kept isolated disease, but most of the left heart things, then patient could have breathlessness or palpitations, long history, short history. These are the things which make out differences between mitral valve and aortic valve. Patient has a long standing history. Generally, it goes with mitral valve disease, and episodic palpitations, which started recently, could be indicating that patient is going to atrial fibrillation. On the other hand, if patient has only palpitations, then it could point towards more regurgitant lesions. So each of could have your analysis and be ready with some sort of mental makeup and history-wise conclusion. Sometimes if you have a combination, patient could have a combination of symptoms too. But by and large, long-standing history is generally mitral valve disease, short history, aortic valve disease, combinations could be there. And then patient has a prolonged history of palpitations, also more of regurgitant lesions like mitral regurgitation, aortic regurgitation, rather than stenotic lesions, excluding sometimes of arrhythmias, atrial fibrillation could also have palpitations. Then each of you, if you have remembrance like that for each valvular heart disease, it will help you in analyzing and answering the questions properly, rather than just going on to one particular murmur. I gave example of aortic stenosis. Like that, similarly for each of the diseases, you have 1 point from history, 1 from general exam. Okay, right, thank you. So I think I'll go to structural heart interventions. I was thinking whether to talk only only about structural heart interventions, but what I thought is relevant to before you pass the exam, rather than knowing in detail of the procedural details of all the structural heart interventions like TAVR and MitraClip, I thought examiners could ask you with what is latest happening in what are the newer trials coming up. So I thought I would cover up those, and if you're interested, you can see at the end one of the structural heart procedure like TAVR. And I'm extremely happy. Let me express my heartfelt thanks to Dr. Shiva and Pailajani sir and Satyavan Sharma for making Fax Foundation part of this extremely good. I did speak on this podium before regarding the same topic, I think sometime back. Thank you, Shiva, for making Fax Foundation part of this. I'm extremely happy and so much interest, and thanks to Intas. This slide brings best wishes from Apollo Group of Hospitals, where we are trying to network across various Apollos and try to collect some registry data, be it be like PCIs, be it be like TAVR. Combinedly, it is a great strength. But when we are analyzing combinedly about a year back, all Apollos together, we did about 19,600 PCIs. That's a huge data. TAVRs, if we're collecting, we had a 500 plus TAVR procedures done across. The problem is we don't come together, we don't make our own registry data, though we are trying an attempt, and hopefully we should come out with some positive data. It's very important for us to learn from our own things. That's why I keep on telling about it. And back to structural heart disease interventions, as we understand with increasing age, the increasing incidence of aortic stenosis happens, and probably more aged populations are there in our country now. So these numbers will keep increasing. Be it aortic stenosis or same thing could happen with even mitral regurgitation as the aging population increases. Then that's how the increase in interest in these elderly patients with aortic stenosis and mitral regurgitation is coming. Though India, I think KGMC, Dwivedi sir, and GPJ, a lot of other centers, GV Pant, we had strong experience in mitral stenosis. Now this regurgitant disease also is being tackled percutaneously. We should be all thankful to Dr. Martin Leon, who initially in 2001 coined this term of structural heart disease interventions. Basically, we know various types of interventional therapies happen in cath lab, but non-vascular interventions like coronary and peripheral leaving, it's all being termed as structural heart disease interventions. So increasing elderly people, it's becoming more common, is further likely to increase in future. So what is structural heart disease intervention? Initially, it was termed as the waste basket, including all other things like apart from the valvular interventions and some things like non-valvular appendage occlusions, all that are also put in this. But it becomes very important for you when you become practice to understand. The beauty of these procedures which brought is, again, it brought all the modalities together, be it be imaging, be it be echo, and be it be interventions in cath lab. Again, unless you have a proper heart team, you can't become perfect in this. And it will also help you to also have a good clinical knowledge. And that's the importance of becoming perfect in this, I think. So this emphasizes the teamwork and image interpretation between the various modalities. It also needs to have some high-end stuff like probably hybrid cath lab if you have, and then probably could change to OTs if required occasionally, though it is less commonly available. So the expertise, the proper infrastructure, the heart team, everything goes a long way in doing the structural heart interventions in a good way in multidisciplinary collaboration. We should all be thankful to this Alan Krieger. I think many of you must be knowing. He's pioneered this TAVR, the first in 2012. And he was a very sick patient, was not suitable for anything. It was transeptal puncture done, but 15 minutes later, the patient was improving like this. That's how we got confidence. Never we thought that this becomes more prominent. And but once this was done, TAVR revolution has happened. So it leads to a lot of new iterations, new devices which has come. Why? Because this is almost like an angioplasty. There's a balloon expandable valve, stent-like valve, expands like a balloon, easy to implant and behaves like a surgical processes. And that's how it picked up so well, because it gives clear-cut results. What is TAVR in 2023? We didn't predict before. So there is so much of advancements happened because newer technologies, so many new valves have come in. And the other beauty of this is many of them are done in a minimalistic approach. No general anesthesia, local anesthesia in patients are discharged in 1 to 2 days. So, but how this come is, it was studied very well through partner trials. It was studied in high-risk patients, moderate-risk patients. Now it is actually more than 15,000 patients. What we need to keep in mind is a proper heart team where all the people are involved, keeping the patient's interest as the top priority. What is good for the patients, we need to do it. With that idea, initial trials were done, and the TAVR 30-day mortality significantly came down. Now it is comparable to surgery. In fact, better to surgery. I will take you through. That's how the numbers are significantly going up. Initially, surgeons said, cardiologists tell all this, it may not be true, but this Mac is also one of the cardiac surgeon who's participated in this trial along with Martin Leon. So this partner 1, 2 initial trials were in surgically unfit patients. Anyway, you do TAVR, but later on we went on to moderate risk patients. Now the latest partner 3 was in low risk patients. Why low risk patients is important is most of these patients of aortic stenosis are low risk, and our surgeons do a good job. So you have to be extremely careful, do good results, as good results as surgeon. That's how it was being very carefully planned.
So what is this partner 3 trial? If it's important for you, it could be asked in the exams, especially in the Vivas afternoon. At least I did ask a lot of students because I was also personally interested, and what is the latest things happening could be asked. But one thing, once you have come to this stage in discussion, even the clinical case means you are already through, I think you'll be passed. But this could be asked in the post lunch Vivas also. It's important just for you to take a note of this trial. Partner 3 trial is 1:1 randomized fashion, 1,000 in each group, were randomized to surgery versus TAVR. And then they were followed up initially for a year, then 3 years, then 5 years. So what could have happened? The beauty of it is, you see, surprisingly, this is the death, stroke, and the rehospitalization. What was the aim was to prove it is as good as surgery. This is a primary endpoint which is being studied. This TAVR performed better than surgery, in fact. That's how I think it got into a lot of good reputation, and more centers were adopting it. If you see the total stroke rehospitalization deaths were less. Even the other thing which is dreadful worried is strokes. That also was significantly less. Disabling strokes were less. In any subgroup analysis, in any type of patient, LV dysfunction, NIHA class, and all these age groups, still TAVR performed better. Obviously, some of these secondary endpoints like bleeding, length of hospitalization stay, if you such things which are more common with surgery you take, then you could anyway TAVR scores over surgery. So in whatever types of complications you see, TAVR had a lesser of problems. So if you see partner 3 trial, it came out, what it said is, surgery is better only in few aspects, like left bundle branch block incidents, mild PVRs are still a problem with our TAVR. That's where I think surgery could score better. Initially, we thought valve gradients are better with surgery, but again, latest trial showed it is the other way around. Both are equal in this pacemaker requirements, and then coronary obstruction, vascular complications like. But see, the TAVR advantage is better is mortality is less, strokes are less, which are very worrisome to patients, rehospitalizations, kidney injury, new onset atrial fibrillation, all that is significantly less. So if anybody has to take a decision, think these are the advantages, these are little advantages, anybody would say which therapy is better? Everybody would prefer TAVR. Obviously, patients also want a less invasive therapy. That's how the partner 3 trial got published in the New England Journal of Medicine, after which it became very popular. Numbers increased significantly. At least this recently, last week in TCT, Martin Leon presented the 5-year data of partner 3 trial, which is again showed the advantages of TAVR, though it's slightly narrowing, but still maintained till 5 years with surgery. The valve size did not matter. All the 3 valve sizes were okay. And deaths, though still less, but the curves are slightly coming together with surgery. CV deaths were less. Another interesting analysis which they did during COVID. During COVID times, then probably TAVR deaths increased compared to surgery. The reasons exactly were predictive. But after COVID, again, then TAVR patients did well. All strokes, though the curves are nearing, still advantage is persisting till 5 years. All the additional endpoints. The only problem which we have is the valve thrombosis, which is slightly more than surgery. But if you see the details of the stroke, and not much. But valve thrombosis, most of them were again reversible with increasing in anticoagulation. That's a positive thing. But rest of it, most of it again was good. Gradients, initially we thought surgery could be better. But again, TAVR gradients were less. Hemodynamics, valve areas were also not significantly different. And the patient's survival rates are also good. The valvular regurgitation is the only thing, I think, little percentage of mild PVRs are remaining. With coughed valves and sheath valves, that is also becoming less. Quality of life, durability, 5 years, no significant difference. So 5-year data concluded saying that both TAVR and surgery are equally good, but for this problem of valve thrombosis, which could be slightly more in TAVR, but again, could be treated. And it concluded saying that both are equally good therapies. Then this got published in recent NEJM again. So at the same time, Evolute Medtronic group was doing the trials with other self-expandable valves. This also showed TAVR advantages furthermore compared to balloon-expandable valves. Strokes are less and problems are less, clinically implying that these patients were not significantly different, and then TAVR, in fact, slightly performed better. This is a valve hemodynamics. Supravalvular valves again had a better valve areas. Compared to surgery, these people had less gradients and more valve areas. 4-year data was again presented in recent TCT, showed that the benefits persisted. Then the TAVR patients had better valve hemodynamics. And then all-cause mortality, disabling strokes are also significantly less with TAVR. That's how I think clinical care pathways, the same day, all this, and then clinical outcomes which improved, made this TAVR to stay together. So in this 2023, what we watch now seeing is we are not bothered which patient is high risk or low risk for surgery. Who does poorly with surgery or not, we're not interested. What we are interested in, who will do well with TAVR. If the patient has any contraindications to TAVR, that's what we need to check. If it's nothing, then we offer TAVR even in low risk patients. That's about aortic valve therapy. I'll touch briefly about 5 minutes and 2 minutes on mitral and tricuspid. Tricuspid valve therapies, again, as you see, mitral valve is a difficult structure compared to aortic. It has various other anatomical targets which could lead to this trouble. So we need to have answers to so many problems which could happen. But predominantly primary degenerative mitral regurgitation or secondary mitral regurgitation. That's what broadly you can divide mitrals into two. Then prognostic importance, we know that if patients has severe mitral regurgitation, they survive are less common. They die faster. So the primary degenerative valve disease, low risk surgical valve repair was done. If it is high risk, when the patients were not suitable, MitraClip was being tried. Then here, if a patient functional ones, generally only repairs or rings were being done in low risk, and high risk, we were only giving medical therapy before, a decade before. Now, even in other places, we have been trying MitraClip. Initially, MITRA-FR trial was done, and then co-op trial was also done. One came positive, one came negative. Co-op trial came positive, showing that there is significant reduction in hospitalizations and problems with all-cause mortality is also significantly less. Then MR severity obviously will decrease when you do a therapy. But MITRA-FR other trial which came showed that it could be no difference between the both. When you try to see, there's advantage reduction with the clip, unlike this. When they try to analyze what could be the cause, here, which patient subsets you are selecting is very important. If you take a patient subgroup in which had a significant mitral regurgitation with not too bad LVs, their patients are likely to improve. This, I think this slide shows you that. MR severity is more 3 to 4 plus, and then LV size function is not too bad. Those subsets, I think, will benefit by MitraClip procedure. And on the other hand, if you have a too hugely dilated cardiomyopathy type of LVs with mild, moderate MRs, they won't benefit. That was taken in the FFR trial. And if a properly taken selected patients, now MitraClip is also replacing the procedure and gradually going now into the era of surgery where patients who are being appropriately selected patients with skilled operators, and then now probably this will move further into surgically suitable patients also. But where are we going further? Are we staying only with MitraClip? This is anyway moving, but a lot of new research is happening with the different type of Pascal type of clips, which are slightly better compared to the existing MitraClip, are also being planned. Annuloplasty reduction procedures, it's not the forum, we don't have time to discuss in this, but a lot of new research opportunities are going on in discussing and deciding the reductions of various types of other procedures here. So there are new research is going on, but gradually I feel where it is going, rather than annuloplasty reduction procedures and all, which are new caudal procedures which are being tried, gradually it is now going towards more of a replacement even in mitral valve. So initially all repair procedures were done. Now I think instead of competing, then probably now what we gradually coming on, this replacement can address all these leaflets, annulus, all these cardiac ventricle problems together. That's how this more research is going on towards newer development of mitral valve replacement therapy also with a less invasive way. So patients initially, when we take, obviously high surgical risk patients are being taken. There are so many new companies which are coming up, newer mitral valve processes, which could be implanted initially transapically. Now it has come to transvenous level where they come to about 28 French mitral valve structures. This Apollo TMVR trial is under place, and hopefully they will also do better. Another word about tricuspid valve therapies. In India, I feel it is very relevant to have a therapy for tricuspid valve also, because we do see a lot of patients, especially rheumatic. Whether the same can be extrapolated in rheumatic, we don't know, but we definitely want a solution to patients, because the more the severe the tricuspid valve TR, again, the survival will be less. So we need to correct those problems, and we need to save these patients who are otherwise dying with high risk with presence of severe AR.
That's how I think newer therapies are also being coming up, not only the annuloplasty devices, and but newer tricuspid valve replacement is again happening, even the tricuspid valve area. Tricuspid valve again is a challenge because we are not able to identify properly, image properly the RV function, valves, all that is a challenge. Gradually, we're learning more through it. The therapy started long time back, and now we are coming to the stage of clinical usage of these patients. And Sushil Kodali, my friend, recently presented this trial in TCT on the tricuspid valve replacement too. This is a Evoque transcatheter tricuspid valve system. This is 32 French now. Only beauty is it's only venous, so that's how they could do it from femoral vein. And initially, first 150 patients, then randomized to 400 patients are being studied. Comparison with medical therapy, what will you get? When you compare medical therapy, obviously the device reduction of tricuspid valve regurgitation. I'll just finish in a minute, sir. Tricuspid valve regurgitation would be less, and a significant number of patients who had severe TRs grades decreased in 6 months of follow-up. Not only TR grades, but even the functional class improved significantly in these patients. That's how this trial concluded, saying that we could successfully tackle TR also in these new devices, and there will be reduction in tricuspid regurgitation too. So what are they bringing in the future? Probably the future is with success of TAVR therapy, bicuspid we are already addressed, but we would address associated concomitant diseases. We also have going to the extent of tackling even asymptomatic AS to moderate AS with heart failure and high-risk severe AR. Also, we have data also coming up with percutaneous valve therapies. Cardiologists are smart. Once we get into it, we keep on searching for newer avenues. This early TAVR trial, before the aortic stenosis becomes severe itself in patients of LV dysfunction, this trial being planned. And Martin Liani proposed this new concept of modification of aortic valve before it becomes severe by leaflet modification therapies, which we call it as upstream therapy. But all these should be planned well and do it only with keeping the patient's interest in view. So MRTR front also, as I said, a lot of new things are happening. Toolbox, later combinations of various procedures will come up. But finally, I think mitral valve replacement percutaneously will stand the test of time. Final thoughts before I close my structural heart interventions talk is basically a lot of new things are happening. But mitral valve, tricuspid valve therapy is still in a long way. And aortic replacement, aortic valve therapy, TAVR has already come into regular clinical practice. I think with this, I'll stop and thank you all for patient hearing. More about this was discussed in our recent TCT meeting, and it is also there. And next year also it will be there. INTAS will be also helping in this meeting too. And I'm also happy to share because this Mumbai meeting went very successfully. They've also made me a scientific chair for the TCT World Link. Apart from the USA, rest of the World Link program also we are involved. And thankful to all of you for making this Our India meeting successful. Thank you.
Thank you, Srinivas. If you have any queries regarding the structural heart, I would say that we'll do it probably post-lunch session or during the lunch. You can catch hold of him and then, you can ask all your intervention things. And now moving on, not by design, by default, somehow we are shuffling between the procedures and the basics again. And now Dr. Dwivedi, who is now heading the KGMC, when I joined my DM, he was my teacher. Under his guidance, I did my DM. And I have no hesitation to say that I personally feel he's one of the best teachers in this country. I don't think the clarity and the vision he has and the explanation he does is phenomenal. Thank you so much, sir, for joining, because this is the first time I could catch hold of you in this forum. And so without much delay, on acyanotic heart disease, Dr. S.K. Dwivedi.
Like something to move here.
This is forward, this is backward.
No, some cursor here.
Okay, cursor is here.
I am, friends, I am so thankful to the organizers, Shivkumar, Srinivas, Professor Pahlajani, and I was lucky to be in the room when Professor Satyavan Sharma was speaking. Yes, it's wonderful to listen to you again, sir. So, in fact, you have been our teachers. We have learned from you in various forums, be it a lecture or Professor Satyavan Sharma would remember that he had come to our place when we had started our mitral program. So there are so many memories, and speaking in front of my teachers makes me a bit nervous. But I hope I'll pass in front of you. So let us go to how to approach a case of left to right shunt. Now, how can I have a cursor here? Yes. Now, my topic in acyanotic congenital heart disease, left-right shunts are obstructive lesions. And my job has been to discuss the approach to this. But before I go there, this is a simple thing. It's a commonest congenital heart disease. It is easily diagnosable, treatable with good outcome. But all these left to right heart shunts do not require treatment. Unfortunately, if you leave some, they may have a complication which you later cannot correct. So before going, I would go to fetal circulation, one of the aspects which have been removed from the textbooks now. But often I've seen that students are hesitating when they are trying to talk about why this happens in shunts and why this does not happen. I would come back to certain points and I remind you that umbilical vein is a single vein which brings the vein blood from placenta, oxygenated blood, goes through the liver, but doesn't mix, passes the hepatocytes and goes into the right heart, and then selectively goes with the IVC blood, it mixes, but total mixing is not there. And selectively, where eustachian valve is directed towards the left heart. From right heart, right atrium, it goes selectively to the left atrium. So left atrium is receiving a more saturated blood. Then SVC blood and IVC blood, they preferentially flow to the right ventricle, and then they go to the pulmonary artery. Now from pulmonary artery, since the lungs are fluid filled, remember this, fluid filled, we'll come to that later, and are collapsed. So there is a very high pulmonary vascular resistance. So what happens? Blood goes from right ventricle into the pulmonary artery, comes back, and then goes through the patent ductus into the lower limb. So RV output therefore goes to the lower part of the body, and the upper part, that is brain, is circulated by the left atrium, higher saturated blood, and coming from the left ventricle. So few things are clear, that it is a parallel circulation, not truly parallel, but if you remember, or if you see here, the upper limb is being circulated, head and neck is being by the other way, and the lower right ventricle is pumping into the umbilical artery, which goes for the gas exchange, comes back with umbilical vein, goes again to the umbilical artery. So these are two parallel circulation, and there is a large amount of right to left shunting. Where is it happening? At the level of pulmonary artery, from where the blood is going through the ductus arteriosus into the descending aorta. And placenta is the oxygenation site. So let us see what is the oxygenation levels at that level. So when the umbilical vein, that is when it is carrying the blood, carries 80%. So that is the highest saturation compared to 95 or 100% in the pulmonary vein. Here it is 86%, 80%. Inferior vena cava, superior vena cava, they both carry 25%. Right atrium, 50%. But left atrium, because of selective shunting of blood of the ductus venosus through the eustachian valve, is having 60%. So ascending aorta, brain receives 60%. Pulmonary arteries, descending aorta, umbilical arteries, they're all having 45%. So you must be wondering what happens, how are they saturated? Because the extraction, it is only 80% saturated. What is happening, how the child is growing or how the fetus is growing? It is because of fetal hemoglobin. The fetal hemoglobin is very, very closely attaching. It has a capability of attaching to oxygen more than what the adult hemoglobin has. There it comes into play. So saturations, despite lower saturations, the development is good enough. Now, few things again I would say. Here, since they are parallel circulation, the cardiac out will not be determined of one chamber. In fact, right ventricle and left ventricle both have different cardiac outputs. And you see here, the right ventricular output is 60 to 65% of the total cardiac output. That makes it a dominant ventricle. It is more dominant, more stronger ventricle. Second thing is important is that 45% of the total output is going into the umbilical artery for oxygenation. Upper part of the body receives 25%, lower part receives 25%. So they are surviving only on this, and the major portion is going for the oxygenation. That is second aspect. And third and more important, pulmonary artery pressure is same as the aorta pressure. Why? Because of the large ductus, which is same size as vein pulmonary artery or the aorta. So pressures are both same. See here, the pulmonary artery pressure is 50 to 60 millimeters, destined to fall to 20 or 25 in a normal newborn. And aorta is destined to go up 20 millimeter higher, from 60 to 80. Remember these things. And LA and RA pressures are same, 5 to 6 millimeters. So now let us go, what happens when? And see what is happening at isthmus. You remember that from aorta, the blood has gone to the upper limb, and from the pulmonary artery, the blood has gone through the descending aorta by the ductus arteriosus. So there is no supply at the isthmus. Isthmus receives minimum, so only 10% of the cardiac output goes through the isthmus. That is the reason why coarctation develops here. It is at the isthmus because it is not having enough expansile pressure, and these are further implications which you will read later. Now, what is happening at the birth? With the inspiration, there is marked reduction in pulmonary vascular resistance. So that is one critical thing that has to happen. The child has to take a breath. The air has to enter. And at the same time, once the PVR goes down, the pulmonary blood flow increases, leading to increased left atrial volume. Why? Because the pulmonary blood is now getting saturated. Functionally, it closes the foramen ovale because the left atrial pressure has gone higher. At the same time, once you have clamped the umbilical vein and arteries, the venous return to right atrium has gone down. So right atrium gets lower, left atrium gets higher, the hinge mechanism closes the foramen ovale, and ductus arteriosus closes functionally also. Why? Because ductus, to keep the ductus open, the blood through that has to be hypoxic. Once the hypoxic blood is not there, hypoxic blood is further stimulus for release of other substances, which this information you use later in preterm infants. So this is what happens, and establishment of a circulation, series circulation starts, right? So these are the quick things. You lose placenta, you get the increase in SVR, lung expand mechanically, oxygen as vasodilatation causes pulmonary vascular bed to dilate, PVR goes down. And remember, it is not only that there are certain more things happen here, is that the acinar arteries continue to grow if the stimulus or if the pulmonary artery pressure goes down, even after birth. And then the total cross-sectional area of acinar arteries goes on increasing, maximal in the first year and later till 8 or 10 years. That means the cross-sectional area for the gas exchange as well is more. That means if it is a normal child, the vasculature goes on having reduction of PVR even substantially after birth, up to 1 year, 2 year, 3 year, because the augmentation of other acinar vessels. And that will also be important. So what are the changes happening? And this is a beautiful, I'm not sure whether you're able to see that. There's seminal work from Rudolph done in 70s. There's a beautiful article, and Rudolph has been most influential. I don't think that we have been able to improve. Remember this figure. It is showing the pulmonary vasculature resistance, pulmonary blood flow, pulmonary arterial pressure, and muscle thickness. and this is the time when there is a birth. And here, this is their course over 1, 2, 3, 4, 5 weeks. Now, PVR, first one, markedly falls at birth. See here, it has fallen here, but continues to fall for 1 more week and continues to fall even further for 4 to 5 weeks. Why is this happening? Because the fluid that was there in the collapsed bronchus or the airway is not immediately absorbed. It takes about a week's time. That is why as the fluid gets absorbed, the gaseous exchange is more, the alveoli are augmented, and PVR keeps on going down even at 1 week. So by the end of 1 week, the adult SVR PVR ratio is maintained, not at birth, but at the end of 1 month. The ratio, but you may see here, the PVR is still falling. Similarly, the PA pressure falls. This is the PA pressure. See here, it was 60 or 75, and it has fallen down here to 25 at 1 week. Immediately at birth, if because of some reason, ductus is open or there is some stimulus to maintain the pressure, we'll come to that, the pulmonary artery pressure will not fall. That you must remember. The pulmonary artery muscle thickness reduces by the end of 4 to 6 weeks. There is the pulmonary artery muscle thickness. Now, because of some stimuli which will retain the pulmonary arterial pressure, they will also not let pulmonary arteries lose media. That is known as involution. When the pulmonary artery loses its media, it becomes more capacitous, and that further makes them capable of reducing PVR and accommodating more blood. Interesting thing here is that the pulmonary artery muscle thickness reduces totally by 4 to 6 weeks. But remember, the right ventricle was more dominant hypertrophied ventricle that also has to shed muscle. That takes time. That takes about 6 to 8 months time. And that will come in play when there is a pre-tricuspid shunt. In post-tricuspid shunts, the pulmonary artery is exposed to high pressure of left ventricle. They don't get time. Pulmonary arteries don't get time for involution. But what is happening in atrial septal defect? The right ventricle is the determinant chamber of how much blood is going from left to right. Left atrium to right atrium, and in diastole, right ventricle will decide how much blood is going to come in the right circulation. In the meantime, pulmonary artery involutes. When the right ventricle involutes at the end of 6 to 8 months, now the shunt will be established. That is why the shunt establishment in atrial septal defect or pre-tricuspid shunt is much later, and the children or newborn are never symptomatic. Remember this. Now, what are the factors which are against this? These are preterm, hypoxia because of any reason, respiratory infection or whatever, lung pathology, and fourth is pulmonary blood flow if it is increased because of presence of shunts. So what will happen there? The PVR will not fall. That is one thing will happen because of any stimulus. The pulmonary blood flow will not increase. It will remain reduced because PVR will not fall. The pulmonary arterial pressure will remain higher, and then the muscle thickness will not go down because there is a constant stimulus for it to remain hypertrophied. So that is what happens in the presence of large left to right shunt, particularly at the ventricular level, but not when it is in the pre-tricuspid area. I hope this clears the physiology why it happens. So at the time of birth, sudden things happen which are favorable. PVR falls, blood flow improves, the pulmonary arterial pressure comes down from 60 to 25, and the media, arteries lose media. But because of these factors, if there are any, this will not happen. That is why the Paul Wood has written that in VSD with Eisenmenger, cyanosis dates back to infancy. If I ask you, when will the child of VSD have cyanosis? You will not say it at birth. Or in infancy, you will say he will get it somewhere in the second decade. But what Paul Wood had written is that if because of any reason, if the child has pneumonitis or anoxia, there will be no fall in the pulmonary arterial pressure at birth, even in VSD, and so there will be a history of cyanosis. That is what he meant when he wrote that history dates back to infancy. History of cyanosis dates back to infancy. So this is what we have talked about. In post-tricuspid large defect, pulmonary artery are exposed to increase systolic pressure of LV from the very beginning. A large defect will delay PVR fall. Large
shunt will be established when PVR falls. And when it is falling, the lowest level comes by 3 to 4 weeks. But did you see, if it is a normal fall, if the flow is increased, it will fall further, it will be delayed further. So you will be having in establishment of shunt even after 1 month or 1.5 months. In pre-tricuspid shunt, the PVR falls normally, but shunt is not established because the RV has not involuted. Large shunts in pre-tricuspid are established at 6 months to 1 year of age. You will never hear a history, or you will never get a history of, let us say, failure to thrive in atrial septal defect. No. And this is the same thing in pre-tricuspid and ASD for large defect pre-tricuspid, telling us the same thing about. Now, why are we bothered about left to right shunt? Is heart failure is here with normal LV function, which may kill. This is very unusual. And second is pulmonary arterial hypertension. Why is there a heart failure? Because lung is fluid filled. The fluid has not been expelled yet. The capacitance of lung is reduced and tachypnea or work of breathing is increased. There is increased venous return of the left side because of increased left to right shunt. Left ventricular end diastolic pressure is increased and something like a pulmonary edema happens. This gives stimulus to left ventricular dilatation because the infant's heart is not good enough to take the volume. That is why it fails. For the same given similar volume or even a larger volume, the atrial septal defect does not produce heart failure. Why is it so? Because by the end of 1 year or 1.5 years, when the presentation starts, the heart is able to handle that much amount of my blood flow. But in an neonate or infant, those stimuli are not there. The myocardium, as well as the autonomic mechanisms, they fail, they overreact. Autonomic systems overreact and they fail. Similarly, the heart is not able to cope up with that volume and fails, and tachycardia. What happens with increased prolonged left to right shunt? There is persistent exposure of pulmonary vasculature to high pressure and flow. There are structural changes in pulmonary vasculature, medial hypertrophy and intimal proliferation. Till this stage, it is reversible. But if it is going beyond that stage, then there are fibrosis and obliteration of the arterioles and capillaries, which is then labeled as irreversible, and then the patient enters into Eisenmenger syndrome. Hence, early recognition of those patients is important because you can intervene earlier. Now, pulmonary arterial hypertension in congenital heart disease, there are certain figures which somebody may ask you. In atrial septal defect, it is 10 to 15%. I'll be only talking about other things you will get in the text. What is the age of development? That I'll not go into. In ventricular septal defect, 50% of them will have. In AV canal defects, nearly 75-80%, and all AP windows will have this. Remember this. Has our understanding about pulmonary veno-occlusive disease has changed? And this is what I was talking about. Recent articles have confirmed what the earlier studies were, that in patients who are having Eisenmenger, the cross-sectional vascular area is lesser rather than only obliterative changes. It is the total vascular area which is also lesser. Why? Because the SNR vessels have not grown in the early infancy and early childhood. So they have the pulmonary vascular resistance has not been lower. So some people say they are destined to go into pulmonary hypertension. Now, what is the determinant of shunt size? These are the two determinants of left to right shunt. One is the defect size itself, and second is pulmonary vascular resistance. High PVR will resist the large shunt. Now, these are this you all know, I believe. There may be small shunt, moderate shunt, or large shunt. To make it simple, let us say that small shunt is 1.5:1, large shunt is 2:1. In between, you can have moderate shunt. Is there a correlation between defect size and shunt size? Not exactly, but that is how it translates into. If you have a small shunt and you do not have a pH, the defect size has to be smaller. So shunt size you are calculating by echo. In today's world, clinical science don't have any value. You immediately jump to echo and you are trying to size and you are not able to see a VSD or VSD somewhere where you cannot see it or find it. You are only seeing the evidence of shunt. Then a small shunt without any evidence of pH, it is a small size defect. If a small shunt with indications or indicators of pH, then it has to be a large defect. And large shunt is there, the defect size can be moderate or large. So again, same thing, small size defects don't cause hemodynamic problems. You need not bother. And in certain situations, you need to close them. Large defect may either cause heart failure and the patient may die or go in Eisenmenger. When do we call them? What is the size which can cause them? ASDs of 20, definitely more than 20 millimeters, they will be associated with Eisenmenger. In fact, Eisenmengers, if you see, they'll be having a ASD of more than 20 millimeters, VSDs of at least 7 to 10 millimeters, and PDAs of at least 5 millimeters. So by size also, you can sometimes say that it is not there. And if you are seeing the gradients, then if you are seeing a pulmonary artery pressure, which is less than 0.3 of the aortic pressure by echo, or whatever way you find out, this has to be a small defect, provided there is no pH. And if there is no pH, you are seeing the gradient here, it is pulmonary artery pressure is 0.3. It has to be a small defect and shunt. If pulmonary artery pressure is more than 0.7 of the aorta, it is a large shunt. So these are certain guidelines which examiners, when you will call it a large shunt, when you will call it a small shunt, depending upon the PA pressure. We are talking about the systolic PA pressure. In Polwood series, all the patients who had pre-tricuspid shunt had an atrial septal defect of about 30 millimeter. Half of this 15 millimeter was for VSD, and half of this 7 millimeter was for PDA. So these are the sizes historically in Polwood series. Now, presentations in post-tricuspid, the symptoms we have discussed is 3 to 4 weeks. There are three things: feeding difficulty, repeated respiratory tract infections, and failure to thrive. They are all related to left ventricular dysfunction with normal LVEF. They're all related to that. But these children, they are growing. Why? Because the epiphysis is getting the normal saturated blood. So the height will be there, but they will be thin because of catabolic state, because of heart failure. Compared to this, in cyanotic heart diseases, children will be small. So they are small for age, and these are thin for age or small. In pre-tricuspid shunts, symptom onset is delayed 9 to 12 months, and then dyspnea is not the symptom. Why? Because the LV has developed. Effort intolerance is there, and matured lungs are there. So they are more compliant, and you will have a larger shunt, 4:5, 4:1, 5:1 in these patients, and you will not have that in VSD or PDA. So they are able to accommodate more shunts. Now, what are the signs? I'll be combining the signs together, and we are going quickly, about 5 more minutes. So in pre-tricuspid shunt, there will be 3 features of left to right, large left to right shunt. One is cardiomegaly, second is flow murmur, and third is shunt murmur. RV type or LV type. Flow murmur can be tricuspid with RVS3, and mitral murmur with LVS3. Remember, if there is no flow murmur, S3 is natural in children. So only presence of S3 will not diagnose it as a large shunt. You have to have a flow murmur. And then shunt murmur in ASD, there will be no shunt murmur. However, there will be systolic or continuous shunt murmurs in VSD or PDA. But ejection systolic murmur at the base is considered as a flow murmur traditionally. In small left to right shunt, there will be no cardiomegaly, there will be no flow murmur. Only shunt murmurs will be there. So that is how you will differentiate between small and large. Your idea is to get the large shunt out so that you want to focus them more. And these are the chamber enlargements. If you are a good clinician, you can see it clinically, or certainly by ECG, X-ray, and echo. So this is the sum. In atrial septal defect, these are the chambers: left atrium, right ventricle, pulmonary artery, aorta, and peripheral lungs. This pre-tricuspid shunt, left atrium will be smaller, right atrium will be larger. There will be no LV. RV will be abnormally large because of volume overloaded. Pulmonary arteries will be much more dilated because they have acquired hypertrophy after shedding that. And then peripheral lung fields in large left to right shunts will be perfused. Aorta will not be prominent. In VSD, left atrium and left ventricle are larger. Right ventricle is not that dominant. Why? Why so? You will not find right ventricular marked hyperkinetic as you see in the atrial septal defect. The reason is that the right ventricle has involuted in ASD, and then it has acquired. That is a different kind of muscle. What has happened? Right in VSD and PDA, in VSD and PDA, remember, intrauterine right ventricle was taking a load from the very beginning in utero. It has not shed its muscle. It was never hyperkinetic from the birth as well. So it will not acquire a hyperkinetic or forceful impulse. In VSD Eisenmenger or PD Eisenmenger, parasternal impulse is generally not more than grade 1 or 2. And then Peripheral lungs are again suffused. That is what will tell you whether there is an increased flow or not. Peripheral 1/3 of lung perfused, large shunt. Not perfused, small shunt. And what will happen with Eisenmenger? You can see here, the ventricular chambers, cardiomegaly will be gone. Chamber size will be reduced. The lung periphery will be clearer. Broadly speaking, the chamber sizes will be reduced. The lung periphery will be reduced. That is the two things that will happen. And definitely shunt murmur, flow murmurs, they will be reduced. So it will be more silent heart, smaller heart. You think that patient is getting better, but in fact, he's in problem. How do you follow up large shunts? Echocardiography is gold standard, but sometimes you can follow them clinically as well. Clinically, you are looking for cardiomegaly, shunt murmur, and second heart sound. Second heart sound becomes important. For example, if you are following a large left-right shunt VSD, baseline, imagine if it's a large left-right shunt, not much pH, it's a wide split, loud P2. Because the capacitance is good, so split will be wide. In follow-up, what happens? The split becomes narrower, or it is normal with normal P2. Shunt has got smaller. If it is a narrow split, but loud P2, split P2, and then decide, then pH. Or if it is a wide split still there, but normal second heart sound or soft second heart sound, probably he is developing a Gussul phenomena, or let's say developing the RVT obstruction. So that is how you can follow in there also. Why should we treat? Why? Because heart failure is there. Left ventricular dysfunction in later life can also happen, and you have to prevent the pulmonary arterial hypertension and arrhythmia and sudden cardiac deaths also. That is why you treat. Atrial septal defects will not go into incidences. There are various types, you know. ECG sometimes, all will present same with cardiomegaly, right ventricular volume overload, and ECG sometimes may help you. How? Because seeing the axis and loop of the ventricle, looping of the ventricle, you can decide what kind is there. Spontaneous closure of atrial septal defect is known till 1 year, maximum to 2 years. And less than 8 or 9 millimeters will close. But if it is at birth, or let's say at later stage, 3 or 4 months, if it is more than 1 centimeter, this is not going to close. So occasionally you hear a report of 4 millimeter ASD, don't bother about it. And this is the data. 87% of 3 to 5 millimeters ASD will close. But none of them with more than 10 millimeters will persist. What is the indication for treatment? Usually they are adults. You don't operate them earlier. Usually they are adults. And you say RA and RV volume overload generally by echo, you generally don't require a shunt calculation also. But still, paradoxical embolism may be there. So if you are having the evidence of right ventricular volume overload, then electively operate them by 3 to 4 years of age. Earlier, if unremitting CHF or associated PH or failure to thrive, I asked the pediatric cardiologists who are working day in and day out yesterday, 2 or 3 of them who are very, very famous in India, and asked them who have more volume, asked them, how often have you asked any child to be operated because of failure to thrive? They didn't have a data. He said 1 in my life. The other said that probably none. So this is written in books, but it is already, it doesn't happen actually. And it doesn't happen because of the physiology. In late detected cases, you have to see probably the pulmonary vascular resistance to see whether it is operable range or not. Early closure is not required. You are not losing anything. But this is the data of long-term survival dependent upon the age. If you see here, this is the age till 24 years of age, or even up to 24 years of age, there is no difference between between the intervention and no intervention. But see here, beyond 21 years, 25 years, the age, appears to be a difference. So if you have to intervene, you intervene earlier than 25. And this is the, how is it related? Basically, what I want to say here is that pulmonary arterial pressure is another indicator. If the pulmonary arterial pressure is more than 40 millimeters, probably he will fare poorly. Operate him earlier than if it is a normal pulmonary arterial pressure, definitely before the age of 20 years. Modality of treatment, closure by pericardial patch using sternotomies, and then septal occluders are also there. Transcatheter closure can be done, but it is essential to see that rims are there. And the Indian guideline says that weight has to be more than 15 kgs and it should be more than 4 years. The reason is that the atrium itself is very small. If you are closing it with the atrial septal occluder, then the devices, the rim which are there, which are beyond the diameter, may be eroding. So one should be very cautious about doing it in small children. These are the ASDs which are not suitable, a primum defect and superior vena cava defects. And this is an important, interesting article. What it is trying to show is that if you do it in patients who are less than 45 years of age, whether it is device closure and surgical closure are having the same result. But if the age is more than 40, then the event-free survival with surgical closure is worse. So if you are intervening in a more than 40 years old individual, you should go for device rather than surgery. Ventricular septal defect is commonest. These are the types. Congestive heart failure is in large VSD. We know about it. This is the outcome. A spontaneous closure is there in 75% of small VSD, but large will not close. And another one which will not close is malignant or outflow VSDs. AR may happen in 7%. Gasol phenomena or RVOT obstruction may happen another 10%. Spontaneous diminution, we have just discussed, small defect 75 to 80% will close down. And almost majority of the closures will occur before the age of 2 years, but they may close till 10 years also. Management, if it is a large VSD, usually it is managed when you encounter the patient, it is managed by drugs. And if you have to operate, you monitor them for weight gain, which should be somewhere around 150 grams per week. That is how you define a failure to thrive. 150 grams per week, it was not, then he is probably not thriving well. And then closure has to be done by 5 to 6 months. In small VSDs, don't close and follow them up yearly. Even why? Because the event-free survival in small VSDs 10 years is more than 95%. Small VSDs sometimes will need closure, probably when there is aortic valve prolapse, or when there is a AR. The most common prolapsing valve is non-coronary cusp. So if you are finding a AR, then operate. Or any VSD which has an infective endocarditis, close it down. Therapy of heart failure, digoxin has no role as believed, but it has no role. The only important thing is loop diuretics with MRA or ACE inhibitors. And transcatheter closure should also be done or may be done, but is not applicable to large VSDs, classical for muscular VSDs. Why? Because there are risks associated of complete heart block. And again, in very small ones, it should not be done. PDAs, incidence if higher is preterm is there. The natural history is nearly same as a VSD. Aneurysm formation and calcification is there. In fact, this is the only lesion wherein the current guidelines say that in PDA in adults, because of risk of calcification, one should always close it by the device. Indication of intervention is that when there is a heart failure, you can intervene at 6 months. And then tiny echocardiographically detected PDA, which has no murmur, can be left. Otherwise, all PDAs have to be closed. If it is a significant in preterm babies, then look by the echo whether LV is enlarged or not. And what they say is that aorta is larger than LA, or PDA size is more than 1.4 per kg body weight, then close it down. You give indomethacin and then close it down. Now we come to, these are the closure devices which can be done. Treatment of choice, but weight should be not less than 6 or 7 kgs. So do we need to catheterize? Coming to these, some controversial points. Do we need to catheterize VSD and PDAs always? First is a scenario which is operable. There are certain clear-cut indications or non-invasive evidence of a large left-right shunt, like failure to thrive, increased precordial activity, cardiomegaly, increased pulmonary blood flow, Q in lateral leads, good LV forces, LA-LV enlargement. You don't require them, operate. You don't catheterize. Why? Because the guidelines say that a patient who is having more than 2 years necessarily must be catheterized. No. And then if there is a clear evidence of shunt reversal with cyanosis, oxygen saturation at rest or exercise going to less than 92%, heart size has become smaller, peripheral pruning is there, then it doesn't need any operation. So in these two scenarios, you may or may not operate. And remember these two. Unnecessary catheterization is not to be done when there is manifest cyanosis. Borderline clinical patients create confusions. And then what to do? Then you have to catheterize. If PVR is less than 6 Wood units, you operate. In fact, your international guideline, EC guideline says 5 units. But here, Indian guidelines say it is 6 units. They say that if it is less than 3 units, you operate. In 3 to 5, you see wait. But here, let us say that still 6 units you operate. If it is 8 unit, you don't operate. And in between 6 to 8, give pH modifying drugs and wait. That is important. From 6 to 8, you give pH modifying drugs, bosentan or PDE5 inhibitors, whichever you want to give, and then wait, reassess, and then operate. I would skip this. What about the borderliners? These are the borderliners. Children presenting beyond 2 years of age with pH. Operability is in doubt. These are different difficult subsets. If you operate, then is a problem. If you don't operate, then there is a problem. But if you are in doubt whether I should operate, there is a question coming to mind because the pulmonary arterial pressure is higher. What should I do? Please don't operate. Leave him. Why? Because his survival, if he develops Eisenmenger, is better rather than if he goes into heart failure and you close the defect, then it is a mess for the child. He will not survive if the defect is open. So I think I will stop here. I thank you very much for the attention that you have given and anything that I may be able to answer. Thank you.
Perfect. Thank you so much, sir, for such an erudite lecture. And do you still want a food or you already had a feast? Okay, so the question and answers, sir, will be there. Probably we are already 20 minutes behind the schedule. And so we'll take a break now and we'll regather within 40 minutes and the session will start again. Thank you. Okay, welcome back. I'm sure it's a postprandial hyperglycemia. So I'll wake you up from all those things. So moving on, as I said at the beginning that, we have a little bit of interspersed lectures because of the availability of the faculty. So although we went with cyanotic and will be followed by Rishi, who will talk about the examination of precordium. In between, I have come with the hardware in the cath lab. Can you start? Okay. Okay. So before I start, I would like to know that how many of you have been into cath labs? Oh, quite a good. Oh, okay. So that's the beauty is that today, every person, every DM who passes out, he is intervention cardiologist by default, until unless proved otherwise. Okay. So all of you are intervention cardiologists. Okay. And happy about it. And the problem is that all of you are in hurry to put a stent, do a complex case, probably do an AICD or CRT, and if time permits, if luck permits, TAVR also to be done. So that's a good goal. But I had been with all these, they are all joining us. Most of the seniors, most of us, and most of these very seniors like Dr. Palajani, Ashok Seth, and all those people, whenever I talk to them, all of them have a feeling that large majority of the cardiologists who have performed good procedures, done very good, but hardly pay any attention to the structure, construction, and the design of the material which they are using it in day-to-day practice. So I strongly urge all of you that since I can see almost all of you want to become an intervention cardiologist, please pay your attention on this lecture because this is not only going to make you pass probably if you answer this, but more than that, it will give you an insight how you do a practice tomorrow when you're coming to the practice and then how to go ahead with that. So with that short brief, I'll proceed. Okay, so this is the reality. So I mean, it is impossible literally to cover all the hardware of the used in cath lab. I purposely thought about the several things. I'm not going to talk about the stents because I'm sure even if I don't talk, almost all the companies will make sure that you know about the stents. Right or wrong, that's a different story. Okay, but at least you will know what the stents are there. Guiding is important, but again, I thought it's a second thing. The most important thing is an angioplasty guide wire. I can tell you one thing is the success of a cardiologist, an intervention cardiologist depends how he handles a guide wire. Now, after almost my 30 years, 35 years of practice, I can say that the moment I see a youngster or any junior or anybody, any operator, in 20 seconds, you can make out how this operator is because it all depends on the guide wire. So I request that, pay some little attention and find out what exactly is the guide wire is made up of. So what is the purpose of angioplasty guide wire? The first purpose is to track through the vessel. Okay. I mean, that means it has to go according to the bends and tortuosities and whatever is there along the vessel. So the guide wire has to go through. Then it has to access the lesion. Access the lesion may be in proximal, maybe in mid-segment, maybe in distal, maybe bifurcation, maybe fibrotic, maybe calcified, whatever may be. But we need to access the lesion with a guide wire. And to cross the lesion atraumatically, that's the most important thing. Once you are inside the lesion, it should exit the lesion atraumatically. And that means it should not dissect, it should not perforate the vessel, and you should be able to get the wire out of the lesion and then take it down. And of course, the last function of it is to provide support for interventional devices like balloons, stents, microcatheters, and rotablation or whatever it is. So fundamentally, these are the 4 principles on which the guide wire works. Before I really start talking about the different guide wires, what are the few characteristics of which are pretty important? And these are often spoken, but very few really understand what exactly it means to. So let's go through that. What is our torque control? So the torque control in simple words is the amount of rotation given at the proximal end. That means at the operator, whatever is the amount of rotation he is giving it at the wire with the torquer, and how much is the rotation at the distal tip of the wire is happening. That is called the torque, or it's a torque control, because that is critically important. Because what is the length of the guide wire? Any idea? I'm sorry? 175 to 180 centimeter. And what is the length of the long guide wire? Loud, please. 280 to 400, it can be anything, okay? So it can be 200 to 280 to 290 or something. So what I'm saying is when you have such a long guide wire, so the torque control becomes a very critical point of a guide wire. Because if the amount of rotation you're giving it and it is that much amount of the tip is not moving, then the success of the procedure will be limited. Second is the trackability. What do you mean by trackability? Trackability, it is an ability of the wire to follow the wire tip. Means whenever there is a curve, there is a tortuosity, there is a bend, there is an acute bend, or there is a calcification. So the wire body has to follow the tip. If it starts buckling it, if it starts kinking it, then the trackability of the wire is not good. That is why we say the trackable means despite all that, the whole wire, we could put it down where it has to go. So that's basically the body is following the tip. Steerability. Steerability, it is an ability of the guide wire tip to be delivered to the desired position. Steerable means you have crossed the lesion fine, but you don't want to leave the wire there. You have thought before it that you want to land your wire, the tip of the wire at this point. So that should be the ability of the wire, that is called the steerability of the wire. If you are not able to do that, then you have 2 problems. Either if you left it before, whichever is the position you thought about, and if you're not able to, it will not give you the support. And suppose if it is gone too much, then it will perforate a small branch. So this happens with a lot of young cardiologists. Initially, they do a good procedure, they do everything, clap, clap, clap. They have done a beautiful angioplasty, everybody cheers up, they get a party, and after 6 hours, they suddenly feel the patient is gone bad. So there is severe hypotension. You come back and you recheck the angio, and then suddenly you figure it out that when you have deployed all the material, at that time, the tip of the wire progressed somewhere else and it perforated it. You didn't even notice it. So this is what happens. So steerability of the wire is critically important. Then the flexibility. So flexibility, it is an ability to bend with the direct pressure. That means whether the tip of the wire is flexible or not. I'll tell you about that also a little later. The other thing is a prolapse tendency. Tendency of the body of the wire not to follow the tip around bends. That means you imagine something like an engine with a bogies, or you can imagine it's a tractor with a trolley. If tractor engine is going somewhere and trolley is not following it, that's the thing. It's a prolapse. It's prolapsing. That means body is not following the tip of it. This is again, there is a reason for that. The prolapse, sometimes this factor can be used in various maneuvers when you really want to enter an acute angle artery. Then, of course, comes the radio opacity and visibility. That is very important because these are the lesser important features, but that is very important because if you are able to see where the wire is, because that radio opacity is the critical point where you can leave the wire. So that radio opacity and visibility becomes the next important point. Tactile feedback. Tactile feedback is the one which makes an operator successful versus an unsuccessful, or a great operator versus an average operator. Because I'm telling you, many times you have a CTOs or you have an acute MI where there is nothing is visible beyond a left main, or sometimes left main is also gone, but still you are able to place both the arteries, the wires into LED and circumflexes because of the tactile feel. You can feel, if you really do few thousands of angioplasties, you can easily tell, you can feel whether you are inside the artery, you are touching a wall, or you are somewhere out of it. So the trackability is again, the tactile feedback is also one of the important factor and character of the wire. So there is a components which play part in tactile feedback actually. So tactile feedback of a wire is again a very important thing. Then of course the crossing, it is an ability of the guide wire to cross lesion with little or no. So that means it is the crossing of the thing atraumatically. We want every wire to cross the lesion atraumatically. That is without causing a dissection, without going subintimal, and without causing a perforation. So this, if we can achieve it by a wire, that is a successful procedure as such. And of course the support. Support is also very important. This why I'm enumerating all these points, because each and every point plays a critical role in your day-to-day practice and when you start really doing an interventions on a regular basis. Because you might have put the wire down wherever you wanted it, all was fine, but if the wire doesn't give you a support, your stent won't go. You will start thinking so many things, but wire is not supporting. You do anything. You take a guide liner, you take another inner catheter, you try to push all those things, but that's not the point. Basically, your wire selection was wrong and you're not taking a wire which can give you a support to transfer all this, whether the balloon, the stent, or the microcatheter, or the rotablation. Okay. So kindly spend some time on all these 8 factors, then start going into the cath lab. So again, I'm not going to spend too much of a time on theoretical part. I thought, I'll just cover the important things, that how basically, that's the reason I said that the structure of the wire or the design of the wire, construction of the wire is important to consider before you really jump into the field and start doing the procedures on regular basis. So it consists of 3 things. One is a core, then another is the tip, and the third is the coating. There are various ways of classifying this. Everybody does it in their own way. I have my own way, but I felt that, I'll do in such a fashion which will give you more relevant information in your day-to-day practice. So first comes the core. You can see that this is this is the major part. So this is the core, which is the structure, which can be of 2 types, with 3 types. You can have a steel, you can have high tensile steel, or you can have a nitinol. Okay, these are the 3 core materials. Now this core, the core can extend up to the tip, or it can end before the tip. So that is the reason when we say the up to the tip means it is core to the tip. Okay, body to the tip. So these are the ones when you have a core up to the tip, the advantage of that is it gives you a support, it gives you a pressure, it gives you a force. So you can penetrate, you can go into the harder lesions, but the problem is it avoids the flexibility. You don't have the flexibility of the wire. So but most of the time, the workhorse wires are the ones which will be, usually they are up to the tip, except for few, 1, 2, I'll give the examples of them. Then of course, comes the tip. So the tip consists of nearly 3 centimeters to 20 centimeters of each wire consists of a tip. And usually it is basically a coil sort of a cover, which is always over there. And this tip can be a same, that means the diameter may remain the same throughout the wire. So that is, what is the normal diameter of the wire is? What is the normal diameter of the guide wire? I couldn't hear any. 0.014 inch is the normal guide wire the diameter is. So either the diameter can continue up to the tip, or you can have a core. The tip can be narrower. That means the 0.14 may come down to 0.10, may come down to 0.19, 0.09, or it may come down to the 0.11 also. So the tip again can be of the same size, or it can be a narrowed one also. There is again a reason for all those things, that how it helps you in practice. And of course, the coating is the third thing. So coronary guide wires are usually 0.014 is the normal standard size. The core I already told you. The tip is usually a spring coil, okay, and it can be extended up to the tip. So most of the workhorse wires are having actually the core to the tip. So they are the core goes up to the tip. And whereas there are some wires, BMW is the commonest wire actually. Basically, it doesn't go up to the tip. That's what I was saying, that, you know, the advantage of BMW is usually a workhorse wire. I'll come to that, why the workhorse wires and other wires are. But the advantage of the BMW wire is that, oops, sorry. This is the BMW wire, when you can see that it's basically the tip, the core is ending here. It's not going up to the tip, whereas here it is going up to the tip. So this gives you the flexibility. So when it doesn't go up to the tip, you get a flexibility. And I'll show you the example. The flexibility can be utilized, especially when you have a very acute angle circumflex arising from left main. Then when you really want to enter it, you don't have to bend the wire. What you need to do is you go there, use the advantage of the flexibility of the tip, it goes down. And that is the reason in these situations, certain wires are there. If you know the structure of the wire, you know the construct of the wire, probably you can start planning your procedure. So, and of course, the most important point is the coating. Coating, I'll come, because this is what it is. The coating is, sometimes the coating can be from here up to the point, this, or it may end just before the tip. Okay. So people have categorized into different ways, but I personally feel the wires should be categorized broadly into two categories, whether it's a polymer coated or non-polymer coated. Okay. People have a tendency, because this is a little tricky. Polymer coated wires usually on top of the stainless steel, very hydrophilic. Non-polymer workhorse wires, nitinol or stainless steel, often hydrophilic or hybrid. I want to tell you here that people think that the non-polymer is hydrophobic. No, there is a difference. Most of the non-polymer wires are hydrophilic. The polymer coating makes it extremely hydrophilic, very, very hydrophilic. And that makes the difference in procedure. So don't go with the hydrophilic and hydrophobic. Hydrophobic, when it comes into water contact, it becomes like a wax. When it comes with the hydrophilic, when it comes in contact with the water, it becomes slippery. Those are all not the practical ones, because you want to use the reason why you want to use a polymer wire and non-polymer wire. I'll just go into that a little later. So primarily polymer wires are usually, it can be both, can be a stainless steel, can be a nitinol, and non-polymers are usually the workhorse wires, nitinol or stainless steel, and sometimes you have a hybrid wire also, where you have a combination of both the nitinol as well as a stainless steel, and that's basically is a run-through wire, is a normal, is the one which is a combination of both. So okay, so this is one slide where I would like your attention, and because this will give you the most of the message which I want to give it, that I'm not describing you only on the numbers and whatever is the structure and other things is enough. You know what it is. The core is made up of steel or nitinol, and there is a tip, and then after that you have a coating. Okay, it's a polymer coated or non-polymer coated. Polymer coated can be hydrophilic, non-polymer also can be hydrophilic. So basically there are two axes. One is lubricity and the penetrability is maximum with a polymer wire. And the moment you have a hydrophobic or you have a non-polymer wire, the lubricity goes out, but tactile feedback, you get it. So it's basically a play between the two things, whether you want a tactile feedback or you want a deliverability, you want a lubricity, you want to really get through the things. So you will understand once you start doing it that what exactly is your idea of doing that particular procedure is what exactly you're looking for. If it is a chronic CT or if it is a very micro channels, obviously you will use a polymer coated wire which will go through a micro channels and it will get through the lesion. Whereas if you really find that it's a hard CTO where you really don't know and you really don't want to perforate the artery by using something, then probably you will use a forced wire, but at the same time, you want the tactile feedback. So these are the things which you will get it across the time. So coming back to the non-polymer, as I said, most of the workhorse wires are non-polymer wires. What is a workhorse wire? Workhorse wire is, primarily, I'll suggest you, all of you, whoever is operating is, you have to select one wire which will be your patent wire for most of your procedures. You can't keep changing your wires every day. Like, you know, one company fellow comes and meets you, you'd start using it. Second fellow comes and you will mess it up, and you will not be successful. I can give you in writing. So primarily, you have to have one wire which is your most dependable wire, which we call it as a workhorse wire, because you get the feeling of it, you get the sensation out of it, and you really know how to handle that wire. So most of the workhorse wires are low tip weights, unlike the heavy tip weights. Actually, in that, one of the things which I forgot to tell you is the bending of wire, because bending of the tip is equally important. The amount of force required to bend the tip of the wire is usually calculated in grams. Okay, that is how you know the most of the CTO wires are called as 12 grams, 20 grams, 2 to 3.5 grams, 4.5 grams, Gaia series and other things. Whereas the normal BMW wire, which is a workhorse wire, usually it will have a less than 0.9 grams, 0.9 grams, and usually 0.85. That is a hybrid wire. So that's what it is. The most of the workhorse wires are low tip weight, less than 1.2. And of course, the BMW and Minamo, these are the two commonly used the workhorse wires, which are usually hybrid wires. It's basically the tip is, it doesn't go up to the tip and the tip is flexible. Whereas the other ones run through Pro Water, Samurai, and Cyan Blue. These are all the wires which basically made up of a steel. Stainless steel is the body. So again, you can see in general, most of the weights are lesser, 0.8 grams, 0.8 grams, and 0.5 grams, and Cyan Blue and Cyan. Actually, there is again a confusion between, I used to get confused with Cyan Blue, Cyan Black, and Cyan as such. But I can tell you, is Cyan Blue is the one which is a non-polymer coated, which what's a Cyan Black, which is a polymer coated. And normally I'll use a Cyan Black whenever there is a CT or very where I really want to slip through a wire there, I'll use Cyan Black. Whereas in Cyan Blue and other things is the one which is more, basically it's a non-polymer, but it's more safer wire, and it can go through the twists and other things, and it gives you a support, because the best part of it, that is the best. I'll show you 2-3 examples of those procedures which I have done, how the wire mattered a lot. Okay. And now the polymer coated, as I told, the polymer is extremely slippery in character, and you can go through the most difficult lesions, and basically it goes through a micro channels. So first line is usually Whisper. Whisper is my favorite wire. Of course, I won't suggest everybody to start with Whisper at the beginning, because Whisper is polymer coated. It's a slippery wire. If you don't have a control, you can perforate it or you can dissect it out. But it is one of the best wires, because my workhorse wire is Whisper, and majority of cases I do with that. But of course, there are Pilot 50, Cyan Black, and Fielder FC. These are for the polymers. And before I really go on to the low tip weight, I will say that what are I don't want to really go through too much on the CTO wires, but again, Gaia series is the one which everybody all of you must be aware of it. Gaia is the one which is often spoken in all the meetings whenever there is a CTO things, where the thing is, it is 3.5 gram and tapered. That's the important thing. As I said, as you start tapering of the wire, the tip of the wire is tapered. So the amount of force is in a smaller area. That is the advantage of taper versus non-tapered wire. Because you can have the same amount of gram, like 3.5 grams or 4 grams Gaya. But if it is non-tapered, then it doesn't give you that force. That doesn't. So in CTOs, it doesn't really help you out. Okay. So tapered wires have this beauty of it. And of course, Judo and Miracle, you know that. Confianza Pro is the last choice. All of us, you use Hornet for 14 because both have got the tapered as well as 12 grams and 14 grams. So not going into that too many about it, but generally, I would say that if you really want CTO wires, this is usually the classification. That's how we step up the things. And whereas if you have a polymer coated wires, the initially start the work, basically the primary line wires are these Vespa, Pilot, and Xeon Block. And low tip weight, tapered tip. In simple CTOs, Fielder XT is my choice. Fielder XT is beauty is because it is again a tapered wire. It usually comes down to 0.009. So from 0.014 to 0.009 gives you that force. And in simple CTOs, it can cross through. And heavy tape, Pilot 200 and Monango is again a very common wire. Okay, Pilot 200, a lot of my colleagues, they use it. So as I said, that basically stainless steel versus nitinol, it's basically that's the core. The advantage of nitinol is that it is kink resistant. Okay, it can take the shape and it doesn't get spoiled. That's the beauty of the nitinol versus the stainless steel. And as I said, that many times nowadays the companies are coming with a mixture of both the things. Like, you know, there are like initially I told you the Xeon and other things, they are pure stainless steel wires. Whereas you run through wire is a combination of both stainless steel and the nitinol. So that again makes the wire gives you support as well as the flexibility also. So the wire properties, these are the ones, the trackability, flexibility, deliverability, and kink resistance. If you want all those things, so the first choice is, it is very high with the polymer wire. It's usually okay with soft, low tip wires with hydrophilic and with nitinol. Whereas if it is stiff tip and heavy body, you won't get these things like trackability, flexibility, deliverability, and whatever. So if you really, it has to depend on the type of the lesion which you are to cross. And according to that, probably these are the wire properties. You should keep it in mind, and then you should select your wire. Tactile feedback, as I said at the beginning, that, you know, you want to cross it, but you really want to know whether you don't want to perforate that, you're not sure about it. So tactile feedback becomes a very important point. And whenever you need a tactile feedback, so it cannot be it cannot be a polymer coated. It has to have a steel, because core to tape, it will give you the force and it will give you back the tactile sensation. And of course, if it is a tapered wire, further good. Okay. So I think I've already crossed a lot of time. So I'll just go on to the clinical situations, few of them. If you have a calcified critical soft polymer wise Whisper, as I said, Whisper in Xeon Black will be my first choice. If it is a thrombus, if it is a simple thrombus, probably any BMW Pro Water or Samurai is pretty good. But if you have a subacute thrombus, or it is an organized 4 days old MI, 9 days old MI, probably, but I always use a Whisper as my first choice. But for beginners, maybe Whisper can be a second line of choice. Okay. And of course, CTO, I don't want to really go through all those things, but because this is, don't start with a CTO ever in your practice at the beginning. But okay, this is how you go up with the Fielder XT, you start off in Gaia second and Pilot and Confianza is the last one. So skipping few slides and okay, I just told you that, you know, how the wire helps. Now, this is the one which we did this case just 2 days before, actually. Okay, now, okay, unfortunately, that is not there. No, my dear, before this, there was another. There's one more AP caudal view. This is okay, yeah, this is okay. Now you can see here that it is an ostial left main, the ostial LAD with almost like, actually I wanted to show you that in AP caudal view, unfortunately it's not there. So the left main and circumflex were directed like this, and LAD you have seen, it's ostial LAD almost like a 99%, and it was at the right angles. Okay. So primarily you have to have a wire which is actually the left main, everything was directed towards the downside, and the LAD was exactly at a 90 degrees angle, and it is almost like a 99%. So that was a really challenge. So this is where you need to select your wire, because what do you do with the selecting for the such type of wire? So your tip is flexible or not, that's very important, because if you know that your tip is flexible, probably there it can bend, and before that you can give your bends to the wire, the primary and the secondary bends, and secondary and primary bends are given according to the size of the artery. How much is the size of the, if the LAD is broader or smaller, according to that you give a secondary curve. So unfortunately I could not show you, but that would have been a nightmare to enter, but I used initially the otherwise, but this was the things, and finally this was a simple whisper wire which easily went through, and that's how I could got it. And you can see at the beginning that, you know, I made all those bends in that. Okay. So this is what it is. Anyway, that's all. So moving on now, the second point is the guide catheters. I really will spend just 2 minutes on this. The guide catheter selection is elementary, but an issue of extreme importance, because until unless you select the guide catheter properly, until unless you give the support, your procedure will not be successful. You might cross lesion, you might do anything, but if the guide support is not there, you're gone. So guide selection is critically important. It has to sit, it has to cannulate properly. The another thing, most important thing is, any idea what is the internal diameter of a guiding catheter versus a diagnostic catheter? So I would suggest, I give you the answer immediately, but I would always suggest, please go back and go through that. It's very important. I'll show you why I'm saying that also. But anyway, keep it in mind, and I'll tell you later. Okay. So the guide catheters, and often it is told in French. So again, what is this French? French is not French leave, but French is, of course, you know that Charrier, who was a urologist who did it for the urinary catheters. That's how he named it. And one French is equal to pi is equal to 3.14, or one size is equal to 1/3 millimeters. That means if it is a 6 French catheter, that means it's roughly about a 2 millimeter size catheter, and if it is a 9 French, it is a 3 millimeter. So kindly remember that, like, you know, 6 French, 7 French, and 8 French, how it is. Why? Because I'm saying is, the reason is, when you measure the coronary arteries, or when you're measuring the guiding, and that is how you are assessing the stent, the balloon, or whatever it is, you must know, because that will come into millimeters. It will not come into French. So how do you know that, you know, 6 French is equal to how many millimeters and 7 French is equal to how many millimeters? According to that, you can calculate the stent size and the balloon size and other things. So that is the reason you must know what is one single French stands for. Again, the basic design of it, there are 3 things: lubricious, the innermost coat, then stainless steel, which actually makes the braiding, and then the outer soft nylon thing. So this is the difference, because the between the diagnostic and guide, okay, the braiding is not there, so that becomes the supports are less. And again, there usually a primary curve and a secondary curve. And normally you say JL 3.5, 4, 4.5. What does it mean? Any idea? Sorry? Primary curve. Yeah, it's basically a secondary curve. So that's the length. Okay, it's a 3.5 centimeters, 4 centimeters, or 4.5 centimeters. Depending upon the width of the aorta you selected. Suppose if you have a very wide aorta, naturally you will have to go with a 4 or 4.5 or 3.5. So that's the thing is, okay. And these are the different catheters. I don't want to get into those. Judkins and other things you should know. You should remember all those things before you really enter into the cath lab. So yeah, M+ cannulation. This is one thing I will say, that AL1 is primarily for left side cannulation, but you will be surprised that most of the right coronary catheters are done with AL1 or AL2 because that's the best part. Many times the right coronary doesn't get cannulated by regular catheters, regular guides. Then what you need to do is you have to take a M-plus L1 or AL1 or AL2, spin it off the other side, and then it goes and happily goes and sits it. But not at the beginning, do it at the later on, because the problem is the M-plus is the push, it comes out. If you pull, it goes in. So that it works in differently. So out of anxiety, you think, oh, it has gone too deep, and you try to pull, it will go further down, it will dissect it. So don't handle M-plus at the beginning of it. You have to be really good at handling the things, and that is how the M-plus AL1 catheters or AL2 catheters, they go and sit. That they normally go into the left side and give a spin, and then they go and sit into the right coronary. So extra backup is again for the surgery, multipurpose, and this is the one which I would show you. Can I run this, please? Okay, this is my practical experience, and again, I'm not trying to do it please, yeah, for any popularity purpose, but I just want to show you. Okay, so you can see that this is nasty left main, okay, which is completely dissected left main, and we came across this situation, and what happened is this is a diagnostic catheter, and after that we did everything possible. No guide went and cannulated. We could not cannulate any guiding. I tried everything, and by the time you can imagine, it's a left main nasty dissection. Patient's condition started deteriorating. Patient had a hypotension. We had to ventilate him. He was really in a very, very bad shape. But still, unfortunately, we were not able to cannulate it with any guide. Next. Oops. Sorry. Next. Next. Okay, can you see here? Okay, so now you can see what it is. This is very strange. You're seeing a stent on a guide wire. Have you ever seen it? So this is what it is. So what happened is we tried everything, failed. I could not by any means could cannulate. And at that moment of time, patient is already in a pretty bad shape. No surgeon would touch. Nobody would do anything about it. Except for the diagnostic catheter, nothing was going in. And that was a time when this helped me. The internal diameter of diagnostic catheter versus a guiding catheter, because internal diameter of diagnostic catheter is 0.050 inch, and whereas the guiding catheter should be about 0.067 to the 0.90 inch. That is in inches, actually, the guiding catheter diameter comes into. And the stent size was, we measured it, okay, it tells you what is outer diameter of the stent, okay. It was around 0.72 inches. So I knew that by no means I can get it. So what we did is, I don't have all that thing, but I'm just telling you that we went with the diagnostic catheter. I knew diagnostic catheter is going to take a balloon through. So we cannulated the left main, we went into the left LAD. With a balloon, I have expanded the left main, got some time of 10 to 10 minutes where the patient stabilized a little bit, BP's picked up a little bit. And once the BP a little bit came to 60, 70, that's the time I took this most riskier thing, that I pulled out the diagnostic catheter with an extension wire of the normal guide wire, because I had a normal length guide wire that was 175 centimeters. That's the reason I asked you. You must be aware of what is the sizes of the guide wires are. So it was a 175, but eventually I had an extension thing, so I could extend it with another connector BMW wire, and then made it 300 centimeters. What we did is we removed the diagnostic catheter completely and took the stent on the wire. And now you will ask me, how did you deploy it? Okay, because again, how can you deploy? Which place you can deploy? Because there is no way you can take an injection. So again, fortunately that day my starts were good. what I did is I told my technician and sister and everybody not to move a single millimeter also anything. So we have taken one particular place in AP Caudal, I fixed the table, did everything, took 2 bony landmarks, took the stent, deployed the stent, and after that took a diagnostic catheter. It was pretty well placed and I could save the patient. So anyway, so point is that the simple things of knowing the internal diameter of the diagnostic catheters and guiding catheters has helped me to come out of that crisis. So I request all of you spend some time on basic designs, basic structure. What are the different types of stents that you forget it? Because I said every company fellow will come and brainwash you and you will become very expert in that. But knowing the basic things are very important. Thank you so much. So again, we'll have a query, question answers later only. I request Rishi. Oh, he's not there?
Sure.
In the meantime, you can go with the question answers if he's coming. Pass the mic. Okay, so I don't think so there are any questions there. Yeah, go ahead, please. Somebody is raising the hand. Go ahead.
Please.
Hello, sir. Hello.
Yeah.
Sir, in last case, that problem was we can't able to identify where the site of location. So you said he stabilizes the table not moved. In that case, we can take other actions and pigtail catheter to take a shoot.
I'm sorry. Can you repeat your question, please?
The last case, via guide wire we passed this stent. So the problem was to identify where to deploy the stent.
No. So basically, the problem was not there. There was no guide which was getting cannulated there. So
That's true. But we are not able to give injection.
Yeah.
So it is possible via any pigtail we can take aortic root shoot with other actions.
Yeah, basically there could have been so many other things. See, another thing is that, you do a radial artery puncture and then take a diagnostic catheter and do that. Okay. But the problem is all those things when the patient's BP is 30, 40, you really can't do all those things. Okay. So at that moment of time when the stent is already gone, because I did a POBA initially, it gave me just a 5-7 minutes of time where we could remove it. But again, going there and doing a puncture with the radial artery left side or radial side, and by the time I cannulate, I lose the patient. So I had no other option but to go ahead with that. Okay. Okay. So thank you so much. Now moving on, my close friend Rishi is coming on clinical of precordium in a cardiology case. Probably his style is different. So please come. Rishi.
Okay, so a very good afternoon, all of you, friends. Thank you, sir, and my teachers for giving me this opportunity to discuss clinical cardiology with you all in the examination of the precordium. Now, you have to face this talk after an interesting talk of interventional cardiologies, which is thrilling and exciting. And it's the siesta time, post-lunch. So my job would be to keep you awake first for the next 50 minutes. And if I can do that, then probably rub in a few points that you can take back home and benefit a little bit in your clinical examination. So for the first thing, I would like to have a little survey of what the audience is like. So how many of you are first year or second year DNB students? Can I have a raise of hands, please? First and second years. And how many of you are exam going final year DNB students? Great. So can we have one from this table? One from this table? Anyone? I would like 5 final year students who think would like to interact a little bit more, because it will be difficult to interact with the entire audience. So that would be a sample. So we can have any 5 final year students who can come here. We were just discussing, and so that we don't sleep in between the lecture. It's a long lecture. Anyone? No, it's not a test. It's not an examination. Please come on. Oh, all 5 from this table. Don't. Anyone can pick up. It's not going to be a test. It's going to be just a question. So as to allow me to assess what is your knowledge level from which to go high. Great. Great. So I've been given, my time was actually 50 minutes. So if you can reset the clock, that would be. Yeah. So where are you guys from? Which is your institution, please? Arna, Delhi.
Kengalpattu Medical College. Kengalpattu Medical College.
Great. Same. Okay. You can have one more chair. Any lady? Any ladies? Anyone from the ladies final year? Let's have a good cohort. Come on, anyone. It's not going to be a test. Okay. So what I will do is that apart from talking about Precordium, I would just briefly go to what should be the construct of your final year long case, because that is the time, if we have, especially the first long case that we are going to get, generally we get 2 to 3 cases in our examination. But if the construct on a lot of people and almost everyone go on to make the same kind of mistakes, and which we see repeatedly over years. So based on my past experiences, I would try to hit those points. And before Precordium, I would like to take you through. So today, as part of my main presentation, we'll be talking about inspection and validation of Precordium. Then we'll be going to auscultation, the heart sound, murmur, the clicks. And then I would be briefly touching upon dynamic auscultation. So dynamic auscultation is a separate talk. I remember last time I was in Hyderabad for case the examiner, dynamic auscultation was an individual talk that I took. So I would be speaking on dynamic auscultation, the salient features in the end. So whenever you are going into the final year of your examination, remember, almost all of you know the diagnosis of your case before you even start to examine your case. And that's really a tragedy, and that's really a trap that I would advise not to fall into. Start with an empty slate. The examiners are not testing you in whether you are able to make the diagnosis or not. They want to know what is the construct of your mind in order to reach that diagnosis. How much academic investigative your mind is in order to reach the diagnosis, so that you can do it predictably over the next many years that you are supposed to practice, and not just make one diagnosis in clinical case. So that's one thing. So at least try to start as clean as possible. And whenever you reach to Precordium or history, Precordium examination, remember you have already gone through history, differential diagnosis, general examination, and the examination of pulse, JVP, and DNB. So take the whole picture into construct. Whenever you reach the examination of the Precordium, don't forget about what your history was, or what your general examination was, or what differential diagnosis that you were considering, or what were your pulse, BP, and JVP findings. So as part of your cardiology case, pulse, BP, and JVP should not be a part of your general examination. Your examination should be consisting of general examination. Examination of pulse, BP, and JVP should be the middle part, which should be very important. And then you could move on to the Precordium. So whenever you reach a Precordium examination, try to keep the entire building that you have been constructing, and then do the Precordium examination in that background. Do not go on one fancy small finding that you get in your auscultation and try to try to give too much weight to it and ignoring all the other directions, all the other things that were pointing in a different direction. So of course, sometimes we are trapped that, okay, we have found this finding that, there's a paradoxical split and nobody else has picked up the split. We get so obsessed by it that we fail to see everything else. Do not fall trap to try to impress your examiners by one single very highlighting feature finding that no one else has picked up, whereas missing the entire picture in between. So you should keep the hard points in clinical examination, give them more value than a soft, fancy finding. These are common mistakes which everyone is doing. And then many a times when you are going in your examinations and there is a difference of opinion, your examiners will say something to you as a joke or a suggestion. It's a sign that they want to shift the conversation to a different direction, but we are so obsessed with whatever we have learned during the examination of our case, and we are very sure that the diagnosis is right because it's already been told to us by our friends. We fail to pick up those hints, and then things start to go messy. So whenever an examiner is suggesting you something, okay, you can have your firm point of view if you are confident, but try to listen to the hint that is given to you and then take the conversation in that direction. So these are philosophical points general for the place. Coming on to the examination, before I come again to the precordial examination, I would briefly talk about a general examination. And that, whenever you have to describe pulse, general examination, JVP, apex, epical impulse, epical beat, then you can have try to remember to say normal things. If you have to describe the normal JVP, try to memorize in your mind how will you say that normal JVP. Because whenever you say a normal JVP, examiners may get offended. You have to say JVP is normal in height and waveform, normal respiratory variation, and the pathogen. So similarly for pulse, and similarly, if the general examination is normal, no point stressing about what is the BMI, what is the socioeconomic class, lying lateral. Nobody is interested in that. Everybody is interested in coming to the findings. So learn to speak something in both in completeness as well as speed, so that you have said everything that is supposed to be said, but you have not wasted your time too much on nutrition, on height and upper body, lower body, and arm span, until and unless it is relevant for the case. For example, if the general examination is normal, you can go away by saying there is no pallor icterus edema cyanosis clubbing, there is no hepatosplenomegaly, abdominal system, respiratory system, musculoskeletal system examination is within normal limits, and you are done. So you can get over this normal general examination in saying one single line: no pallor icterus edema cyanosis clubbing, no hepatosplenomegaly, abdominal system, respiratory system, musculoskeletal system is within normal limit, fundus findings are normal. It's complete, and don't waste time before you quickly move on to the more interesting things. Of course, if there's something abnormal or some relevant to the case in that examination, then of course you will have to give it due recognition and time. Okay? Right. So coming to my talk per se, the next 40 minutes or so about precordial. So what do you understand? I mean, the first point I wanted to discuss, if someone has a precordial pulse, inspection and palpation are supposed to be spoken together. What do you understand? You say there is a bulge at the epical area.
The cardiac chamber enlargements.
Huh?
Enlargement of cardiac chamber.
How many chamber enlargements? How many LVH? How many RVH? How many left atrial enlargements have you seen that have produced bulge in precordial? Anyone? Please speak in the mic.
Precordial bulge seen in frontlet.
Mic.
Shunt lesions.
Shuntly. Okay, so always remember that chamber enlargements will not produce precordial bulge until and unless they have present before the fusion of the costal cartilages of the ribs, which happen at the age of 8 to 10 years. So if the chamber enlargement is happening, like might happen in the shunt lesions, if the chamber enlargement is happening before the age of 9 years and 10 years, then there is a chance that the chamber enlargement can produce a precordial bulge. After that, precordial bulge is never produced by chamber enlargement, although they can be produced by aneurysm of the vein artery, by tumors, by other things, but chamber enlargement will not. So if you are getting a cardiology case which is not a tumor or not an aneurysm kind, and you are getting a precordial bulge, it means that the chamber enlargement was present before the age of 9 to 10 years, and that will give you some sense of idea what was the onset of the disease and what has been the course of the disease. So very, very important. Can anyone in the audience tell me what an apex beat is? Define an apex beat. What is the definition of an apex beat?
Lowermost and outermost point of definite cardiac impulse.
Perfect. The first time in my life I've heard someone to describe it. So it's a, and can you describe it in more detail? What are the qualities of apex beat? How is it defined as? Other features that you say?
So whether it is tap type, hyperdynamic or T type,
Area.
how much is the localized area covered, and whether it is confined to a single
Area. So how do you define diffuse versus localized?
If it is more than 1 process.
Exactly. So that was the point I wanted to highlight, the gap in the nomenclature I wanted to highlight. Now come back. You said apex beat can be diffuse if it's more than 2.5 seconds. Okay. Come back to the definition of apex beat. What did you say? Speak loudly to everyone.
Lowermost and outermost point of
point. How can point have an area? Mathematically, point can never have an area. Always remember, in your description, in the palpatory findings of apex, describe apex beat and apical impulse as different entities. Apex beat is the lowermost and the outermost point of a definite cardiac impulse, and it tells you only and only whether cardiomegaly is present or not. You can go on to extend that if it is lower and outer, then it is probably LV, and if it's only outer RV, but might as well don't say. It is just telling you whether cardiomegaly is present or not. All the other features that are described are a part of description of apical impulse, whether it is forceful or not, sustained or not, diffuse or not, and what are the other accompaniments. But apex beat is only and only telling you about cardiomegaly is present or not. Okay? So define apex beat and apical impulse in a little different settings. Many examiners do not notice it, but many will try to catch it on this point. So that is another thing. And then of course you can describe it in the pulmonary area. You can have a palpable pulmonary artery or a palpable P2. Again, a lot of time children get confused here. Palpable P2 is a palpable sound of the pulmonary vascular closure. It is tapping in nature. It is never visible, while pulmonary artery pulsations are more diffuse. They are visible also sometimes. So you can differentiate between palpable P2 and palpable pulmonary artery pulsations, both of which might have different connotations in your clinical examination. And then, of course, parasternal area. Again, an area of confusion, because parasternal area, the right way is to see the elevation or the feeling of the edge of your hand, keeping your elbow straight so that your shoulder is acting as a fulcrum. If you feel the impulse, but if your hand is not raising, it is grade 1 impulse of RV. If it raises your hand, but you can suppress that impulse, it is grade 2. If it raises your hand and you cannot suppress it, it is grade 3. Sometimes grade 3 impulse, some examiners will say as RV heave, while sometimes some other examination will grade 2 and 3 both as RV. But again, you can, to be on the safe side, don't say heave, say grade 1, grade 2, or grade 3 RV pulsations. And another pulsation that you can feel in the parasternal area, in the right parasternal area, is the LA pulsation. To differentiate between LA and RV, RV will come with the apical impulse, and LA will come at a gap of apical impulse. And then after relaxing the abdomen, you can look at the epigastrium. The two things you are looking for again is an RV, which you feel at the tip of your finger, and aorta, which you feel at the base of your finger. So all these things are important for inspection and palpation. Again, a normal, very, 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 very important point, because by the time you have completed, I would say, everything that is supposed to be told by this slide, I would say that you should have your diagnosis. By the time you are through with your history, the interpretation of your history, asking provocative questions about differential diagnosis and ruling in or ruling out differential diagnosis, after your general examination, after the examination of your pulse, your JVP, your blood pressure, and your apical area, and all the pulses, you should have your diagnosis. You only confirm your diagnosis by stethoscope and try to find out additional findings, but the predominant core lesion should be there. So that's why this slide is very important, and this is why part of that slide is given. So again, how do you define a normal apex? Any one of you? I'm using them as sample because it was difficult to write.
The normal apex is outermost in the outermost lowermost point of the palpation.
Normal apex feet.
And
Yes.
apical impulse is just 1 centimeter internal to mid clavicle line, or just immediate.
No. Apical impulse, you have already told about. The first line I have written in red is for apex feet, because that the location is defined only by apex feet. Now you're coming to apical impulse. What are the 3-4 headings in which apical impulse is described?
So first is the location.
Not location. Location we have already explained to you again and again. Apex feet, the location is
Duration.
over.
Duration. Sir.
Duration. What is the normal duration?
It's less than half of the C2.
Okay.
Less than 50% of the C2. Then is the area.
Area.
Then is the
How much is the normal area?
The normal area less than 2.5 centimeters square.
Less than 2.5 centimeters and only occupying 1 intercostal space. If it's more than 2.5 or more than 1 intercostal space, it is diffuse.
Then it is RV type or LV type.
Forceful. Forceful. Force, is it forceful or not?
It's sustained.
RV and LV, I would advise you, not to go too much into detail. Of course, if there is a medial retraction, you can say it is LV. If it is medial, is moving, the entire thing is moving, you can say RV. But generally, apical impulse is described as forceful or not forceful, sustained or not sustained, localized or diffuse, and whether diastolic events are any thrill or any S3 or any S4 are palpable. Okay, systolic or diastolic. Any thrill or any diastolic events are palpable. Fine. So now coming to this combination, this thing which is hidden. So let's talk about 4 combinations of force and sustainment. You can have a normal force and not sustained. You can have forceful but sustained. I can't say it. Then you can have forceful but not sustained, forceful, sustained, not forceful, sustained. Now fill in the blanks on the right side of the screen. Who's going to do that? Anyone can do that? What do these 4 combinations mean? Because this will actually, by the time you finish this, your diagnosis should be with you, at least in rheumatic heart disease. Anyone? Yes, please. The guy in the green shirt. Yes. Let's start from the first. Let's follow some order. Normal and normal. Not forceful, not sustained. Give me the mic, please. Not forceful, not sustained. I will make your life easy. The normal type. Normal. Okay. Come to forceful, but not sustained.
Forceful and sustained is the LV.
No. That you are telling me, but I am asking you, what is the second line? Forceful but not sustained.
Is a hyperdynamics. Hyperdynamics.
Okay.
Forceful and sustained is the hypertrophic, concentric, heaving type. Heaving type, sir.
What does it show? What lesions will it signify?
Concentric LVH. LVH, concentric aortic.
Pressure will LV outflow obstruction. LV outflow obstruction, force pressure on the load. And then what is not forceful but sustained? Heaving. Inflow. Inflow. That's the game. That's the catch. Any one person stand up because yes, please. Great. LV dysfunction, that's great. That's great. So the point is that whenever you tend to memorize it, you will forget again. Now you have to go, why do we feel an epical impulse? Why do you feel an epical impulse? In which phase of cardiac cycle do you feel a epical impulse? In the isovolumetric systolic phase, we feel the isovolumetric systolic contraction. The isovolumetric contraction. So what happens? Your both mitral and aortic valve are closed. The ventricles start to contract. There occurs the epical impulse. Now there's the ventricle has blood, but it is contracting, but it can't flow the blood out. So it will go to a torsion force and you will feel the epical impulse. As soon as the aortic valve opens, all the blood will gush out into the aorta and the ventricle will go away from the chest wall. That is why it is only felt in the first 1/3 of system. Up to half is normal. Beyond half, you say it is sustained, but it is generally felt in the first 1/3 of system. So anything which prolongs the opening of the aortic valve, for example, LV outflow obstruction, will cause a sustained apex. At the same point of time, if LV takes longer time to generate pressure to overcome the aortic pressure, if LV takes a longer time to generate sufficient pressure to overcome the aortic pressure so as to open the aortic valve, again, the apex will come and it will take a longer time to go away, but it will not be forceful because LV dysfunction. So LV dysfunction will give rise to a not forceful but sustained apex. Now you have imagined you have seen your pulse, you know your JVP, you have a hyperdynamic pulse, you have white pulse pressure, you have Corrigan sign positive, and then you get an apex which is forceful and sustained. Theoretically, it should have been a non-sustained because of an AR situation. That was you were expecting. But now you get a sustained apex. The interpretation can be only two. You have a significant aortic stenosis attached to it, or the AR is now going into LV dysfunction. Next, and the location of the apex will also guide you whether epical beat will also guide you whether cardiopulmonary is present or not. So that's why I'm saying that if you have your pulse, your BP, your history, and your precordium examination by palpation, and you have seen your apex beat and epical impulse, your diagnosis should be with you with a reasonable level of certainty. Are we clear up to now? Do I have your attention? Yeah? Okay. So here is it. Not forceful, not sustained is a normal epical impulse. Forceful but not sustained is a hyperdynamic condition, any hyperdynamic condition, the prototype being AR. Forceful and sustained is generally LV outflow obstructions, and not forceful but sustained would be LV systolic dysfunction. Okay. So if I had your attention to here, let's move on to now you have your diagnosis and you want to kind of pick up the stethoscope and do some fancy work and try to confirm your diagnosis. We will discuss about the hard sound, we will discuss about clicks, we will briefly touch upon them. So, whenever we talk about S1 and S2, in generally speaking, no one talks about splitting of S1 and M1 and T1, but splitting of S2 is important. In first hard sound, generally it's the loudness of the first sound that is taken into consideration in the examination, and that loudness is dependent on a lot of factors. That loudness is dependent on the structural integrity of the mitral valve. If the mitral valve structure apparatus integrity is suffered, if there is caudal rupture, if there is heavy calcification, if there is infective endocarditis on the mitral valve, then the S1 will become soft. For the time being, I'm focusing S1 for the mitral valve only on M1 because T1 is significant only in certain rare conditions. But let's focus on the closure of the first heart sound for mitral. It also depends very, very importantly, and almost always you get cases and combination of mitral stenosis. So it will depend a lot on the position of the mitral valve at the onset of the ventricular systole. In mitral stenosis, there is prolongation of the flow. The mitral valves are wide apart during the onset of ventricular systole. They come back with a force, and the mitral valve is thickened, it's fibrosed. It produces a larger sound because it is far away during ventricular systole, and when it comes back to a longer distance, it produces a larger sound. It is also dependent upon the flow across the mitral valve, or flow across the valves. For example, in ASD, there would be a loud T1 component because there is a lot of flow across the valve. Again, the valve would be open, a lot, wide open at the onset of the ventricular systole, and it will come back with a longer duration, longer distance, and therefore it will produce a larger sound. And the same thing will happen with shorter PR intervals. Long PR intervals and premature closure of mitral valve, as would occur in acute ARs or sometimes technical ARs or LV dysfunction, will stop the S1. It will also depend upon, there are so many factors in this. And why there's so many factors are important. Suppose in a case of mitral stenosis, you are hopeful of hearing a loud S1, but you are not hearing a loud S1. So we will have to think of all these things, that these things might be an additional finding there. There may be an associated AR, there may be heavy calcification, there may be some degree of mitral regurgitation also, which is helping us. So all these things you need to construct and bring into the focus and bring into the collaboration. So all these things are important. So another factor that governs the loudness of the mitral valve is the or the first heart sound is the integrity of the isovolumetric contraction. If you have an associated VSD, if you have MR, if you have LV aneurysms, then this isovolumetric contraction phase is compromised, and it will produce a softer S1. Of course, it also depends upon myocardial contractility and heart rate because of so many of these combinations of these lesions. Coming on to the nemesis. The nemesis is actually the S2. So S2, unlike M1, is to be this. S2, unlike S1, needs to be described not only on the loudness, and loudness here is to be described, loudness of both the components need to be discussed. It's also very, very importantly, it has to be discussed in terms of the splitting. So we have to, the first thing, can anyone describe why P2 comes after a gap? Why there's a gap between P2? There's A2 P2 combination. Why P2 comes a little late? What's the concept of hangout interval? Anyone? Yes, please. So what do you mean by hangout interval? Right, absolutely right. So these things depend upon the compliance of the vascular structure. Remember that the left and the right side of heart are pushing equal amount of blood. But systemic circulation is distributing in a much larger area. whereas the pulmonary circulation is a very localized circulation, handling the same amount of blood. And to handle same amount of blood in a smaller area, in terms of in gross area, your blood vessels need to be much, much more elastic. And the S2 of the individual side, A2 and P2, does not happen at the crossover between the pressure of whenever the aortic pressure will overtake the ventricular pressure, the valve should close. But actually, A2 and P2 will happen after a little lag of this crossover time, because you need the point of the hangout interval, and of course there is the valves in a dynamic motion forward. It takes some time to come back and close. So the actual closure of the valve will happen sometime after the pressure crossover between aorta and or the great artery and the ventricle. And the absolute definition of hangout interval, and that's why the compliance is larger, and the absolute definition of hangout interval is the time distance between the pressure of the ventricle and its great artery at the level of incisura. So the hangout interval of pulmonary circulation is longer. It takes longer for the pulmonary valve to close to produce P2. So A2 will come first and P2 will come second. That's why there is a gap. So what are the features? The most important feature that governs the loudness of A2 and P2 is the pressure of the great vessel beyond the valve. The aortic pressures almost always would be higher than pulmonary valve. Therefore, A2 will almost always be higher, louder than the P2 component. So in A2 and P2, remember 2-3 things. First, A2 will, of course, we're not talking about pulmonary hypertension severe times, but A2 is generally louder than P2. A2 comes before P2. A2 is louder than P2 even in the pulmonary area. Remember this fact, and it will be helpful to you. A normal P2 is not heard away from the pulmonary area. If you remember these 4 things, how will you define by the loudness of your P2 component or A2 P2, mild, moderate, and severe pulmonary arterial hypertension? That's my question to you. How will you do a clinical examination and say that this pulmonary arterial hypertension is mild, moderate, or severe based upon the auscultatory findings of P2?
The loudness of P2 is more at the elevated P2 is severe.
Excuse me?
The loudness of P2 is very weird at the apex. It can be said as severe pulmonary artery.
No. And mild, moderate, severe, how do you? So we may have one answer, but until and unless you have a continuum of how to describe mild, moderate, and severe, of course, there would be other signs of pulmonary artery heave and a TR and a PR, everything else. But based upon P2, how do you say that?
P2 is very weird at the apex.
It just means, and what is moderate then? I'm asking you to classify it on mild, moderate, and severe. Anyone? Anyone? Yes, please. No, one person.
Sir, if P2 is equal to A2, nearly equal is equal to A2, it is considered as mild. If it is louder than A2 and there is narrowing of the splitting, it is considered as moderate. And if it is loud and banging and there is no splitting, which is appreciable, it is considered as severe.
Yeah, so there's 2 ways you can describe it. As I said, even in pulmonary area, A2 is louder than P2. So if A2 becomes equal to P2, it says that it is a loud P2. If it becomes louder than A2, then at least it is a moderate degree of pH, and sometimes very loud with the retrograde masking when it finds it difficult to hear an A2 in the pulmonary area. Of course, splitting we will come to a bit later. Then that is the one way of saying whether it is mild, moderate, or severe. Another way of saying is, if you have a loud P2 that is equal to the aorta,
aortic sound in the pulmonary area, but it is heard only in the pulmonary area. It is mild. If you start to hear your P2 anywhere between apex and your pulmonary area, anywhere away from the pulmonary area, it is moderate. If you are hearing a P2 at your apex, it is a severe form of PAH. And therefore, if you hear a splitting of sound at the apex, it automatically means you have severe disease of pulmonary arterial hypertension. Am I correct? So you can take it both by the loudness in the pulmonary area in comparison to A2, or you can see how far away from the pulmonary area you can hear P2, and then you can say that it is loud, it is mild, moderate, or severe hypertension. Now the splitting. So for splitting, we all know that A2 comes first and P2 comes afterwards. For anything to make this splitting longer, you will need either the aortic sound to come before, or you will need pulmonary sound to come later. There can be electrical causes for it, and there can be mechanical causes for it. The pulmonary sound will come later in right bundle branch block. The aortic sound will come early in a left ventricular beat. So in electrical activities, ectopic beat. So LV ectopic or right bundle branch block, both will cause widening of S2. Similarly, if you have increased flow across the pulmonary valve, it will take a longer flow, so your P2 will start to come later. So for example, ASD, pulmonary stenosis, right ventricular failures, your PT will be delayed and you would get a wider gap. And similarly, in mitral regurgitation, you have ejection fraction, you have blood going, so the aortic sound will come early, so you will have again a widening of S2. Am I with you all? Am I with you all still? So similarly, for the splitting to become narrow, you would require either the aortic sound to be delayed or the pulmonary sound to be early. So you can have left bundle branch blocks or the right-sided ventricular beats. Or you can have aortic stenosis and LV dysfunction. The same things you were applying for the right side, apply for the left side, AS, LVF, and you can, and similarly TR, for MR was there, TR was this side. So these will come a normal, narrow splitting or a reverse splitting. Now remember, narrow and reverse are a continuum. You have a narrow splitting, then it becomes a single S2, and then it goes away and becomes a reverse splitting. And how do you describe that? How do you describe a normal splitting, a wide and variable splitting, a wide and fixed splitting, single S2, and paradoxical splitting? Anyone? This is a little tough one.
Sir,
yes.
In normal splitting, sir, on expiration there is only one sound. In inspiration, both A2 and P2 are audible.
If you hear splitting only in inspiration and not in expiration, it is a normally split sound. Great. Normally split.
In wide and variable, both in the expiration and inspiration, A2 and P2 are audible. But the duration is variable, sir, in the inspiration and the expiration. In inspiration, duration increases, sir.
Very good. So you hear splitting in both the cycles of respiration, but in inspiration, it is longer, and in expiration, it is shorter. Great.
In wide and fixed, sir, split is present in both inspiration and expiration, and duration is fixed, sir.
Perfect.
In single only S2 is heard, sir. A2 and P2 are
both the phases of respiration, you hear only one sound. Yes, sir. And what is the reverse of paradoxical splitting?
In paradoxical split, sir, in inspiration only single sound, and in expiration both P2 and E2 is audible.
Perfect. Perfect. So in expiration, you will hear the splitting, but in inspiration, you will not hear the splitting. And of course, the examples of wide and fixed splitting are ASDs and why does it happen? Why does fixed splitting? Why does it happen in ASD?
Fixed, sir, because the respiration variation is not able.
So the right side, it's already so much volume is flowing in
that a little bit of respiratory changes are not appreciated here, and similarly in the right heart failure. And what are the examples of singles thing, apart from the fact that single S2 may be a part of continuing of narrow A2P2 gap, which have become now fused and it has become single, while a single S2 happens also because of many other reasons. You have only one valve, for example, truncus. You have one valve which is atretic, for example, pulmonary atresia. You have a posterior position of the valve, so you can only hear one sound, for example, transposition complexes. And sometimes one heart sound may be so loud that you cannot hear the second heart sound. And that is called as a phenomena of retrograde masking. And that also is one of the causes. So single S2 has got multiple reasons. Many a times when we are not able to appreciate the splitting, we go on to commit that S2 is single. It is much sensible to say that I cannot appreciate splitting rather than saying it is a single S2, because then you will have to come down to one or the other reason why you are saying. If you are not able to appreciate it, say to your examiners, I am not able to appreciate splitting of S2, but that would be a saving grace. But if you commit that it's a single S2, you will have to give one or the other of the explanations, and then you might be in trouble. Okay? Thank you. Great answer. Coming to the S3, the S3 and S4 are diastolic events. These diastolic events generally are low-pitched events. They are sometimes better felt than heard. And from a point of view of teaching, they should be actually seen first whenever you pick up your stethoscope. Because it is easier when your ear starts to hear louder sound, it becomes very difficult, to appreciate these low-pitched sounds, which are softer in nature. So, I mean, if you are suspecting, try to hear for these low-pitched sounds first, and then then focus your attention and your mind on the other things. There are many theories of S3 and S4 formations. Of course, the most common theory is vascular theory. S3 will happen in the first phase of diastole, when there is a gush of blood, and the blood will, strike. So anything, the ventricle wall, and anything that leads to an increase in the flow and hyperdynamic circulation will lead to an S3 formation. Left-sided, of course, is better heard. Left-sided S3s are better heard at apex. No effect of his respiration. Better heard in the left lateral position and associated with the left-sided murmur, while right ventricular S3s are in left parasternal region. Increase on inspiration. They will increase when you have your passive leg raising, and they are associated with the rise of the JP and the right-sided murmur. The causes are many. We all know about it. Physiological in children, young adults, pregnancy. There may be S3-like sounds, which are tumor flops and pericardial knocks. And then, of course, there may be pathological because of the ventricular failure or because of any situation that leads to hyperdynamic circulation. And you all are well aware what are the situations that produce hyperdynamic circulation. The S4 is produced in the third phase of diastole, that is the atrial contraction phase of the diastole, and you need to have 3 prerequisites to have an S4. You should have a sinus rhythm. They will never be held in atrial fibrillation, a mistake many a time people make. They will not be heard if the AV valve is stenosed, and they need a non-compliant ventricle. So they are commonly seen, normally sometimes. One school of thought says that S4 is never physiological, but of course, S4 is heard in older individuals, hypertension, aortic stenosis, and all the features that lead to non-compliant ventricular wall. Clicks are sounds that are produced either by valvular apoptosis or by dilatation of great artery. Rarely nowadays in clinical examination, but still of some theoretical value. Vascular clicks are generally louder, and when we talk about the vascular clicks of pulmonary artery, you may feel the pulmonary artery pulsations. Valvular clicks are generally softer, and when you talk about the aortic vascular click and pulmonary vascular click, the one thing that is asked sometimes in examination is that if your click is variable on respiration, what does it mean? What does it mean? So vascular clicks that are originating in the great arteries by the dilatation of the great arteries are never variable with respiration. Your valvular clicks can be of different intensity during different phases of respiratory cycle, but that phenomena is limited only to the right side of the heart, meaning pulmonary valve click may be variable on inspiration, but aortic valve click will never be varied on respiration. And if anyone can tell me the explanation of that, it will be an icing on the cake. Yes, please. The hangout interval guy, huh?
Hello. Sir, in case of pulmonary ejection click, during inspiration, the inflow increases, and as such, the pulmonary valve is opened in the late diastole only. So when it comes to open in the systole, the leaflet have to cover a short distance as compared to the normal valve. That is why the ejection click becomes softer in inspiration. No, sir. So basically, inspiration increases the right-sided inflow. Right-sided preload is increased with inspiration.
More important, in cases of RV failure, with inspiration, you get more blood volume. And transiently, during the end of that inspiratory phase, you may have a situation where your RV end diastolic pressure is a tinge higher than your pulmonary RV diastolic pressure, and your valve slightly open. And because of that valve opening, the click becomes softer on inspiration. There is no way LV and diastolic pressure can be higher than aortic diastolic pressure. Okay? You guys get it? I mean, it's impossible to go into the murmurs in detail because each of the murmur will have different characteristics. Each one will have different severity criteria. The time cannot allow that, certainly. But these are from my DM notes as I classified the murmurs, and of course, not my classification, but as I tried to remember them, two things I want to tell you. Always describe the murmur in relation to the heart sound. You end up saying it's an early systolic murmur. And then when someone asks, what is the early systolic murmur? Why you are saying it's an early systolic murmur? You are clueless. If someone says it's an early diastolic murmur, what does an early diastolic murmur mean? My guy in black shirt, yeah. Yes, you. What does early diastolic murmur mean? No. Guy in front of you, yeah. Exercise a bit. Early diastolic murmur, what is early diastolic murmur? Early diastolic murmur is heard in AR, right? What is an early diastolic murmur?
Start immediately after S2.
So always describe 1/3 of the diastole is the length. What does early? Huh?
Start after the S2.
Starts with the S2 and
just at the one
and before S1. Anything ends before S1. As I said, time your murmurs according to the S1 and S2. You can't describe the timing because it may be different in the severity of the aortic regurgitation. Any murmur that starts with S2 and ends before S1 is an early diastolic murmur. Similarly, what is an early systolic murmur? Let's start with S1. Hence before S2. Brilliant. So simple. Give me examples of early systolic. 5. I know. That's what I was asking. It's very important because someone raised the question of the organic tricuspid leak versus the physiological tricuspid leak, in the early one. There are no 5 causes. There are only 4 causes. When you are committing an early systolic murmur, you're only talking about these 4 things, nothing, no 5th. MR is a pansystolic murmur.
Yes.
Huh? Okay. So, of course, you have a very small muscular VSD that closes on in the late phase. It's the early systolic murmur. You have a very large VSD, which has got produced PH now. The PH does not allow the pressure, a continuous flow in the entire phase of systole. You have an early systole and then it closes. The murmur shuts down. You have an acute mitral regurgitation. The LA cannot dilate so much to take blood throughout the diastolic. You have an early, and you have an organic tricuspid valve disease, which is again an early systolic murmur. It is non-pansystolic murmur. Pansystolic murmur means that the pulmonary artery pressures are elevated. And therefore, it's a secondary TR. There are only 4 causes. So always describe your murmurs. What is the ejection systolic murmur? The guy in the check shirt down. Yes, you. How do you describe an ejection systolic murmur? Describe it in relation to heart sounds. And not of the, I don't know what isomer I'd have. What is it? What is it in relation to S2? S1 and S2, both you have to describe. Okay, it will start after S1 and it will end before S2. So that's why you have to. Continuous murmur is not the same thing as to and fro murmur. Continuous murmur is something that will engulf your S2 completely and not the 2 phases, not the seesaw murmur. It will engulf you. So continuous murmur can be described in such a way. So that's what I want to say, that always describe your, whenever anyone asks you, why do you say it's a, until and unless these are very simple things. This is not a rocket science, very simple thing. Describe your murmurs in relation to your S2 and S1. And all of them will have one definite explanation or one definite definition. And follow that construct and you will know what it is. Should I carry dynamic auscultation? Sure. I'll take dynamic auscultation. I'll just take briefly, in terms of 2-3 minutes. I think my time is up. But these again are my DM notes from 2004. My first DM lecture, first DM case the presentation in seminar. 20 days after I joined my DM examination was dynamic auscultation. That's why I love this talk. It is the technique of altering circulatory dynamics by physiological and pharmacological maneuvers and see their effect on heart sounds and murmurs. Remember, do not do dynamic auscultation in clear-cut murmurs which are loud, clear, and visible. Don't say that you have a very good mitral regurgitation murmur or aortic regurgitation murmur and then say, oh, it is best heard in the those are MBBS and MD things. If you have a clear, full-blown, severe murmur, well heard, no need to do it. It is only for faint murmurs and heart sound where you want to differentiate one situation from another, or you want to accentuate that heart sound and murmur. It is only for doubtful situations, not main situations. Learn how to do the right way, because sometimes you want to impress the person. Okay, I did Valsalva and I saw this, and the examiner asks, how did you do Valsalva? You have no clue. So learn to do the right way. And of course, in the days of echocardiography, it is not needed. Still, it is needed to pass your examination. And at least the understanding of dynamic auscultation tells you much more about the circulatory physiology, so that you are well adapted to answer other questions. So if you have reached dynamic auscultation, it means you have known the circulatory physiology in greater detail, and therefore you will be better. So many dynamic auscultations, how to do it? Club them first. Valsalva is equal to sudden standing. They are same thing. You get same finding. Muller's maneuver is equal to passive lead-in. You get the same findings. Club them together, correct? And then you can do squatting. No one does isometric exercises. You must know the technique, really useful. Amyl nitrate, never has any one of us done, but you must know because it gives you a differential diagnosis of a couple of things, at least theoretically, you could have asked. You could be asked. So theoretical exact way is to, for do Valsalva, is to push into a manometer and maintain a 40 millimeter pressure for 20 seconds. Maintain the 40 millimeter pressure for 20 seconds. Of course, it can be done in the other ways that you can go back and read. And remember the changes there, it is divided into 4 phases. Anyone knows the 4 phases of Valsalva? Okay, so the first, I said, sustain the pressure on the manometer for 20 seconds. The first 10 seconds is the phase 1. The next 10 seconds is the phase 2. As you end the 20 seconds, that's the phase 3. And a few seconds later is the phase 4. In phase 1, you have suddenly blowing it. There is increase in the intrathoracic pressure. So your aorta also gets pressurized, and you have a raise in the BP and the fall in the heart rate. But then, because of the sustenance of the pressure for the next 10 seconds, you get low venous return, and then both your right and the left side heart start to receive less blood, and your blood pressure goes down, your heart rate goes up. As you release, theoretically, you expected the BP to go high, but it doesn't happen because the pulmonary capacitance suddenly increases and all the blood get accumulated in the pulmonary area. So again, you have a sustenance fall of BP and increase in the heart rate. And then there is a sympathetic overshoot in which your BP rises and your heart rate falls. So this is something that you get in the top panel. You have a raise in the BP, then you have a fall in the BP in the second phase. You have the further fall in the BP in the third phase, and then you have a systolic overshoot. It doesn't happen in something which is called as a square root response, where your BP tends to rise and it remains elevated in the phase 2 and phase 3, which happens in cases sometimes with ASD, and it becomes that. So how, of course, the correct way you have learned, the correct responses you have learned. I think we've gone too long, and we lost of interest. Okay, so just remember that in Valsalva is equal to sudden standing, and Muller's, which is deep inspiration against the same close blotted, and the passive leg raising are the same, will produce the same thing. The only time they are generally used in the cases of HOCM and MVP. The murmur of HOCM will become louder while doing Valsalva, and MVP murmur will get longer while doing Valsalva. And these changes are seen in phase 2 of Valsalva, which is done. I would just come to the amyl nitrate. Amyl nitrates leads to, you can differentiate a couple of things. You can differentiate mitral stenosis from Austin Flint murmur. Austin Flint murmur, because of AR, will decrease on amyl nitrate, while the mitral stenosis murmur will increase. TOF murmur, because of amyl nitrate, more blood will start going into aorta, more right to left shunt. So therefore, the murmur of the pulmonary area will decrease. The TOF murmur will decrease on giving amyl nitrate. HOCM murmur will increase, and AR will decrease, but there will be no change in pulmonary evacuation. And of all the dynamic auscultation, it is only the right-sided changes, Muller's maneuver, or passive leg raising, or deep inspiration, that have got more significance, and other things are scientifically not much valuable in terms of, still you must know. So I would end by saying that, again, start with an empty slate in your mind, in your at least a long case. Keep history and possible differential diagnosis in mind while doing clinical examination. Before you reach the examination of the precordium, BP, pulse, and JVP are very important components. And once you have done your apical area examination, your diagnosis should be certain with you. See the whole picture. Don't rush after small findings in dynamic auscultation and forget the hard endpoints of, how your apical impulse was and listen to your examiners and be ready to adapt whenever needed. I thank you for the opportunity and I thank you for your attention.
Thank you so much, Rishi. It was a fantastic demonstration and then, covering the whole thing. I think probably it's worth for all of you making all the way to this place and then, listening to Rishi and and all our faculty members. Before we take a tea break, quickly, some 2 to 3 questions we can entertain. Anything? So everybody is clear. Okay. Yeah, go ahead.
Hello.
I believe what you are trying to ask me is that sometime when you feel in mitral stenosis, you can feel your S when you say that it's a tapping effect. So that's essentially when you can feel but then when you talk about the apical impulse in general, tapping is a normal apical impulse and it is a combination of a normal force and it is not sustained. So it is tapping because it is just tapping you and going away. But tapping is sometimes also used in cases of mitral stenosis when you get a pathological external. And then that's a different connotation for saying. It's better not to say tapping when you are talking about mitral stenosis situation.
Anybody else?
Good evening, sir. Clinically, how to comment on the narrow splitting of second heart sound?
So narrow splitting. Oh, so I mean, normal splitting would be a narrow split sound. You can only say that it's a normally split sound when you can hear the splitting in inspiration and you cannot hear the splitting in expiration. When that normal becomes a narrow, I would not say that is something that we should go into how many milliseconds, because there it's a phonographic findings. And I think when the narrow becomes so narrow that it becomes single, or it becomes more narrow and it becomes a reverse splitting, that is the time we should comment upon it. Otherwise, you can just simply say that I can hear the normal splitting in which I can hear the splitting during inspiration and I cannot hear anything during expiration. It's a normal splitting sound. I would not advise you to say that the S2 is narrowly split and trying to say that the LV obstruction is producing that, because then it will be getting yourself some trouble. Yeah. Only speak when it has become so narrow that it has become single or reverse. Otherwise, you can only hear in inspiration, you can hear splitting, in expiration, you cannot hear splitting. That's the only thing human hear can do. Otherwise, rest are phonographic findings.
The patient of severe aortic stenosis, how would we say that
In severe aortic stenosis, A2 is tend to be soft. It will tend to be soft because, so how do you say?
Question.
A2 is soft.
And why do you need to say this? If you are not hearing the A2 because of a severe calcification, if you're hearing only a single sound, then it's wiser to say that, I'm hearing a single sound. Everything else is constructing it to be severe aortic stenosis, and I would contribute that sound. I'm not hearing any splitting, and I would contribute that I'm able to appreciate P2, but I'm not able to appreciate it. That's what happened in just the last case that Myra is presenting. But then he said that I can listen to the second heart sound at the apex, implying that the P2 is now heard at apex. You get what I'm saying? If you are only hearing one sound and you're not getting a splitting and it's a severe aortic stenosis, you can say that it's the pulmonary sound I am getting. I think I cannot appreciate the aortic sound because of severe aortic stenosis. But then you cannot say that that second sound is heard at the apex also, because then it means the severe PH. Then you will have to justify the severe PH in the clinical examination, which would be very rare in isolated aortic stenosis.
Okay, so with this, we'll take a very short tea break. Please come back within 10 minutes because two important lectures are there and they'll be really useful. So please come back within 10 minutes.
हाँ एक रखो क्योंकि बाकी मिल नहीं रहे ना कोई ही नहीं ना एप्पल नहीं डेल डेल से चार्जर लो चार्जिंग की जरूरत है नहीं फुल चार्जिंग और सारा साउंड हाँ डाल दो इसमें लगा
Single person, in the side way.
No, duplicate.
Hello, I request all of you to settle down, please. Now we have another two interesting lectures coming up. One on assessment of LV functions, systolic and diastolic by Dr. Alligation, sir. And then in the end, you have another very interesting thing and very important for the exam regarding the spotters and chest X-rays and other things which will be dealt by Dr. Palajan. Request Dr. Alligation, sir, please.
Okay. Good evening to all of you. So last two lectures, and this is now the important topics in echocardiography, assessment of systolic and the diastolic function of the heart. So we will take up diastolic dysfunction first because it is a little more difficult to understand. It may take a little longer time. So we always don't think about diastole and systole as a separate thing. Both the things are coupled together. As you can see, the actin-myosin bands gets attached to the receptor sites, and calcium is involved in the contraction and relaxation cycle of the heart. So systole and diastole are combined together. So actually, one of my friends today asked me, say, in all the patients with diastolic dysfunction, there is there systolic dysfunction also? That is, in patients with heart failure with preserved ejection fraction, you get predominantly diastolic dysfunction. Is there a systolic dysfunction or not? And the reverse one, in patients with reduced ejection, heart failure with reduced ejection fraction, the systolic function is abnormal. Is there a diastolic dysfunction in some of the in all the patients or not? I don't know what other, you have to tell me the answer last. This is actually based on recommendations for assessing the diastolic and the systolic functions of the heart, combined recommendations from the American Society of Cardiography and the European Society of Cardiovascular Imaging. The assessment of left ventricular diastolic function should be an integral part of routine examination, particularly in patients with dyspnea and heart failure. This is one of the older classification, grade 1, grade 2, grade 3, and grade 4, based on the left atrial outflow pattern, tissue Doppler imaging from the mitral and septal mitral annulus, and the pulmonary venous flow pattern. You can use the flow propagation velocity also. This is the typical E wave, which is smaller than the A wave. And here the E velocity is decreased in the tissue Doppler from the septal mitral annulus. The E velocity of the pulmonary vein is higher than the S velocity is higher than the E velocity. So this qualifies for impaired relaxation. The second one is the pseudo-normal pattern where the E and A wave looks like a normal one. But if you look at the tissue Doppler, the E velocity is decreased below 7 centimeters, and the pulmonary vein shows a smaller S wave and a taller D wave. So this qualifies for the pseudo-normal pattern. The third one is the restrictive filling pattern, where the E wave is very tall and the A wave is very small. Again, the E of the septal tissue Doppler is reduced. The S wave in the pulmonary vein is very, very small, and the D wave is markedly increased. These are the three type patterns which are described. But the problem with this is this typical pattern is not obtained in all the patients. In about 30 to 40% of the patients, you cannot determine what is the type of diastolic dysfunction and all that. And it was more cumbersome because we had to look at the mitral annulus flow, tissue Doppler flow, pulmonary venous flow, and sometimes you have to get other parameters. Even in the mitral valve, we had to measure the E velocity, A velocity, deceleration time, isovolumic relaxation time, too many measurements, and there will be variations and all sorts of confusion will be there. To avoid all these things, they came out with a newer advice in 2016, which is little more practical, and it is little easy to follow also. Here it is more simplified, and what we are looking at in diastolic dysfunction, the main thing is look for impaired relaxation, whether the patient has got impaired relaxation, that the initial stage of diastolic dysfunction. And then in addition, does the patient have chamber stiffness also? This is a little more advanced stage of diastolic dysfunction. Along with that, does the patient have elevated filling pressure? This is the most important one. It's not enough if you say there is diastolic dysfunction. We have to say whether the left ventricular end diastolic pressure is normal or increased. When we say diastolic pressures, there are too many pressures. There is a pulmonary capillary wedge pressure, mean LA pressure, LV pre-A pressure, and LV end diastolic pressure. When we say elevated pressures, we always mean LV end diastolic pressures and not the other ones. So here you can see the pre-A pressure, this is the mean pressure, and this is the LV end diastolic pressure. Here, when we say in diastolic dysfunction with the elevated left ventricular pressures, we always mean the left ventricular end diastolic pressures. Okay. What are the parameters to identify the diastolic dysfunction in patients with normal ejection fraction? This has been very much simplified now. So look at the left atrial outflow velocity. You have to keep the sampling volume in between the anterior and the posterior leaflets, get the flow pattern. Measure the E velocity and the A velocity. That's simple. And get the E by A ratio. Second, look at the tissue Doppler from the septal mitral annulus. Measure the S velocity, E velocity, and A velocity. The important thing is the E velocity. And measure the velocity from the lateral mitral annulus. This is lateral, this is medial. So you can measure the lateral and the medial mitral annulus. Similarly, the S, E, and A, the three velocities. The third one is the ratio. You can divide the LAOT E velocity divided by the E velocity in the tissue Doppler. So if you are using the septal annulus, the ratio should be more than 15. If we are using the lateral mitral annulus, it should be more than 13. If we are using both the average of lateral and medial mitral annulus, it should be more than 14 to call it as a diastolic dysfunction with elevated left ventricular end diastolic pressure. The fourth index is the volume, left atrial volume. This can be obtained from the apical four-chamber view and the apical long axis view, or you can use the apical two-chamber view also. This is by using the area length method, measuring the area of the left atrium and the long axis diameter. We can use even the Simpson method, or if you have a three-dimensional echocardiography equipment, you can use three-dimensional echocardiography for the measurement of left atrial volume. The last one is the tricuspid regurgitation velocity, which should be more than 2.8 to call it as a positive sign. So there are only four parameters which you have to measure. Left atrial outflow velocity, tissue Doppler from the median and lateral mitral annulus, calculate the E by E bar E prime. The third one is the left atrial volume, and the fourth one is the tricuspid regurgitation velocity. If you have done this, then you are ready to diagnose diastolic dysfunction and classify it. Look at this pattern, the LA outflow pattern. This LA outflow pattern shows that the E velocity is smaller, A velocity is higher. If the E velocity is 50 centimeters or less, with E by A ratio less than 0.8, then it is type 1 diastolic dysfunction. Can you understand? So E velocity should be less than 50 centimeters and E by A ratio should be less than 0.8. Then it is type 1 diastolic dysfunction. You need not do any other measurements. That's all. It is over. In both reduced ejection fraction with heart failure with reduced ejection fraction, in heart failure with preserved ejection fraction, this pattern, you have to, but the E velocity should not be 60 or 70 and the A velocity 80 or 90 and all that. It will not be qualified for that. The E velocity should be very low and the E by A ratio should be less than 0.8. Look at this pattern. So this is the LA outflow pattern, which shows a markedly increased E wave and a very small A wave. And the ratio is more than 2. So here, again, this immediately tells you that the patient has got a type 3 diastolic dysfunction and impaired LV relaxation and chamber stiffness, elevated left atrial pressure. So when you get this pattern in both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, this pattern always indicates that the patient has got a type 3 diastolic dysfunction, grade 3 diastolic dysfunction. Is okay? It's quite, these two are quite simple. Only thing is the next one. Now, the E velocity is 70 centimeters in this patient. Even though the A is bigger than E, the E velocity is 70. So this will not qualify for the type 1 function straight away. And here you can see the E velocity is higher, the A velocity is smaller. So this looks like a normal pattern. And the ratio is between 0.8 to 2.0. E by A ratio is between 0.8 to 2.080. So in these patients, to say whether they have a normal diastolic function, type 1 diastolic function, or type 2 grade 2 diastolic dysfunction, we should have some other parameters. What are the other parameters which you should have? These are the other parameters which I've already described to you. So you have to find out whether these parameters are present. So in patients with normal ejection fraction, if these 4 parameters, out of these 4 parameters, if only one is positive, then the diastolic function is normal. If 3 or 4 is positive, then there is type 2, grade 2 diastolic dysfunction. When there is 1 or 2 positive, the diastolic dysfunction is indeterminate again. So instead, if you are not able to get all the 4 parameters, you are able to get only 3 parameters, then it is going to be different. So in this indeterminate patients, sometimes we can use the peak global longitudinal strain. If it is decreased, again, it indicates, suppose the diagnosis of diastolic dysfunction. If only 3 parameters are present, here you can see, this is the mitral flow pattern. I told you initially the E wave is 50 centimeters or less, and the E by A ratio is less than 0.8. It immediately qualifies for type 1 diastolic dysfunction. This E is very markedly increased and A is very small and the ratio is more than 2. It qualifies straight away for the grade 3 diastolic dysfunction. When these 2 are not present, then we have to look at the other criteria. If by using the 4 criteria, we have seen again, say when 1 criteria is present, then it is normal. When 3 or 4 is present, then it is grade 2 diastolic dysfunction. Only when three criteria are available, one criteria we are not able to get. For example, that there is no tricuspid regurgitation velocity to assess. Then if it is so, then if only one is positive, then it is likely to be a grade 1 diastolic dysfunction. If 2 is positive, then it is likely to be a grade 2 diastolic dysfunction. If only two criteria is available, then if we have one is positive and one is negative, we cannot determine the diastolic dysfunction. If both the things are positive, then it indicates that the patient has got grade 2 diastolic dysfunction. So only when it is not typical grade 1 or typical grade 3, then it becomes a problem. We have to rely on the 4 parameters, and depending on if even if you're not able to remember this 1, 2, 3 and all that, more number of parameters which are positive, then more likelihood of diastolic dysfunction. Less number of parameters are positive, then less likelihood of diastolic dysfunction. Less parameters are positive, then it is likely to be a milder degree of diastolic dysfunction. At least this one you should be able to remember. So no parameters are positive or less parameters positive, then it may be normal diastolic function. If 1 or 2 are positive, it will be mild diastolic dysfunction, it will be grade 1. If 3 or 4 are positive, it will be grade 2 diastolic dysfunction. Of course, grade 3 diastolic dysfunction will require this pattern, the early outflow pattern. Apart from this, we have some other criteria also for supporting the diagnosis of type 3 diastolic dysfunction. In patients with atrial fibrillation, in mitral valve disease, left ventricular assist device, and ventricular pacing, we cannot use these criteria. And there are certain other diseases in which it is, say, assessment of diastolic dysfunction is going to be much more difficult. There are certain other parameters which can be used. One is the deceleration time. If you see this E wave, the E wave comes down very fast. It is less than 160 milliseconds. If the deceleration time is less than 160 milliseconds, usually it indicates a type 3 diastolic dysfunction with an elevated left ventricular end diastolic pressure. The second one is presence of another wave between the E wave and the A wave. You see another wave between the E wave and the A wave. It was described by Dr. Liv Hatley. It is called L wave. If there is a prominent L wave with more than 50 centimeters, then again it indicates that the patient has got type 3 diastolic dysfunction with elevated left ventricular end diastolic pressure. And look at the pulmonary venous flow pattern. If the E wave is if the S wave is very small, again it indicates that the patient has got type 3 diastolic dysfunction with marked elevation of the left ventricular end diastolic pressure. And the additional one is the global longitudinal strain of the left ventricle. The global longitudinal strain in a patient with normal ejection fraction again supports the diagnosis of diastolic dysfunction. How will we report diastolic dysfunction? We can report it as normal diastolic function and normal filling pressure, if everything is normal. Grade 1 diastolic dysfunction is impaired relaxation with low to normal filling pressures. Grade 2 diastolic dysfunction will be impaired relaxation with chamber stiffness, resulting in moderate increase in filling pressures. Grade 3 diastolic dysfunction, which is the restrictive pattern, there is impaired relaxation, increased chamber stiffness with marked elevation of the left ventricular end diastolic pressure. So these are the grade 2 and the grade 3 are the patients in whom, if the ejection fraction is normal, they will qualify for heart failure with normal ejection fraction. Okay. Anything, any doubts about the systolic function, you can ask me. We'll go to the systolic function. Systolic function is little more easier for you to understand. And these guidelines were published in 2015, say assessment of cardiac chambers, dimension and dimension and function. And it is accepted that 2D is the accepted practice for volume analysis today, with acknowledgement that 3D is superior. So all the measurements should be done from the two-dimensional echocardiogram. And if you have a three-dimensional echocardiogram, use it for measuring the volumes and the ejection fraction. If the left ventricular measurements, left ventricular global function, left ventricular regional function, and left ventricular mass, these are the most important things. You can use say M-mode echocardiography for measuring the left ventricular internal dimension in diastole and systole. But you should use the two-dimensional echocardiographic guidance and cut the interventricular septum and the left ventricular posterior wall perpendicularly like this. If you don't do that, then you will artificially produce an increased diameter. So if you cut like this from an oblique picture, then you will get a longer diameter. So you should be careful when you are doing measurements from the M-mode echocardiogram. Use always the guidance of the two-dimensional echocardiogram. Do it like this and not like the first one. So this is the most important one if you are taking the when you are measuring the diameters. The next one is always use the two-dimensional echocardiogram for measuring the volumes. You should not use the cube method or the T-Koch method for measuring the ventricular volumes and the ejection fraction. Use the biplane Simpson method or the area length method for measuring the left ventricular volumes in diastole and systole. And from that, you calculate the ejection fraction. Of course, if you are not able to clearly make out the endocardium in more than 2 segments, you should use left ventricular contrast echo. So this is a left ventricular contrast echo. When injected into the peripheral vein, it passes through the right atrium, right ventricle, and crosses the pulmonary circulation, fills the left ventricle, and you can clearly make out the left ventricular endocardium. This measurement is much superior, and the error is very less if you use left ventricular contrast for measuring the left ventricular volumes. The three-dimensional echocardiography is more accurate than the two-dimensional echocardiogram. Usually the volumes obtained by three-dimensional echocardiography is slightly larger than the volumes which are obtained by two-dimensional biplane Simpson method. Why? Because I see in most of the two-dimensional echocardiogram, the left ventricular apex is foreshortened and it is not included in the measurement. Whereas the left ventricular apex is always included in the left ventricular cast, which if we are using the three-dimensional echocardiogram. The second one is in two-dimensional echocardiography, we use a mathematical formula for measuring the left ventricular volumes by Simpson method or the area length method. Whereas here, we measure the number of volume cells which are present in the left ventricular cast. Otherwise, like pixels, when you are viewing a TV, you call it as a pixel, how many pixels are present. Here, how many volume cells, Vox cells are present inside the left ventricular cavity can be correctly measured, and from that the volume is calculated. So these are the two things. One is the lack of mathematical formula which is involved in measuring the volume, and left ventricular apex is always included in the three-dimensional echocardiographic picture. So three-dimensional echocardiographic volumes are much superior than the two-dimensional echocardiographic volumes. So to again say impress you on that, say M-mode echocardiography should not be used for calculating the volumes and the ejection fraction. So T-Koch method and the cube method should be abandoned. We should use only the two-dimensional echocardiographic method, especially the biplane Simpson method for measuring the left ventricular diastolic volume, the systolic volume, and the ejection fraction. And the three-dimensional echocardiogram, we can use the say the whole volume pyramid, and from that we can calculate the left ventricular volume in diastole and systole and calculate the ejection fraction. So use the two-dimensional echocardiogram. If you have a three-dimensional echocardiogram, that will be an added advantage. And the systolic dimension, normal systolic dimensions, it's there in the books. You can go through male and female, and the volumes in male and female. And the ejection fraction you can see in the male is about 52 to 72%, whereas in female it is about 54 to 74%. So these are the normal ejection fraction in male and female. Similarly, you can get the left atrial volume also, and the left atrial volume index also we can measure. Any volume which is above 34 ml per square meter body surface area means that the left atrium is dilated. And most of you will be asking, say, can you do an eyeballing method? So the eyeballing method is subjective. We can do it when you are in a hurry like this, when the ejection fraction is completely normal, when the contraction is completely normal. Instead of measuring, you can say the ejection fraction is going to be normal. It's about 60% like that, you can say. But it's very subjective, experience dependent, lack of standardization. There will be large inter and intra-observer variability. The next one is, how about using artificial intelligence? So this is the one artificial intelligence model. It is the Philips three-dimensional echocardiographic method. So it automatically detects the endocardium, and they have fed in a large amount of data into it. And the machine itself from the three-dimensional echocardiogram immediately produces a cast of the left ventricle and calculates the left ventricular diastolic volume and the systolic volume. So the only thing which you have to acquire is the pyramidal cast from the entire left ventricle from the by using the three-dimensional echocardiogram. When you push a button, then immediately it will mark out the endocardium and calculate the left ventricular volumes. Again, there may be some errors and it has to be supervised because these measurements depend upon the endocardial delineation. The endocardial delineation may not be so good in all the patients, so we need some supervision for the assessment. That is about the global function of the left ventricle, especially left ventricular diameter, left ventricular volume, and the ejection fraction. Regional function. In the hemodynamic days, we used to say find out the thickness and how it thickens during systole and say this is normal. This is a patient in whom the interventricular septum is thinned out and it's not showing any thickening, so it is most probably infarcted. There is another patient in whom it is hypokinetic. Most probably the septum is normal in thickness, shows some thickening. So we can get an idea about the regional function by using the hemodynamic. But regional function is better assessed by the two-dimensional echocardiogram. So this is done from various views. The most important view is the parasternal long axis view from which we start. Hope you remember all the chambers of the chambers which are shown in the diagram. And we have two important views, sets of views. The short axis view. This is a short axis view at the level of the mitral valve, short axis view at the level of the papillary muscle, and short axis view at the level of the apex. The short axis view at the level of the mitral valve is divided into 6 segments. So this is the interventricular septum, which is divided into anterior septum and the posterior septum. Here, from here to this point, it will be left ventricular anterior wall. Then here it will be anterolateral wall. This will be infralateral wall, and this will be inferior wall. So all of you are clear, there are 6 segments in the left ventricular circle. At the level of the base, we call it basal, anteroseptal, basal, anterior like this. There are 6 segments at the level of the papillary muscle, similarly, and there are 4 segments at the level of the left ventricular apex, septal, anterior, lateral, and inferior. There are 4 segments. Totally, there are 16 segments in the left ventricle, and these 16 segments can be viewed in the apical 4-chamber view also. In the apical 4-chamber view, you can see in the, apical 4-chamber view, it is what we see is the posterior septum and the anterolateral wall. In the 2-chamber view, it is the inferior wall and the anterior wall. In 3-chamber view, it is the infralateral wall and the anteroseptal wall. So we can assess all the 6 segments in this view also. So by looking at the segments, we can find out whether the contraction is normal, reduced, or markedly reduced, or contracting in the opposite segments. And it can be displayed as a bullseye display, you can do it. Why should you have this division? Because this corresponds to the blood supply. You can say if the anterior septum, left ventricular anterior wall are involved, it is almost definitely it is a LAD territory which is affected. And if you see the basal portion of the left ventricle is not affected, only the mid-ventricular and the apical portions are affected, then you can say definitely even in the LAD, the obstruction is beyond the first septal perforator. So this much of information we can obtain by the contraction pattern, which is abnormal in these patients. So the right coronary territory will be the inferior septum and the inferior wall, and the rest of the left ventricle is usually supplied by the left circumflex artery. There will be some overlapping and differences in the area of the blood supply of the right coronary artery and the circumflex artery. There will be some variation depending upon which one is dominant, etc. And we can give a scoring. Normal is given a score of 1, hypokinetic is given a score of 2, akinetic is given a score of 3, and dyskinetic will be given a score of 4, and aneurysm will be dyskinetic with an aneurysm will be given a score of 5. So this 1 to 4 score can be totaled and divided by the number of segments to calculate what is called the wall motion score index. So the total number of segments which are visualized and the total score, when it's divided, it gives you the wall motion score index. If the wall motion score index is more than 2, usually it indicates that the patient has got a significant left ventricular wall motion abnormality and that there is a diastolic dysfunction. And we can also assess the left ventricular shape, whether it is more spherical or more normal from the two-dimensional echocardiogram. Also, we can measure the left ventricular mass. And this is one place where the mode echocardiogram is still useful. Well, the only thing is there is lack of data by using the two-dimensional echocardiogram and the three-dimensional echocardiogram. The mass has not been, there are not a lack of data. That's why we still use the mode echocardiographic method for measuring the left ventricular muscle mass. We measure the interventricular septal thickness, left ventricular posterior wall thickness in diastole, and measure the left ventricular internal diameter in diastole. From that, we can calculate the left ventricular muscle mass and measure and multiply it by 1.08 to get so many grams of left ventricle in that person. We can use the two-dimensional echocardiogram by this method, but it's going to be cumbersome. And again, I told you for a research paper, if you want, you can use it. But then the day-to-day practice is going to be very difficult. But this one is little more easier. The three-dimensional echocardiogram, if it comes into practice in every patient, we can mark out the endocardial volume and the epicardial volume. The difference between the two will give you the myocardial volume. When it is multiplied by 1.08, will give you the left ventricular muscle mass. And there is this mass has been again calculated, and it has been correlated with muscle mass, which is obtained by MRI. The volume and the muscle mass, the gold standard is the MRI, and both have been compared with the MRI data, and it has been found to be excellent correlation between the two. And this is the muscle mass in women and men, normal data from above which we have to call that the patient has got left ventricular hypertrophy. And depending upon these parameters, only the ejection fraction only we decide whether the patient has got heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, or the mid-range ejection fraction. Next, coming to the newer parameters, there are a few other parameters which can be used for assessing the left ventricular systolic function. One of the important parameters is the myocardial strain and strain rate. So this actually, the normal muscle, during ventricular contraction, it may lengthen or shorten. During ventricular contraction, it shortens. So the difference between the diastolic length and the systolic length is calculated. From this, we can measure the strain. So to give you a graphic example, say the initial length is 10 centimeters. During the contraction, it increases to a length of 12 centimeters. The difference between the two is 2 centimeters. 2 divided by 10 will be 20%. Because it is lengthening, it is plus 20%. So the myocardial strain is plus 20% in this patient. In this example, the initial length is 10 centimeters. During contraction, the final length is 8 centimeters. So there is a decrease in the length of 2 centimeters. So this is minus 2 divided by 10 will be minus 20. So the strain will be minus 20. Here you can see this plus 20, this final length can be achieved in 1 second, or it may be achieved in 2 seconds, or it may be achieved in 3 seconds. So when you divide the strain by the seconds which taken for the length to be achieved, then it is called strain rate. So it looks quite simple, and the machine will be able to do it. You need not worry about the formula, etc. And there are two methods by which we can do strain and strain rate. One is by the Doppler method. The second one is the speckle tracking method. The speckle tracking method is the most accurate one, and it is being used on a day-to-day basis. If you see the two-dimensional echocardiogram, you can see some bright spots. They are called speckles. The bright spots are called speckles. So we are tracking the speckles. The number of speckles constitutes a kernels. So we track the speckles during each frame. So this is the first frame, and in the second frame it has moved to this side. The third frame led here, and the fourth frame like this. We can track that speckles in the two-dimensional echocardiogram. From this, the tissue velocity can be calculated, and from this tissue velocity we can obtain the strain of the two-dimensional echocardiogram. And you have to know something about the myocardial fiber orientation also to understand what I'm going to tell about the other ones. See, there are circular fibers and the longitudinal fibers which are situated in the left ventricle. The longitudinal fibers are situated in the epicardium and the endocardium. They contract longitudinally. The contraction involved in early systole and atrial systole. Usually it correlates very well with the overall ejection fraction. Whereas there are circumferential fibers in between the epicardial and the endocardial fibers, which are oriented longitudinally. Between the two, it is in the middle of the myocardium, the circumferential fibers are situated. This results in shortening or rotational movement, and their predominant action is during ejection phase and the early diastole. This is best seen in the short axis view. So if you see, this is the heart. Now you are seeing the longitudinal contraction of the heart. Here you identify the speckles and then calculate the strain. This is the short axis view of the heart. Here you identify the speckles and then calculate the velocity. And from this you obtain the strain. This is called longitudinal strain. Okay. Instead of this, so this is an example of a normal longitudinal strain. This is a patient with very abnormal longitudinal strain. You can see the contraction, say upward and lower, downward is very low. Instead of this, take the circumferential fibers, circumferential short axis view. Here you can see two spots. You can measure the velocity of contraction, and from that calculate the strain. This is called the radial strain. The third one is here. Along the circumference, you take two spots and measure the velocity and calculate the strain. This is called the circumferential strain. So in strain itself, there is a longitudinal strain, radial strain, and circumferential strain. This is just for academic purposes. I have told you there is another one is called in the area strain is also there. But what is used nowadays in clinical practice is only longitudinal strain. If you are thorough with that strain, it is enough. So this is a patient, normal person. You can see the contraction is normal in all the views, long axis, four chamber, short axis. And this is the apical views. From this apical view, we have obtained this strain pattern. So the strain is minus 21.1. Anything above minus 17, so it is 18, minus 20 will be abnormal, but will be normal. Anything minus 16 or below will be definitely abnormal when the two-dimensional picture is good. So the strain depends upon this two-dimensional echocardiogram. The two-dimensional echocardiographic picture should be really good if you want to have reliable two-dimensional echocardiographic parameters. This is another patient with dilated cardiomyopathy. You can see the contraction is diminished. It is not severe dysfunction. It will be mild to moderate left ventricular dysfunction in this patient. And if you look at the four-chamber view, you can identify again the mild left ventricular dysfunction due to dilated cardiomyopathy. The strain is minus 13.5 in this patient. This is another patient with myocardial infarction. You can obviously visualize the left ventricular aneurysm here, a large left ventricular apical aneurysm, and corresponding to that, you can get a positive strain because it is bulging. So it is the muscle is expanding during systole. You get a positive strain in the mid and apical region in this bullseye segment, and the global strain is markedly diminished. And this is another patient with hypertrophic cardiomyopathy, left ventricular outflow obstruction, marked hypertrophy of the left ventricle. You can see that the left ventricular systolic ejection fraction is completely normal in this patient. But if you look at the global strain, it is markedly diminished because of the abnormality in the muscle fibers. Even though the ejection fraction is normal, the longitudinal function is markedly diminished and the strain is minus 7.5. So this is the second parameter which can be used, and it is very useful in assessing the left ventricular systolic function. Then the other parameters I'll just mention and I'll finish within this 1 minute. These are the other parameters. You can use the basal fractional shortening, the myocardial performance index, otherwise called as the TAE index. And the other one is the left ventricular say tissue Doppler imaging, and the desynchrony measurements also can be done from the for assessing the systolic function. We'll not go into the detail. I think you all of you know about that. It is not used now and that much in day-to-day clinical practice. It is mainly for your exam purposes. You can read about it. Thank you.
Hello.
No questions?
Thank you so much, sir.
You
I'm
understood
sure.
completely or not understood.
I think he covered such a difficult and vast subject in such a short time. He has put in so much of effort in explaining that, and I'm sure that it's hard to digest all those things. But go through his lecture at leisure time. I'm sure that many of your basics will get cleared, and especially today the strain thing, which is in thing for LV function assessment. Majority of people don't know how to do it. He has really told some fundamentals, real good fundamentals. It will take time for you to really understand and go through them. But despite that, if you have any questions, 2 questions can be allowed. Otherwise, we'll go to the next session, please. Everybody knows everything. Thank you. Okay. So for today's last lecture, but that will be really a good one. All of you, whatever, probably you don't require any more tea, coffee, anything. And I'll request Dr. Palajani sir to come in.
Yes.
we come to the end of the day, and after Dr. Allegation talked about strain, I hope you're not strained. And if you are, we'll make our last spotters very, very light. So be relaxed and comfortable, and we'll show you some interesting ECGs and some spotters, which many times are given to you in the examination. And I will start with a very simple one. And first one, this is a 78 years female, sudden palpitations. And I would like you to have a look at the EKG. Anybody wants to take a chance and say what it is? Very quick, very fast. Tell me. Can't hear. What is it?
Atrial fibrillation, sir.
Say it loud. Anybody, one person to stand up and say.
It's 12 lead normal standardized is showing a neurocomplex tachycardia, irregular in rhythm, and the precordial lead, you can see the R waves are okay, but limb lead showing the low limb mode. And the age is 75 years, likely might be any atrial enlargement causing the atrial fibrillation. We might be might be a RCM.
So therefore, in other words, what you're saying is an atrial fibrillation with a fast ventricular response.
Yes.
Now, therefore, I will ask you, what should your treatment options? Should we give IV Cardron, IV digoxin, IV diltiazem?
I would like to know the hemodynamic status of that patient.
I think patient was hemodynamically quite stable. And the last one is to immediately perform a DC cardioversion. What will you do?
Rate control will be the ideal one.
Rate control will be ideal. Anybody else has got any difference of opinion? Will you like to revert these patients to normal sinus rhythm by giving IV Cardron?
We need to see the time. We need to rule out the clot. Then we can go ahead with the cardioversion if it is.
Will you do a DC cardioversion on this patient?
Structural heart disease.
Without knowing the clot, it's very difficult.
Who's speaking? Can you stand up? Somebody who's speaking? I can hear only from the speaker. But who's the one who's... Oh yeah, last one. Yeah. Will you do a cardioversion on this patient?
No, sir. Directly we can't proceed. We have to see for the any LA clot is there and what duration AF it is.
Yeah, I think it's very good answer. First of all, when you see an atrial fibrillation with a fast ventricular response like this, couple of things you have to know. Number one is a hemodynamic status. If the hemodynamic status is compromised, then I think, of course, that time you can take a chance to do a cardioversion. However, if the patient is hemodynamically stable, first time you've seen a patient with atrial fibrillation, do not do cardioversion. The reason being, you don't know, patient might have been getting atrial fibrillation paroxysmally, and there may be a clot inside, and you may shoot a clot if you try to do a cardioversion. So your choice should be to rate control either with IV diltiazem, or you can even give IV Cardron, which may do a pharmacologic cardioversion. This is another patient, male, 56 years, palpitations on and off, no history of chest pain, resting ECG, and echo normal. Can anybody tell me what exactly it is? Okay, I'll give you a clue. First, have a look at the ECG, then I will give you a clue. Could it be a ventricular tachycardia? Could it be an SVT with aberrant conduction with right bundle branch block and a left axis deviation? Was it an atrial fibrillation with aberrancy? Was it a fascicular tachycardia? Or was it an atrial flutter with aberrancy? I've given you some 5 options, so I'll go back now. Look at it very carefully and let me know what exactly you think.
Fascicular VT.
First of all, is it ventricular tachycardia?
Yes. So
Why
it's
do you
a
say ventricular
There
tachycardia?
is normal capture beat.
Is it the same person speaking?
So left posterior fascicular VT.
Yes. Why do you say it's a low posterior?
So it's QRS morphology is between 100 to 120, less than 120 milliseconds. with
Okay,
an
why I
RV
will ask you one question. Why this is not a supraventricular tachycardia with aberrancy? Is there anything pointer in this ECG which says no, it is not a supraventricular tachycardia? Can you look at all the leads, especially lead L2? Is there some pointer there?
Yes, sir. Capture beat is there, sir.
What do you
Lead
what do you
two.
find there?
Lead two, sir. There is a capture beat.
There is a sinus beat there.
Sinus-
Once you see something like aberrant ventricular, when you see a white QRS complex tachycardia, if you see a fusion beat or if you see a sinus captures, it indicates that the patient has got a ventricular tachycardia. So you're absolutely right. The location seems to be, you're again right, it is a left posterior fascicular tachycardia because there is a left axis deviation and there's a right bundle branch block. I think it's a very highly diagnostic of the patient with a left posterior fascicular tachycardia. Now, what will be your, so our diagnosis is fascicular tachycardia. Now, what is your treatment for this? Amiodarone, sotalol, verapamil, lidocaine, DC shock.
Verapamil.
Verapamil. This is the only white QRS complex ventricular tachycardia which responds to the verapamil. It does not respond to anything else. You can try something else, but it's very specific to give a verapamil to control this tachycardia. Okay, anybody to take a guess on this? What is this tracing supposed to be?
It is CV waves actually.
Huh?
CV waves.
It's said, let me tell you, below is the aortic tracing. What do you find?
IABP 1:1 diastolic hypertension.
Pardon? But where is the signal for the IABP? Where is an augmentation signal? So what do you see? One is a large complex pressure tracing. Another one is a smaller tracing. So what is this? Every alternate beat.
Pulses alternate.
What is that? What is that? Say it loudly. Pulses? Alternance. Yes. It indicates a severe left ventricular dysfunction. Really, it indicates a real left ventricular dysfunction. Patient is about to die. Now, this one, I think Dr. Rishi Sethi has already discussed on the Valsalva maneuver. So I don't want to go into this. And okay, what is this?
Torsades.
Torsad. Absolutely right. You can see an undulating QRS complexes of different, they're actually moving around one axis, up and down. This is Torsadi pontes. And what is the treatment for this?
Magnesium. Magnesium.
Magnesium. So can you give a shock to these patients?
No.
Actually, if you see this ECG, a DC shock has been given to this patient and patient has converted to normal sinus rhythm. So DC shock and intravenously. Okay, now I will ask you one question. You see this gentleman and he has got a posture like that of an Englishman. Anybody can take a guess?
William Harvey.
Okay, I'll give you the 4 options. William Osler, William Harvey, William Heberdin, and William Shakespeare.
William Harvey.
William Harvey. Anybody else? Can he be a William Shakespeare? Any other guess? Now 2 guesses are gone. William Osler. He is a guy whose description we even recite today, and the maximum money that we make in our clinic is because of this man's description of angina. What was his name? Huh? Aberdeen. This is William Aberdeen, an English physician who described angina in somewhere about a century back. Okay, now here's a 24 years medical exam patient who has come, person, not patient, who has come for medical examination for pilot job. Will you certify him? Will you certify him for the... Please, please. Will you certify, first of all, my question, will you certify him for the pilot's job? Yes or no? No. Why not? Why not?
Sudden cardiac death.
Huh?
He has a tendency of having
Pardon?
sudden cardiac death.
So what is this called as? Why he will have sudden cardiac death? Brugada syndrome. What are the features of Brugada syndrome which you can describe on this ECG?
So there is coving of the ST segment.
Yeah, if you look at the V1 and many times V2, you find something like an RSR pattern, and the terminal part is slightly ST elevation. This is very typical of Brugada syndrome type 1. And these patients are known to suffer from sudden cardiac death due to ventricular fibrillation. What is the treatment for these patients? ICD. Okay. Now, here's a patient just few days back I left, and I was referred this patient by our gastroenterology colleague. She's a 35 years female, and she actually presented to our emergency medical services, breathlessness, ascites, liver 4 fingers, was referred from the EMS thinking this to be a cirrhosis of liver, referred to the gastroenterologist who did not know what exactly was happening, did the upper GI endoscopy, did the lower GI lower endoscopy, did not find anything, and then referred the case to us. And the first thing we did was to do an echo. And this is the echo, that's what we did on this patient. And okay, 1 minute. I think this is not connected to the... No, it is not. Okay. All right. What do you find? I think allegation will laugh at us if we don't say what it is. Anybody? RA myxoma. You see a big tumor popping in and out of the tricuspid valve. The right ventricle itself seems to be slightly narrowed or maybe smaller in size, but there's a big mass which is coming up and down. Can this be a clot? Can this be a right atrial clot which is coming up and down? If you see, the mass looks like sessile. It's not sessile. It has got a peduncle. Possibly it is popping up and down. When you see something which is popping up and down, it is very unlikely to be a clot. It's a very rounded shape. It's on the right side, and it must have obstructed the tricuspid valve. That's why the patient must have developed ascites and liver enlargement. The people thought this was probably some gastrointestinal problem. And then, of course, this patient, I think, is being operated today as an emergency procedure to remove this right atrial myxoma. So this is very classical of the right atrial myxoma. Okay, here's a patient who came with flu-like symptoms, and 32 years female. See the ECG. What do you think it is? Pardon? pericarditis, correct. What is the other differential you would like to offer on this?
Benign early repolarization.
Early repolarization pattern. Don't diagnose this as an infarction, because if you see the ST elevations have got a concavity up. Once you see a concavity up, it's more likely to be either an early repolarization pattern or acute or pericarditis. And this patient had a very short history, had a flu-like symptoms. Therefore, I think we made a diagnosis of the pericarditis in this patient. Okay. Anybody can take a guess on this physician?
First angioplasty.
Again, because of the description what this physician gave, we all are making millions of rupees and millions of dollars. Just give a small
Frostman.
hint. Is a physician
Frostman.
from Chicago.
Hello.
Anybody has seen this picture?
Frostman.
Who described the anterior wall infarction with an occlusion of the LAD at the postmortem specimen and said the only hope lay for this man to have a recanalization of the LAD? Anybody? Dr. James Herrick, physician from Chicago, who attended on an autopsy of a patient who died of anterior wall infarction. The autopsy showed a clot in the LAD, and he made a comment, and when he wrote this description in the American Heart Journal, that the only hope lay for this gentleman was to have his LAD opened up. So I think that probably was the earliest prophecy made for the patient's treatment of acute infarction, either with thrombolytic treatment or with angioplasty. Okay, anybody can take a guess on this X-ray? Can you describe, anybody can describe the X-ray? Can read as an X-ray? Come on, it's very simple to read X-ray. When you see a photograph, how do you describe? Looks like a beautiful woman, has got good hair.
With decreased pulmonary blood flow.
Please stand up and say.
The central like heart, mesocardia.
No, who's there? Who's speaking? Okay, again at the end. Why don't you come in front? Huh? Yeah, tell me.
So it's looking like a mesocardic heart, and the blood flow is very much decreased, oligemic lung. And coming to the situs lung, means liver is on the right side. Yeah, means atrial status I can't make it out. Means it's a which side that means bronchus. But
So in other words, it's an AP chest, right?
Yes.
It's an anterior posterior X-ray of the chest with the stomach bubble on the left side, liver shadow on the right side. Heart is well centralized. This is how you should read an X-ray. And of course, you can't see the trachea well, so you don't know whether the trachea is shifted or not. But obviously, it looks like it's a well centralized place. Then you go to the lung markings. What do you find the lung markings? Decrease. They look like oligemic lung markings. Now, what do you see in the cardiac shadow? How is the apex like?
it's in center like mesocardia.
What does the apex look like? The apex seems to be slightly lifted up, correct? And the lung fields are oligemic. So what is your spot diagnosis on this X-ray?
Top.
Could be a tetralogy. Any differential diagnosis on tetralogy of fellow differential diagnosis?
ASDPS.
Oligemic lung fields,
ASDPS.
double outlet right ventricle,
Yes.
transposition of great vessels with severe pulmonary stenosis, but there usually the heart size is slightly larger, right? So this looks like a tetralogy physiology, and maybe it could be a tetralogy of fellow. I think that's what you should describe your X-ray. Okay, now I'll go to this. This is actually this my very favorite angiogram, which I used to do. They showed in the past, and I've done this when the child was very small baby, about a month old. And this was a catheter. Can somebody read this? This is an angiogram. Let me see. Yeah. At the end. Yeah.
It's an RV angiogram. We could see the catheter placed in the IVC to RA to RV, and the injection has been done in RV.
No. Tell me. This is a catheter you're saying is put from the IVC. I'm pressing it up to RA and then
to RV.
To RV. Yes, okay.
And then the injections show there is
Injection is done with a contrast.
Yeah.
And then what is happening?
The RV is filled, and we could also see the dye getting infiltrated into the probably the coronary artery.
Correct, very good, yeah.
So it could be a Alcapa, that is anomalous left coronary artery from pulmonary artery.
No. Do you see the pulmonary arteries coming up anywhere? And you see the right atrium being, sorry, I'm sorry.
So it could be the RV dependent coronary circulation.
Do you see the pulmonary valve anywhere?
Pulmonary atresia with RV
Yes,
dependent coronary
yeah,
circulation.
correct. So you don't see pulmonary valve, so it is a very classical picture of a pulmonary atresia with what?
RV dependent coronary circulation.
It's a pulmonary atresia with intact ventricular septum, because if there was to be a ventricular septum, you would have seen a part of the left ventricle getting opacified. And these are very typical what you describe. These are right ventricular coronary sinusoids. So these are actually circulations which are going into the coronary arteries from the right ventricle, and they go like a serpent here. And there is a severe tricuspid regurgitation because there is no dye or there is no blood flow going into the pulmonary circulation. Okay, now can somebody describe this? What is this supposed to be? Anybody has seen this in the lab?
It's a balloon atrial septostomy procedure.
Balloon?
Atrial septostomy.
Yeah, it is a balloon atrial septostomy catheter. Who described it?
Rashkin.
Bill Rashkin. Bill Rashkin was the one who did the first. As a matter of fact, as far as I'm concerned, he was the first interventional cardiologist, because he was one fellow who did the septostomy of the atrial septum as early as in 1960s in a baby who was dying of cyanosis. And what are the indications of performing balloon atrial septostomy? Indications?
TGA with restrictive ASD.
So it could be TJ intact ventricular septum.
Transposition of great vessels is the classical indication to be done. Okay. Any other indication you know of?
HLHS with a restrictive.
What is it? What is it?
Hypoplastic left heart syndrome, probably with a restrictive PFO.
Correct.
APVC with a
Particularly, you saw the patient. We showed you the patient with a tricuspid, either tricuspid atresia or pulmonary atresia with a restricted ASD. If you want to maintain some circulation, decompensate the right side, you can do a balloon atrial septostomy to tide over till the interventional pediatric cardiologist comes and does the put in a wire, opens up the balloon, with the balloon opens up the pulmonary valve. Okay, now anybody wants to comment upon this X-ray at the top? There is an angiogram also below, but look at the X-ray at the top. Just give a spot diagnosis, very straightforward. Do we have time, Shiv? Huh? 10 minutes more. Just look at the X-ray at the top. We have shown the arrow also.
Top with absent pulmonary wall.
What is it?
Top with absent pulmonary wall.
Top with absent pulmonary wall. X-ray, X-ray.
It is right aortic arch.
What does the X-ray look like?
Figure of 8.
What does it look like? Snowman.
Snowman. Figure of 8.
What is a snowman appearance classical for?
Supracardiac tape.
Yeah, correct. Total anomalous pulmonary venous return of the what type?
Supracardiac.
Yeah, okay. So that's the classical example. As a matter of fact, you can see at the bottom, there's an angiogram also, which shows the complete opacification of the chambers which are opacified after the injection done, and which shows that these shadows correspond to the anomalous veins draining into the right atrium. Okay. Now let's see the next picture. This picture is taken from simultaneously from the right ventricle and the left ventricle. And what do you find? What's your diagnosis when you see this kind of tracing? Ventricular tracings, right ventricle and left ventricle tracings. This is a spot diagnosis. When you see this, what does it look? Both of them are more or less in the height same. Number one. Number two, the top of the tracings looks flat, same. Right ventricular tracing and the left ventricular tracings look same. So this looks like what? When you see this like this, huh? Huh? Constrictive pericarditis. This is a classical when you see of tritology of fallow, because the ventricles pressures in both the ventricles are absolutely identical. One could say, okay, the right ventricular pressures in the right could be same as the left ventricle in, say, for example, in pulmonic stenosis. But the pattern of the right ventricular tracing will be like straight and then down. Here you can see the top is absolutely same. So when you see something like this, as a matter of fact, both the chambers are acting as in the similar fashion, generating the similar type of pressure. So therefore you find equal pressure with the equal pattern, similar pattern in tetralogy of fallow. Okay. Now, anybody giving me a diagnosis? I think this possibly now we already discussed. What is this? Is it a supraventricular tachycardia aberrancy? Is it a ventricular tachycardia? What is it? Somebody gave up just now an explanation. Is it VTAC or is it SVT with aberrancy? Huh? Again VTAC, because now here you can see it's very classical. You can see here fusion beats. Once you see fusion beats and a sinus captures like this, it is nothing but ventricular tachycardia. It can't be anything else except ventricular tachycardia. I think we already discussed this. And okay, I'll ask you the last question. This pertains to our own country. And of course, unstable angina has been described all over the world by different speakers and different workers. But in the world, the first description of acute coronary syndrome, unstable angina, pre-infarction angina, whatever you want to call, came from India and is recorded. I want to ask you, who amongst was the earliest to describe the syndrome of unstable angina? Was it Dr. Sujoy Roy from Delhi, KG Nair from Mumbai, Rustam Jal Vakil from Mumbai, or Dr. George Cherian from Vellore? Anybody give a guess? Correct. Rustam Jal Vakil from Mumbai described this. And as a matter of fact, his paper is there in the circulation in 1961, where he showed that he described his patients As a matter of fact, all his patients from his own clinic. They were not from any other institution. And he described their pattern over last or few months earlier, how they behaved. And he published this paper. And today, even today, I think his description is valid. And I think we'll go to the last picture. And can anybody describe this ECG? 75 years male palpitations. Atrial fibrillation, atrial flutter. What is it?
MAT,
SVT?
multifocal atrial tachycardia.
Multifocal atrial tachycardia. Very right. Actually, you can see here in this patient, there are various places where you see P waves, and the configuration of the P waves keeps on changing. And this is very typical of the multifocal atrial tachycardia. Usually occurs in the patients who have got a COPD. And the treatment is very simple. You have to give them, control their rate either with verapamil or digoxin and treat their COPD. I think we can end here, Shiv. Huh? We can end here.
Thank you, sir. So with that, we come to the end of the first day session. And before you disperse, and I'm very happy the response by the students is quite encouraging. And we have one long case and two short cases. Before that, there will be two lectures, because I again don't want you people to miss Dr. Ramakrishna from All India Institute, who will be talking on cyanotic heart disease, and Sandeep Bansal on his topic. I forgot his topic. Okay. So yeah. Then basically after that, we'll have a long case and two short cases. Total 19 people have volunteered themselves. So what I would suggest is we'll take about, we can't, allow all the 7 to be there and then, do a combined diagnosis, because then the whole purpose will get defeated, because there, unfortunately, you will be alone when you go for an exam. Okay. So we'll make it into the groups, but we'll allow only 2 people to go and examine the whole thing and make their diagnosis. But when they're presenting it, we'll keep these 3 groups, okay, so that they can keep answering it whenever the examiner asks. Suppose if the first 2 people are not able to answer it, the other, say, 6 people or 5 people, whoever it is, they can answer it. So eventually we will have only 2 people who can examine the case, because 10 people examining and discussing and other things will not be an exam pattern. Is that okay, sir? Okay. So in a short while, we'll tell you that who are the people who can go and examine those. So tomorrow morning, the presentation long case to show is at 10 o'clock. So we'll allot you by 9 o'clock so that you get a 1 hour time to examine it. And by 10 o'clock, and similarly, short cases will be given 45 minutes before, and so that by 11 o'clock they can do the short case presentation. Okay.
Yeah. Yeah. Couple of announcements. Today's dinner is from 8 o'clock to 11 o'clock at the pre-function area of this hall. Tomorrow, all trainees who are at Radisson, please have your breakfast at Radisson, check out and come over with your luggage. All at Trident, please check out and come in for the session. We start at 9:30, not at 10. So please be inside the hall by 9:20. The breakfast timing for tomorrow is 7:30 a.m. to 9:15. I repeat, 7:30 to 9:15. Thank you so much. Good night. Yeah. Yes. Yeah. All who are checking out in the morning, please please keep your luggage at with the bellboy. They'll help you with the luggage. Please check out before you come for the session. Thank you so much. Good night.
हेलो वालेकुम सलाम खैरियत दोबारा अच्छी है